All right. So good morning, everyone. It's me again, Dr. Jenny Yusuf, physical therapist and doctor of physical therapy, creator and founder of Balance and Fall Support Group in Aging Adults, and president of Fusion PT and Wellness. I'm the current treasurer of the Future Foundation Global and also the current state advocate of USA Delaware for the APTA Geriatrics. And I'm the previous vice chair of global health in aging adults special interest group with the APTA. So welcome, and I am so glad you're able to make it today. And we're going to discuss today more on the Geriatric Rehab Summit 2024 fifth annual event. If you're aware of that, this is our fifth annual event. Every year we do this, and this is our day 2. Some of you are here yesterday, and this will be recorded for your future reference as well. At the end of the 2 days summit, you will have an access for the a link for the exam so that you can get some CEUs from 30 plus participating states. All right. So thank you. All right. So let me see. If you have any questions, we have a QA chat box. And we have a webinar chat for us to check on. All right. Let me see. All right. So I introduced myself. I'm a doctor of physical therapist and a certified lymphedema as well, and a board certified specialist in geriatric. All right. And for our first speaker, we will have lots of speakers today, more, I think around 8 or 9 for the whole day from 8 o'clock in the morning, Eastern time until 4 o'clock. So for our first speaker, opening speaker today for day 2, we have Dr. Brunda Capadilla, and she is a Master Science Physical Therapist. We usually say dual certified, but she is triple. Congratulations, Dr. Brunda. She is a doctor of physical therapist and a certified clinical specialist in geriatrics, orthopedics, and of course, neuro. And I think she just had certification. She just passed the neuro certification this year, and congratulations, you're amazing, Dr. Brunda. So if you haven't heard her yet, and she will she's a great lecturer and also speaker, and she's part of the NPTE Final Frontier. But before that, we're going to know more about her topic. Her topic today is enhancing geriatric care, preparing physical therapists for the geriatric specialist exam. All right. So I think I introduced her a lot already on that first, but she is a board certified orthopedic clinical specialist, as I've said, and she's currently in an outpatient setting with a focus on geriatrics, vestibular, and orthopedic caseload. Dr. Brunda also is doing the NPTE Final Frontier. As I've said, it's a preparation course for NPTE if she's not in the clinic. And she's also an APTA North Carolina delegate for the House of Delegates. She's very passionate about global education and physical therapy profession and serves as the Chief Operation Officer for the Foreign Academic Credentialing Tools and Services, which is a 501c. It's a nonprofit organization that helps internationally educated PTs become licensed in the US. So definitely, if you have any questions, the typical steps, the different rules on how, like a roadmap, how to get here as a physical therapist. So you can connect with Dr. Runda. With his colleagues, Dr. David Friedberg is also here with us. Thank you, Dr. Brunda. I'm giving the floor to you. I'm so excited to learn from you.
Hi.
Let me see. Where are you? And then I'll go into, you are already the co-host, Dr. Brunda, okay? You can
Yes.
share a screen. Oh, you're there. Oh, you're so pretty. We have an
Thank
opening celebrity.
Thank you. Thank you for the amazing introduction. And before I even get started, Jenny, thank you so much for hosting this. I think this is such a great opportunity for all the clinicians to come together and just talk and present on important topics. So thank you so much for having all of us here.
You're
And
welcome.
thank you. All right, I'm going to go ahead and share my screen. Can everybody see my screen? Perfect. Well, welcome everyone. Such a pleasure to meet all of you. I hope everybody's doing well, and I appreciate all of you attending this on a weekend. I think this definitely shows your commitment to being better physical therapists, better clinicians, and of course, interacting with one another. Um, Dr. Jenny did a fantastic job of introducing me. So I think it's probably okay to skip most of the things mentioned over here. But just a little about myself. She's right. I am a triple board certified clinician. And one of the reasons for that is because I love studying. So I am ortho, geriatric, and neurologic physical therapist, certified clinical therapist. And one of the things that I'm going to talk about today is going to be some of the strategies that helped me get my triple certification. So I'm hoping that some of these strategies and resources are helpful to you as well. Our focus for today, especially because this is a geriatric summit, our focus for today is going to be on geriatrics because it is such an important patient population to work with, right? So some of the objectives for today's session are going to be we're going to talk about what exactly is a clinical specialty certification, just in case somebody over here is not aware of it. So we'll talk about that. We'll talk about the importance of geriatrics and if the geriatric certification is a good option for you to meet your career goals and for you to meet your long term goals as a physical therapist. We're also going to find out that if this is something that you want to pursue, how can you become eligible to take the geriatric certification exam and what are some of the deadlines, and then if you do choose to pursue this as a clinical specialty, what is it that you need to study for the exam, what are the topics, what is this exam going to help you improve, how is this exam going to help you. So we're going to be talking a lot about geriatric specialty. So let's get started. The first thing we're going to talk about is going to be who are board certified clinicians. So, if you haven't heard of board certification, American Board of Physical Therapy Specialties is basically the organization that kind of conducts all of these exams. So, these exams are basically conducted to ensure that physical therapists who are certified, they basically are demonstrating some form of competency and specialized knowledge. It basically indicates that you have some advanced clinical proficiency when it comes to this specific area of practice. So when you say that you are an orthopedic clinical specialist, just like how you say that this person is an orthopedic surgeon or this person is a neurosurgeon, right? So when you say that somebody is a neurosurgeon in the medical world, that kind of instills confidence or respect, or that this person is the expert in that field. And similarly in the world of physical therapy as well, when it comes to physical therapists, yes, all of us are physical therapists, all of us are a general physical therapist, which itself is a great thing. I don't think that's a bad thing at all. But if you feel like you would like to specialize in one area of practice, or you enjoy treating a particular patient population more, and if you feel like you're the expert in the profession or you want to become the expert in that profession, in that case, the American Board of Physical Therapy Specialties has created this path to pursue a specialized certification exam. When you think about what are the different areas of practice in physical therapy in which you can specialize, so here are the 10 options which you can pursue. So you have your cardiopulmonary, cardiovascular and pulmonary physical therapy. There is a clinical electrophysiology specialty where you learn more about EMG and CV testing. You have your geriatric specialty, which is one of my favorites. You also have your neuro specialty. You can specialize in oncology, which is another which is another profession, which another specialty which is coming up, especially just looking at the number of patients who are unfortunately diagnosed with cancer and related diagnoses, right? So oncology is another specialty that's gaining a lot of traction. Orthopedics is one of the most common ones. You'll see highest number of clinicians get certified in orthopedics. You do have pediatrics, sports, women's health, and then, of course, wound management as well. So, as you can see, there are various options for you if you want to become a specialist in any of these areas of practice as a physical therapist. Why geriatrics specifically, right? A lot of times people ask me, why did I pursue geriatrics? One of the reason is I feel like this is my favorite patient population to work with. But even thinking about your career growth, right? Just looking at the patient population that you're going to be seeing in the future, if you look at the number of Americans, right, that are aged 65 and older, it by 2050, it's predicted that about 82, we're going to have 82 million people in the US alone who are going to be over the age of 65. And even if you look at the total population, it's going to be about 23% of the total population. And currently, if you look at studies, the US population is older today than it has ever been. So, as you can see, you're never not going to have a job if you're a geriatric specialist, because there's just so many people who are aging every single day. All of us are aging every single day. So, there's just so much scope in this particular area of practice. And this is in the US. If you are somebody who's working outside of the US, so say for example you're working in the Philippines, or if you're working in working in a South American country, right? So if you're looking at the world population, so back in the 1950s, only 8% of the world population was over the age of 65, versus in 2000s it was about 10%. And this is another statistics to support that by 2050 about 21% of the patient population is going to be over the age of 60 or 65. So as you can see, 1 in every 5 adult is an older person. So definitely a lot of scope over here. And then what are the implications of that, right? I love this image because as you can see, as people as get older, right, the burden, I don't want to use the word burden, right, but the responsibility also falls on the younger generation, especially the medical profession, because we are the ones who are essentially taking care of these people. So any profession, any specialty that is catering to the older adult population is always going to have some of the other role or responsibility, and they're always going to have a job. So I think this image does a really good job of showing you that how we are responsible for taking care of them. Okay, so let's talk a little bit more about geriatric clinical specialty. The first geriatric specialty examination was actually offered in February of 1992. So it's been about 32 years since this certification, if my math is correct. It's been about 32 years, yes, since this certification exam was launched. It happens once every year, and we'll talk about the dates and registration in a minute. But it happens once every year, and as of date, we have as of June of 2023, we have 4,000, approximately a little over 4,000 geriatric specialists. So you can see that there's not a whole lot of specialists. And that is why if you choose to specialize in this area, you're one of the few, people who are considered to be specialists in this specific area. There's not a lot of competition. So you can easily, market yourself as a geriatric specialist. um, when you talk about this exam, right, or when you say that you are a geriatric clinical specialist, right, it's essentially saying that you have the expertise and the clinical experience in the specialty area of geriatrics. It's basically focused. The exam is basically focused on conditions that are relevant to individuals over the age of 60 or 65, and of course, this certification demonstrates your proficiency in assessing, treating, and evaluating senior citizens. And if you're looking at the statistics with respect to which is this a good certification for you or not, or like who are the people who actually take the geriatric certification exam. So this is an image that I got from the description of specialty practice for the GCS exam takers. So basically, if you look at the practice setting, right, literally whichever practice setting that you're working in, you can this certification exam can be relevant to you, right? Being a geriatric certified specialist will be relevant. In general, a lot of people who work in a home health setting are more likely to take this exam. So if you are somebody who works in the home health setting, this is definitely a good option for you, because in general, home health is for patients who cannot get out of the house, and they usually tend to be the older adult population. So again, people who work in home health, or even if you're working in an outpatient setting. So you can see home health and outpatient setting is like very high number of patients. And then of course, your skilled nursing facility, acute care hospital, academic institutions. If you're not a clinician, if you're an academician, you can still benefit from being geriatric certified. So as you can see, and irrespective of whichever country you're in, irrespective of whichever healthcare setting you work in, you can benefit from learning more about geriatric care. If you look at the people who take this exam, again, people who've taken this exam in the past have at least 20 to 30 years of experience. If you look at the current trends, I would definitely say that the current trends are changing. We currently have people who are within their first 5 years of clinical practice who are pursuing this certification just because of the benefits that it offers. And then in general, people who've if you look at the statistics with respect to the years of practicing, years of number of years that somebody has practiced as a geriatric physical therapist, majority of the people have practiced after getting the certificate. People have practiced for at least another 15 years as the experts in this area of practice. So if you're thinking, should is this something that's going to be a right path for you, especially in the US, taking the certification exam is directly connected with potentially increase in salary depending on where you're working. Of course, there are increased job opportunities. It's essentially, even if you're a private practice, even if you have a private practice, you can always promote that you offer the highest level of care and you're keeping up with the latest evidence-based practice and research. It, of course, you get to earn CEUs with it, and you get to enter the prestigious pool of board certified clinicians, right? As you can see, Jenny over here is also a geriatric clinical specialist, which is awesome. And I'm sure she will agree with it that, it feels good to say, like when you're working with your patients, just to say that, you're committed to committed to them feeling better. And you are the one who's working hard and studying and keeping up with the latest research to make sure you offer the best care to your patient. So looking at who can become eligible to take the GCS exam, there are two paths. One of them is, of course, if you go through the APTA's clinical residency program, you can just do 1 year of residency training and then you can go ahead and take this exam. But if you're somebody who's not pursued the residency path or you don't want to pursue the residency path, that's totally fine too. If you have 2,000 hours of direct patient care, that means it actually equates to 1 year of work experience, right? 1 year of full time work experience as a PT. Even if you have that experience, you can actually go ahead and register for this exam. Of course, this work experience has to be with older adults. You cannot be working with pediatric population for a year and then apply for a geriatric exam. So that's not how they allow it. You have to have 1 year of full-time work experience or about 2,000 hours of work experience with older patients. And then now that you have the clinical experience, you can go ahead and apply for the clinical specialty exam where you will learn more about the geriatric population. How do you apply for it? If you want to, you can go to the ABPTS portal. Here's the website on the slides, and we will be sharing the slides later on as well. So you can just go to the ABPTS portal, and then you can go ahead and apply for the exam. It's a slightly long form that you have to fill, but once you fill it, it gets approved, and then you can go from there. Talking about the specialty exam, once you pass the exam, the certification is valid for 10 years. Of course, every 3 years, you have to do some activity to prove that you are still committed to the geriatric population and you're still, seeing the geriatric population. But once you take the exam, it is valid for a good 10 years. And for those reasons, the costs of the certification exam is a little bit on the higher end, but a lot of workplaces do reimburse people for taking this exam just because it offers CEUs as well. And usually this exam happens in February or March of every year. So if you look at the next year, it's going to happen. It's a window during which you can take the exam. So it's about 28th March to 28th February to 20th of March. So you have about 3 weeks, and you can register to take the exam during any of the days on any of the days during that time. So yeah, so there's this whole process where you have to apply. Once they find that okay, you have the relevant work experience, they go ahead and approve you to take the exam, and then you can just register for the exam. So it's a pretty straightforward process. And as long as you fill the form properly, you should be all set. Looking at this specific exam, so this exam essentially has 200 questions, and you have about 7 hours to answer 200 questions. And I know it sounds like a whole lot, but trust me, I have done 3 board certifications, and time flies for sure. So you essentially have 4 blocks. Each block will have about 50 questions. Okay, and you have about an hour and a half for every you have about an hour and a half for every section, and that brings it to about 6 hours, right? So 1.5 into 4, so that brings it to about 6 hours, and you get 1 hour of break in between, and that is what brings it to 7 hours. So you have about, yeah, 10 minutes of total, 50 minutes of break, and then you have 10 minutes of training video, so that's about 1 hour extra. But that's why I said you do get a lot of, you have the opportunity of taking breaks in between the exam, so 7 hours just, they just fly. Okay, so let's talk about what is it that you're going to learn if you choose to pursue this clinical specialty. Again, the exam is focused on knowledge area and of course certain practice expectations. So they're looking at your skills, or when you're studying for it, you are essentially learning things about how to do an examination, differential diagnosis and prognosis, evidence-based interventions for your patients, and what are some of the good outcome measures for the patient population that you're treating. So most of the exam is essentially focused on these things, right? It is called a clinical specialty exam because they're training you to be better clinicians, and that is why most of the questions are going to be very clinical based. Like, what would you do if this happens to a patient, or how would you handle this particular case, so on and so forth. So about 70% of the exam is based on everything related to being a clinician. Additional 15% is actually based on professional roles and responsibilities. So these are some of your ethics related questions. How do you follow rules and regulations? What would you do if somebody else breaks the rules? What would you do if a geriatric patient has a fall? How would you follow the clinic procedures and policies? So about 15% of the questions are based on those specific topics, and another 15% questions are based on your foundational skills and knowledge. So when I talk about foundational and clinical knowledge, what I'm talking about is, as you know, that the bone density tends to decrease as we tend to get older, right? We are at a higher risk of getting osteoporosis. So that's your foundational knowledge, right? Your osteoclast tends to go up, the osteoblasts in the body, in the bone, tend to go down. So that's your foundational knowledge, and that is what 15% of this exam is based on. This that what is your background knowledge about the geriatric patients. So as you can see, it's a very comprehensive. It covers the whole patient population in a very comprehensive way, where they talk about everything, your basic knowledge to your professionalism to your clinical knowledge. And because it covers so many different content areas, that is why, irrespective of whichever setting you're working in, it's very, very relevant to you when you're working with those patients. This is just a very exhaustive, this is a long list of topics that it covers. It is not a complete list. These are just some of the topics that the exam talks about. So as you can see, like, as you study for it, right, you are learning so much about all of these different topics. So let's come to big things, right? The most important things, which is how to be successful as a learner, as an adult. Like we discussed, a lot of people who take this exam are at least 10 years into their career. But if you look at the current trend, anybody who has at least 1 year of work experience can take this exam. I took it within 3 years of getting. I took it within 3 years of getting my license. So I worked for 3 years, and then I took my GCS. So yeah, a lot of early career professionals are realizing the importance of this exam, and they are taking the exam. And irrespective of whether you decide to take this exam 10 years 10 years from graduation, or if you're taking this exam within, say, 1 or 2 years of graduating, there are certain tips that you can follow. And let's remember, all of us are adult learners, right? Nobody is a kid who has to go to school, who has to be spoon fed, right? So if you just look at latest literature, it says that as an adult learner, right, all of us have developed this preferred learning style. And as long as you stick to that specific learning style, you're going to do a better job of retaining that information. And again, just looking at this is from one of the articles on the types of adult learners. And one of the things they found was, as an adult learner, when we are studying something, whether it's a geriatric exam or orthopedics or just even for your board exams or anything else that you're pursuing, as an adult, we tend to be very self-directed and we have a very independent learning behavior style, which is a great thing. But what they've actually found is, as we age, we actually become we don't tend to be as good at self-assessment as we think we are. When we are kids, right, we usually are given tests, right? So people, our professor or our teachers will give us a test, and that's the way of assessment, right? Kids don't really do self-assessment. But for adult learners, because we are independent learners, nobody's coming to you and teaching you every single day. The onus of self-assessment falls on you. So as you are prepping, as an adult learner, as you are prepping to take any of your specialty exam, make sure you're focusing on self-assessment. And what does self-assessment look like? It looks, you got to focus on taking practice exams, practice quizzes. Those are the things that are going to be very, very important, because that's going to be, you have to find your own practice exams or make a quiz for yourself, quiz yourself, because self-assessment is easy. Just a lot of times we study something, we think that we've understood it, and that is our version of self-assessment, that yeah, I think I got this down. So make sure that doesn't happen. Focus a little bit more on self-assessment when you're studying for these exams. Keep a track on what is it that you know and what is it that you don't know. And again, let's talking about the two most effective methods to study. And this definitely sounds like, yeah, this makes sense, I know this already. But trust me, when you study for these exams happen once a year. The content for this exam is a lot. So the sooner you start studying for the exam, easier it's going to be. But at the same time, the sooner you start studying for the exam, what happens is we get bored, right? None of us loves to study for 6 to 9 months, right? So we tend to get bored, and then we start studying initially. Once you register for the exam, one thing that I've seen when I work with students is they register for the exam, they feel very pumped up, they're studying very, consistently, and then December sets in, it's the holiday season, and we just stop studying, right? So that's one thing that I've seen in a very high number of students. So remember that it right now, when you hear about it, it might sound like, yes, I know that I should study on a consistent basis and I shouldn't cram. But when it actually comes to following it, a lot of us don't do that. So I just want to iterate the importance of spaced practice and retrieval practice, which is actually more important than spaced practice. So talking about spaced practice a little bit, learning at different times over the course of multiple sessions is important. This essentially talks about when to study. And when you talk about when to study, it's talking about studying at different times during the day, depending on whatever works best for you, and starting early on, so that even if you decide to take a break for, say, Thanksgiving or for Christmas, you're still fine, because whatever you were supposed to study during that time, you've already made up for it. So before, one of my big recommendations is going to be, before you even start studying for this exam or any exam that you're taking, create a schedule. See how many months you have. Then take out all the dates and weeks that you're going to be out, traveling, Christmas, family, and then whatever remains, now start to create your study schedule. So only include the days where you're actually going to be studying. So create a schedule, yes. So wherever you see study tips, they always say create a schedule. I always say create a reasonable or create a realistic schedule, because if you create an unrealistic schedule, that's not going to work. And the next one is retrieval practice. One of the big things is retaining the information that you're studying, just because the information is so vast. And for that, if you look at research articles about how to convert your short term memory into your long term memory, it highly, highly, highly focuses on active recall. So, say, for example, you've studied a topic. There are two most important things that you need to do. One is you need to do a recall. That means you need to revise whatever it is that you've studied. But when I say revise what you've studied, it does not mean go back to your notes and read it again. It means kind of do like a brain dump. So make sure you try to focus on active recall on a, I would say, every single day. Like every single day, you should do an active recall. And the way we recommend it is, say, for example, you have studied a topic X, right? Today you studied a topic X. When you're doing an active recall, do not do an active, say you read the whole chapter, don't close the book and do an active recall, because that information is still within your short term memory. We usually recommend that whenever you've studied something and you're doing an active recall, do it the next day or 2 days later. Don't do it a month later because now too much time has passed, right? But within 2 days, try to do an active recall. Don't try to do an active recall on the same day because that is what is going to help you with retaining the concepts. Again, if you look at articles, they call it successive relearning because what they recommend you should do is you should ideally do an active recall over multiple days. So say today was the first time you did active recall and you retained 80% of the information. So whatever was the 20% you missed, you just review it again. And then the next day when you do an active recall, you're probably going to get 92% of it, right? Whatever you missed, you study it and then you do an active recall again. So keep doing active recall till you feel like you've understood most of the information or you're able to retain most of the information. Okay. So these are the two big things. Start early, create a realistic schedule, and it's okay to give yourself breaks. It's very, very important. It's one of your principles of motor learning as well, right? You got to take some breaks in between, but then also focus on active recall. So we just discussed this already, like creating a schedule and then spending time on new topics as well as older topics in the form of active recall is essential. And definitely don't cram. If you think you can start studying for the exam in Jan, when the exam window opens in Feb, it's not going to work. 1 month is not going to be enough. And what's going to happen is you're just going to sit and cram for the exam. And then even if you pass the exam, you really haven't learned anything, right? Because you just crammed everything in a month. So make sure you don't cram. It just goes without saying, right? Now, whenever you're studying for the exam and you're focusing on certain retrieval practices, making your own questions is a really good strategy. We live in a world full of internet and technology, so making sure that you are making your own practice questions, you are making your own application based questions, making index cards, flashcards, whatever works best for you. Make sure you're doing it, but the focus has to be on retrieval of that information, not just reading and studying that information, but recalling that information is very, very important. Specifically for the specialty exam, specifically because it is a very clinical based exam, one of the best ways to be successful as a clinician as well as a student for this specialty exam is applying what you've learned and make sure you apply it on your patients. So what I mean by that is, like I mentioned, the exam has certain foundational concepts, right? And then the exam also has some clinical concepts like outcome measures and things like that, right? So if you've studied that a certain outcome measure is good for a particular condition, right? So you've studied it. Go to your clinic and use that outcome measure on your patient, right? Because that way now you're actually applying. The whole purpose of taking this exam is to be a better clinician. So go to the clinic, use those outcome measures. That's going to be really, really helpful. So that's how you apply the clinical concepts. With respect to your foundational concepts, right? If you studied the topic of osteoporosis and you studied about osteoblasts and osteoclasts, like why do older adults develop osteoporosis in the first place. So in that case, you can, whatever you've learned, you can use that information and do an active recall by educating your patient about it. If you have 5 patients with osteoporosis, make sure you educate every single one of them. What is osteoporosis? Why does it happen in older adults, or why does it happen in females or postmenopausal females? And you can tell them, because that's you applying the concept, you revising the concept, which is going to help you for your exam, but it's also going to help you be a better clinician, and it's going to help the patient understand what's going on with them. And that is what this exam is all about, right? So for the foundational concepts, make sure you're educating your patient about what you're learning, and for all the clinical concepts, make sure you're applying those specific learnings on your patients to be better clinicians. And then the last one is going to be, as you prep for your exam, know all the resources that are available to you. I think APTA does a fantastic job. APTA has a lot of resources on their website. Of course, you have to be an APTA member to be able to access it. Jerry Notes is one of them. There are a lot of versions of the Jerry Notes, so you can look at that. I would highly recommend going over your clinical practice guidelines, especially the ones that are related to the older adults. So you have your osteoporosis clinical practice guideline, you have knee arthroscopy, you have the hip shoulder clinical practice guideline, you have your vestibular clinical practice guideline for BPPV as well as for hypofunction, as well as for concussion. So make sure you know your clinical practice guidelines in, like, it has to be pit pat. Like, this exam is very, very research based. In addition to that, knowing all of your research articles. Again, the goal is to become an evidence based clinician. So going over all the different articles is going to be helpful. PubMed, of course, is one of the free resources available to all of us as clinicians. With respect to which textbook you should be studying, I would highly recommend studying the Geriatric Physical Therapy textbook by Gusion. I think I learned a lot as a student when I was studying for the exam. But then also, I think it was a good refresher to go over this book when I was prepping for my the board exam as well, the geriatric exam as well. So that textbook is a good resource. But then, in addition to that, you want to make sure that you're keeping yourself abreast of all the latest literature. Where this is where all of your clinical practice guidelines come into play. So as long as you're doing your clinical practice guidelines as well as the textbooks, all the clinical practice guidelines and the some of the latest articles, you should be all set. And then in addition to that, we had a group of clinicians who studied together with GCS Final Frontier. So, and that's how we actually launched GCS Final Frontier as well, which is where we focus on combining all of this important information then we provide it to the students. So GCS Final Frontier is another resource to check out. And in full disclosure, I do run the program where we work with a lot of students who are prepping for their GCS specialty exams. If you have any questions about that, I'm happy to answer that as well. But yeah, that's dot on time. Here are all my references related to everything that I spoke about. If you have any questions, and Jenny, if you have the time, I'm happy to answer any questions that you may have right now. Or if you don't have any questions, or if you don't have any questions right now, or if you want to connect later on, here's my email ID. If you want to talk about the geriatric, orthopedic, neurospecialty exam, or if you want to talk about just how to prep for the exam, or just anything in general, I am always happy to answer any questions you may
Yeah,
have.
I think we have time for 5 minutes questions, guys. Yeah, this is a great opportunity to talk and chat with Dr. Brunda. She has also, I think Dr. Brunda kindly put on the chat your social media or how they can connect with you, especially for the foreign credentialing as well. I think majority will be that's their questions, and then later on the NPTE questions as well, because they are coming, majority will be questioning how to pass a board exam. But here in US, this is a great tool for us to learn more about the geriatrics. That's why she talked about the GCS, you know. So, and Dr. David Friedberg as well is on the panelist. If you want to get more information about that, they will going to put their emails and how to connect on the webinar chat, okay? Yeah. Dr. Brunda, on the chat, don't forget because this will be out later. And then
Oh,
any
got it.
question, guys? Yeah. So let me see. I can see the chat. Let me see. Yeah. Okay, okay. You put it already there. All right. I didn't see if I have a question so far. All right, good, good. So this is really great resources because I see the CPG, the reviews. As I remember, I just want to share when I was in Philippines, I didn't pass my first board exam. We have this state board exam, the physical therapy board exam. And then I really agree with all the tips, don't cram and things like that. I really, and I think, I'm not sure you put it there also, have a great sleep before, those things, that's really important. And then since I was a student, we always have a group study that we are always studying even 2 nights before. And then sometimes when I have a great exam, I cannot see anything but a bulb on my head. It's like a blank. I can't remember anything. So it's really good that you have a great sleep a night before of your exam, because that's how our neurons are relaxing and we will going to use those. So you really need to have an energy because that's their how they recuperate and then absorb all of the things that you work hard. And I think they have also give you some tips that pretty more on the numbers, the values, a little bit closer, more things that are deeper. Check your weaknesses. Do exam tips, right, Dr. Brenda? They need to practice exams too, so that they will know their weaknesses and focus on those weaknesses too, something like that. Yeah.
Yes, 100%. I think, and that's one of the big things that we focus on even at GCS Final Frontier is you have to solve as many practice questions and as many practice exams as you can because it's going to be really, really beneficial. I do have a question in chat. Somebody asked, is GCS only in the US or is there a are there providers in other country that is APTA related or APTA certified? As far as I am aware, it's mainly for clinicians who are in the US, but actually, fairly recently, through our nonprofit organization, which is FACS, we had received somebody who was actually licensed in another country, and they were working with the board to see if they could actually go ahead and take this exam as well. So I think it might be a good idea to connect with ABPTS and see if you can take it, if this is something that you are interested in. And another thing is, I hope it works out, and I hope this exam is available in other countries and as well. But even if it's not, I do think it's and say your focus is orthopedics or your focus is neuro or oncology, right? Even if you're not taking the clinical specialty exam, I think as a clinician, as long as you're committing to keeping yourself abreast of everything, all the latest literature, and that could mean like enrolling in an oncology exam prep program, and even if you're not taking the exam, but you're still going through the lectures and the reading materials and everything available, I think it's still going to help you be a better clinician. So, yeah.
That's true. That's why we always provide great webinars. We invite great speakers to share their tips and knowledge. And also try to always check. I remember the Academy of Physical Therapy Association has this special like low fee for the foreign educated and then internationally educated as well therapists that they can use something like that. I check it out, guys, because I remember I sponsored one from Indonesia at one point, and I think that's a minimal compared to us US base. That's really a good thing that you can access some of those the benefits of the APTA, and we have those free resources as well. All right, thank you, Dr. Brenda, and she's still here on the webinar chat if you want to ask some information. Thank you. All right, Dr. David said you can save on your registration. Yes, that's true. So usually I always give those tips to my colleagues when they're asking me about those things because once you are a member, they will give you definitely discounts with the combined section meetings, different courses, things like that. So I just want to share that really a review and practice review will help. There are many different exams, books as well to review. I didn't pass also my, Dr. Brunda, I want to say, do you know that I didn't also pass one first time my NPTE?
I
So
did not know that.
yeah, I everything like I'm always on the second. So when I did my GCS, I told to myself, I just want to see how the exam looks like, and then I will nail it the second time. And then when I said to I think I passed the GCS first time because I
Wow.
told to myself I'm always on the second time. My board exam twice, and then my NPTE twice. So I'm always like on the relaxed mode. And then it's been a while since I will say that, oh, I should nail it the first time, But I keep saying like on a positive note that after I failed on the spot, that's okay. But months ago, I will feel, oh my goodness, I need to review again. I'm on Adelaide.
True.
But the GCS, I have this certification like CAA, Certified Exercise Expert in Aging Adults. I have a seatmate. Oh, Jenny, the GCS is next weekend, the exam. What do you call that? The sign up, the registration.
Yeah,
Why don't you sit in? Because you're reviewing already. So I think once you are already in different courses, you're studying. Studying my doctorate of PT that time, and I did my certified exercise expert. I think the combination of review helps. So that's
100%. I think the
why
more you review, the better it
I
is.
think so. It overlaps the pharmacology and things like that. But if you're not doing that, a review itself will be very important because you really need to have resources and social, like what you said, the group, that's really very important. Yes, yes. So we really need just to keep trying and trying and have a passion to study. All right.
True.
Last
Thank you.
questions. Yeah, I think
Sorry,
we
go
have
ahead.
one last question for Dr. Brunda. Is it advisable and reliable to implement any AI apps or website nowadays for further explanation and better preparation to topic lectures that we study? So that's from Max.
Great question. So I would suggest, remember, AI can make mistakes. Chat GPT can make mistakes. It's still developing. So I would say, even if you're using Chat GPT to study, make sure you verify the information that you're studying. Go back to your textbook, go back to the original source of the article just to verify the information. One, this is especially irrespective of whether you're studying for your NPTE, which is the board, like the PT board exam, or whether you're studying for your GCS or any other specialty exam. Especially for the specialty exam, I would suggest rely more on your clinical practice guidelines versus if you are studying for the NPTE, rely more on textbooks, because that is what the makers of these exams use as a reference. So for the NPTE, go back to your PT textbooks, and for this, go back to your clinical practice guidelines and of course the geriatric textbook, because I think those are the most reliable resources for you. But I'm very confident that in the next couple of years, AI is going to be the go-to. Right now, AI is still learning, so AI can make mistakes. So you don't want to make the same mistakes as AI does. So rely on the primary sources. You can use AI as an adjunct, not as the main tool of learning. So I hope that helps answer your question. And thank you so much, Dr. Jenny, for having me. And thank you again for all of you for your questions and for listening. I hope our paths cross in the future. I hope I get to meet you in person, and all the best.
You are welcome, Dr. Brenda. Yeah, Dr. J has a comment here. I thought it's a question, but great lecture on the roadmap for the certification. Thanks, Dr. Brenda. Dr. J, I can see your question, but
Thank you.
definitely ask on the webinar chat, okay? Yes, so we love that. Thank you, guys. All right, so we have our next speaker. Let me see first. See my share. Right? We learned a lot every day. All right. So thank you, Dr. Brenda. We appreciate you. And let me see. We would like to give you our certificate of appreciation, Dr. Brenda Capadia, so for sharing your knowledge and expertise today as a great speaker for our Geriatric Rehab Summit 2024, our 5th annual event today, August 17. So thank you so much, and we appreciate you, and definitely we would love to support you and follow you with your social media as well. All right. Okay, guys, for our next speaker, we have Laura Gusay. All right. So if you're familiar with the LSVT Big, she is our Chief Clinical Officer, and she'll going to discuss about promoting positive partnership with Parkinson's caregivers. We always met as a physical therapist, never that you will meet some Parkinson's disease patients, cases, subject, topics, right? So this is a great opportunity to learn more the basics and how to deal with our caregivers, of course, and our clients. See? So Dr. Laura Gusay received her master's degree in physical therapy from the University of North Dakota. Um, Laura has over 15 years of experience working with adults with neurological disorders with a special focus on Parkinson's disease and multiple sclerosis. She has been LSVT Big certified since 2009. She now serves as an LSVT BIF training and I think this is LSVT Big because I'm an LSVT Big. LSVT Big training and certification faculty and as the Chief Clinical Officer of LSVT Big, overseeing training, curriculum, and product development related to the LSVT Big. She has spoken at many national and international conferences on topics related to LSVT Big and has trained thousands of clinicians globally. So guys, when you hear the LSVT Big is for us physical therapists, occupational therapists, and the LSVT Loud will be for our colleagues, the speech language pathologists. All right. Without further ado, welcome, Laura.
Oh, all right. Thanks, Dr. Jenny. Thanks for having me. It's
My
a pleasure to be here
pleasure.
with you this morning or this evening, depending on where you're joining us from.
Globally, right?
Globally, yes. I am going to go ahead and share my screen. If you just want to let me know if you can see it. All right, all good, Dr. Jenny? All right, I'm getting some
Yes.
thumbs up, so that is great. Let me just fix a couple more things on my end of the screen so I can see you, and then we will get rolling. Okay, well, thanks for that nice introduction. And just starting the morning with a little bit of alliteration of promoting positive partnerships with Parkinson's caregivers. As Dr. Jenny said, my passion has always been working with individuals with Parkinson's disease and other neurodegenerative disorders. And with that comes you're not only working with the person living with Parkinson's disease, but their care partners as well, whether it be family members or friends or, really whoever fills that role. And so that's really what I want to dive into today with our presentation. Just as a matter of disclosure, I am an employee of LSVT Global and have a treatment preference for LSVT Big. There is one video that I'll show in this presentation, and the objectives are these. By the end of the presentation, I hope that you'll be able to list at least a few things that you can do in your practice to promote a positive partnership with care partners of people living with Parkinson's disease. And then we're going to talk a little bit about the complexities of Parkinson's disease that can make caregiving especially challenging. Lastly, I'm hoping that you'll be able to recall at least a few ways that care partners can actively participate in the plan of care. And so for a moment, I want you to take off your therapist hat and just imagine that you are a person living with Parkinson's or a care partner yourself. And so to start, I'm going to tell you a fictional story, but really the story is based on the conglomeration of experiences with many, many people living with Parkinson's and their care partners. And so we'll name them Don and Jean. This is a stock photo, so not real people here. But just imagine that Don and Jean have been together for decades, okay? They've raised a family together. They have a few grandkids now. Don recently retired, and Jean plans to retire in less than 5 years. In their retirement, they're looking forward to hoping that they're going to travel, they're going to spend more time with their families, they're going to do some volunteering, spend more time on their hobbies. But 2 weeks ago, they got hit with a hammer that Don was diagnosed with Parkinson's disease, something they knew nothing about, something they never expected, and suddenly they have a million questions going through their heads almost every minute of the day. Like, is there going to be a cure? Could there be a cure in my lifetime? Is there any way I can stop it from progressing or slow it down from progressing? Why did I get this? Why me? Could it be a mistake? Maybe the doctor was wrong about it. Should I tell people or should I not tell people for a while? If I tell people, will they treat me differently? Should I retire early? Maybe Jean is thinking about that. Maybe she's thinking about, should we move into a house that's more accessible or should we wait? How do we know how fast this will progress? What if I can't take care of him? Who will do all the things that he does if he can no longer do them? How will it affect our relationship? Can I manage everything? So there's so many questions that people with Parkinson's and their care partners are hit with when they're diagnosed, and it's not easy at all. And so they both have a goal of they want to live the best life, right? For the future. They want to be able to still enjoy all these things. They don't want Parkinson's to prevent that from happening. And so all these things are swimming through their heads. 1 month later, they show up in your treatment room for an evaluation for the Parkinson's disease. And as a therapist, we need to not only think about what we see with the motor and non-motor symptoms, but what we don't see as well. All of those questions and thoughts and fears and anxieties that are probably swimming under the surface that they may or may not be voicing during your therapy evaluation. So, under the surface, care partners may be really tired or burnt out, especially if they have been in that role for a long period of time. They're probably going through a grieving process, initially upon diagnosis about, what does that mean for the future, grieving the loss of the present as well. They may be feeling lonely, like they don't know anyone else dealing with the situation, worried, anxious, angry even that this is happening to them, depressed, frustrated, a whole gamut of emotions that may change from day to day. They might not know anything about Parkinson's disease, especially those non-motor symptoms that we're going to be talking about a little bit. They may not be a person who's naturally a nurturer, right? Some people are wired like that, and some people are not. And let's be honest, if you have been a therapist for any length of time, you understand that not everyone has a great relationship. They may be coming into this already with relational difficulties. A lot of the problems or issues, struggles that people with Parkinson's are dealing with are similar to those that care partners are experiencing. They may also be very tired and burnt out of one more appointment. It's a complex disease. And so, in addition to therapy, they may be seeing multiple providers for different issues. They may worry about being a burden to other people. They also are going through a grieving process that is not just a one time thing, but maybe ongoing. They may be impacted by these non motor symptoms of Parkinson's disease, like apathy, depression, anxiety, other things like that. Perhaps they're not a good communicator of how they're feeling and it's just brewing inside of them. They might be misperceived if they have a masked facial expression where maybe they're really quite happy inside, but it's coming across as angry or depressed or something other than how they're actually feeling. And again, they too may be dealing with long-standing relationship issues that are now made worse when you add on that stress of a devastating chronic degenerative diagnosis. So I say all this not to be depressing to you, but just to have a little empathy for them that it is not easy. Some relationships deal with it better than others, but for everyone, it's not easy. So there are a lot of things that you can provide. And because I love alliteration, I named all of these starting with the letter E, right? The first thing is empathy. We have to be empathetic to both our care partners and the person living with Parkinson's disease. Our goal is to empower both of them. Our goal is also to provide education about Parkinson's disease that they might be missing. They might not have received from the neurologist or the nurse or Google or wherever. They need education about the treatment, why you're doing what you're doing, not only in the moment, but long term. And they need encouragement of how to develop that long term plan when it's feeling rather overwhelming to them. And lastly, they may need your help to learn how to enlist other people and feel okay about that. So let's start with empathy. We talk about the difference between empathy and sympathy, and empathy is really seeking to understand another one's point of view, but it goes beyond that. It actually requires active or reflective listening. And so when your patient is telling you something, it's good to repeat that back and say, this is what I'm hearing, that you're feeling like this. Do I have that correct? And then they can really correct you if needed or say, yes, that's exactly how I feel. And that creates a great deal of empathy for them. And then use that information as you provide education and treatment going forward. And I'll give you a quick example. I had a patient that was living in an assisted living setting, and she was becoming more and more socially isolated. And I really tried to understand what was happening with her. And as it turns out, she was experiencing freezing of gait whenever she would go in and out of the elevator when the doors would open and close, or if she walked down the hall to the dining room and suddenly there were other people approaching her. Both of those things caused her to freeze. And so she really avoided it because she didn't have a tactic to overcome that freezing and just chose to spend more and more time in her apartment by herself. And so understanding that and empathizing with how that felt helped me to really integrate that into her treatment plan. And we know through countless research studies that when you are skilled as a provider at being empathetic, that improves patient satisfaction, treatment adherence, and actually clinical outcomes. So for some of you, it comes really naturally. For others of you, it can be learned. And there are actually training courses that you can take on how to be a more empathetic person. And this goes for both caregivers as well. They can learn how to be more empathetic. So, as far as the caregiver goes, our operating principle is always empower the person first, the client first, because they are the ones, if they take responsibility, they're also going to be the ones reaping the rewards or the results. And so, in a situation where the person with Parkinson's says, oh, yeah, my spouse, drug me to therapy, they made me come, that's not going to be a good outcome until we can really turn that focus and that responsibility towards them. Sometimes a care partner is necessary, right? If the person has significant physical or cognitive challenges and needs that coaching, that cueing at home. And sometimes a care partner is desirable in the case that that care partner is really a positive, motivating force for the client with Parkinson's disease. The next E is education. Knowledge is power. We hear that phrase a lot because it's true. And as a physical therapist or an occupational therapist, we have a huge role to fill in some gaps with education on the disease itself, including the motor and non-motor symptoms. In terms of the motor symptoms, these are quite obvious, even for care partners. The tremor, slowness of movement, rigidity or stiffness of movement. But they may not understand that, hey, this is beyond what you would see with typical aging. This is actually more related to their Parkinson's symptoms. The same with hypokinesia, small or underscaled movement. They might see that their partner is moving smaller, is lacking arm swing, but they may not recognize just how much effort it takes them to scale that up to more normal amplitude. The non-motor symptoms of Parkinson's disease are many, they're complex, and they're less noticeable, they're less obvious, they're under the surface. These are really, really important for you to talk about with your patients and with the care partners that there is a much higher incidence of depression. There might be changes in thinking. It might take you longer to process something. There might be difficulties, internal cueing, learning, remembering to move bigger, even though you know that you should be moving bigger. There's changes in sensation, proprioception, self-monitoring, and then some emotional changes as well, including anxiety and apathy. And all of these things impact a person's mobility, balance, their activities of daily living, their motivation to exercise, participate in things that they love. And so really take time to educate caregivers and clients on these non-motor symptoms so that they're not misperceiving that, oh, my loved one is lazy. No, it's not that they're lazy. They might be struggling with apathy, or, oh, they never wanted to go out and do anything. Well, it might be related to some underlying anxiety that they're having. So here's some questions that you can ask. Have they had any changes in thinking? What have you noticed? Do they need more time to think about things than they used to? How do they do with multitasking? And these things can really creep in very early in the disease, actually. Do they have feelings of anxiety, worry, sadness, apathy, depression? And so it's good to start conversations about those. Certainly, there's rating scales for non-motor symptoms as well, to help with that. The sensory disorder is something that is often under-recognized, especially by care partners of people living with Parkinson's disease. They may say things to you like, oh, they're always leaning over to the side. I keep telling them to stand up straight all the time, not really recognizing that, hey, when they're leaning over, they probably don't feel it. When they're not swinging their arms, they probably don't recognize it. And so that can be a big aha moment for care partners. Like, why don't they do that? They don't feel it. The same thing goes with speech. Typically, the person with Parkinson's thinks that everyone else needs a hearing aid because they don't perceive that their voice has become softer over time. And I was speaking at a Parkinson's conference not too long ago this spring, and I was talking about this, and the wife and a daughter came up to me afterwards and were completely mind blown. They're like, wow, I did not know that. I keep telling him that he needs to speak louder, and he always blames us, like, you need to get your ears checked. But it is a real phenomenon. It gives them a great deal of relief to know that this is part of Parkinson's disease. When we ask them as therapists to move in a way that we see as more, normal in amplitude, to the person with Parkinson's, it feels huge. It feels ridiculous. And the same thing goes when you can hear them internally, it might feel like they're shouting. And so it takes quite a lot of education and reinforcement. It's not easy. I love this picture here, putting on someone else's shoes. I'm just imagining my husband putting on my high heels and trying to walk. It would be a disaster. But we need to put ourselves in their shoes, and care partners need to take a moment and put themselves in the shoes of a person with Parkinson's disease by understanding these things and imagining, the effort that it takes. So let's talk about some positive things that we can do. And these are some things that are really specific to LSVT Big and LSVT Loud. This is, my wheelhouse where I have spent many years of treatment and learned many things. So care partners, if I suspect early on that they are going to need to do some degree of coaching at home with a home exercise program, they may need to model the exercises. I'm going to ask them to observe sessions and to start participating with the exercises in the corner of the room. I'm keeping my eye out, and hopefully their motor performance is improving over time to the point that eventually I might ask them to, lead a portion of the session, the exercises, so I can just make sure that they are a good coach, that I have trained them well to take over with the exercises for the home exercise program during therapy and after discharge. I'm always asking the care partner for feedback, like how are they doing at home? And they may need reminders as well, like, hey, be patient, be empathetic. You might not see a lot of changes in week 1 or week 2. It takes a lot of practice. Keep going. You're doing great as a care partner. Keep encouraging. We also tell care partners really try to use positive words and experiences. It's easy when you're frustrated, you're burned out, you're, feeling all the feelings to get a little negative, right? But that does not help a person with Parkinson's disease. So we say focus on when they get it right, not when they get it wrong. So if they're using a great voice, say, wow, I can hear you. Your voice sounds great. Or maybe they're walking, with better arm swing or a little better posture, and say, hey, wow, you look great. You're keeping up with me. And then help facilitate positive interactions beyond yourself as well. Really put them in situations where they're around, friends, other family members, where people also might notice, like, wow, you sound great today. You're moving great, whatever that may be. We want care partners to be empowering and to empower the person living with Parkinson's disease. Oftentimes, I see care partners jumping in too early to help a person out of a chair, out of the car, to do some activity. I'm like, stop. They can do it. I've seen them do it in therapy. Let's give them more time to try that. Allow them to take on roles that they might have stopped doing after Parkinson's disease. Sometimes you hear, well, it's just faster for me to do, clean the kitchen or do the dishes or do the laundry. Well, wait, you're taking away that role for them. It might take longer, but allow them to still participate in that occupation that they were once doing. So stop doing everything for them, even if it takes more time. Some movement tips for care partners. We tell them, like, stop using so many explanatory words. We talk a lot about this in LSVT Big training, the importance of simple cues, really focusing on amplitude, like reach big, stand big, put a big movement into your sleeve, and also take time to ask the person, hey, was that your biggest move? Is there anything you could have done to move bigger with that? In public, it might be a secret cue, right? Like if the person is sitting really flexed, just to put a little hand on their back to have that quick reminder. I'm going to play part of this video for you. This is a care partner of someone who received LSVT loud. Here we go.
I suppose like the biggest thing for me is I suppose reiterating what I just said, or what I said earlier, that get involved, be involved from the get-go, try to, absolutely go along to all appointments, try educate yourself, as well as, you were educating yourself, but it's important for partners to educate themselves just to understand the journey, understand what people are going through, understand how difficult it is to do those exercises all of the time. If possible, I think talk to your speech and language therapist about the possibility of sitting in on some of those sessions, just because I think people can feel, well, I wouldn't know if I was doing it right. Like, am I helping him? Am I hindering? Am I doing it the right way? People might be afraid if they are speaking too loud, it's going to hurt my voice. So to get involved, but also then I think to be part of that negotiation, to have that conversation around, how do you want me to help you? Do you want me to, are there days you want me to stand back because I know I can badger? But there can be like, is it, how do you want me to cue you? What is it that you'd like me to do? Because it is hard to get that balance between, not being overly involved, but equally not, supporting enough. So I think you need to figure that out between you, rather than maybe one person deciding this is what should happen.
Great. Yeah, that's great words of wisdom. Thank you, Joan.
All right. So, she was talking about being a supportive care partner for him receiving LSVT loud, but the same things apply if he had been going through LSVT big as well. And I just love what she said. All right, home practice is critical, right? We all know that to succeed, they have to do their homework. And so a care partner might help just establishing where and when they're going to do it, helping up with setup, whether it's just bringing a chair in, setting up the video technology that they might be using. Might be simple as just reminding them like, hey, it's time to do your exercises today if they tend to forget. And then check in on homework every day. The care partner might say, hey, how did your exercises go today? Is there anything that we need to report back to Laura when we see her in therapy? Do you want me to jot some notes down so that we remember to ask her about that? And then ask or observe what was done at therapy so you can be aware of any progress or setbacks. Again, they might be learning to cue or coach. And remember, we tell caregivers that homework is not just during the month of treatment, but when you're dealing with a disease like Parkinson's disease, it's lifelong. And so we really try to help them to reinforce that habit that we're establishing. And lastly, they can help with follow-up appointments and finding different exercise groups in the community after that episode of care is done. The long-term care is vital when you're living with Parkinson's disease. What you'll do during therapy will really help to optimize their movement, restore movement, but we have to be a great partner with them and the care partner in finding community-based fitness options and helping them to be successful at home. And with LSVT Big and LSVT Loud, we have a number of different tools like videos and different technologies that we can use. And we also have Loud for Life and Big for Life group exercise classes in communities and virtually that they can engage in. We also ask that patients come back with their care partners if needed every 3 to 12 months for a tune-up, for episodic care, and proactively discuss the environment. So early in the disease, it's okay to have conversations about, tell me about your house, and start having those conversations early on. Equipment that might be useful down the road. You know, what are you thinking about job? How long are you going to stay there? What can I do to support you? And what kind of goals can we set so that you can function in the way that you need to at work if you're still working? And lastly, enlisting others is difficult, right? It's hard to ask for help sometimes, but remember all those people, when you revealed to them that you were diagnosed, they said, hey, let me know if I can ever do anything for you. Now may be the time to say, hey, I need a ride to therapy, or I really could use someone to just come in and provide some respite for a while. I might need help putting a ramp in my house. And so reach out to people, build that network. And for any of you that have watched Mr. Rogers, like I did when I grew up, he said, look for the helpers, right? And for Parkinson's disease, we need a lot of helpers. They might be the medical care team, the allied care team, and then people in the community as well that can provide a range of services. There are a number of wonderful, wonderful organizations. We're so fortunate. A lot of these are available to people in the US and even internationally to really support caregivers because we know it's not easy. Some of them are educational resources, some of them are virtual support groups, some of them provide respite care or respite grants. And so educate yourself as a therapist what sort of opportunities and programs are out there for caregivers when you see that, hey, they could use some support, they're struggling, or I'm just trying to be proactive and be helpful with that. So in summary, lead with empathy and empower your patient and caregiver. Appreciate that Parkinson's is complex. And so educate your care partners on these complexities of Parkinson's disease and really empower the caregivers. Like, you are a vital person that can really help to support their voice and movement at home, during therapy, with homework practice, and acknowledge that, yeah, it's exhausting, but it also can be very, very rewarding. Make time for yourself so that you don't get burned out, and learn to enlist the help of others. If you're interested in learning more about LSVT, we have a website and a blog where we've got a ton of information. But I just want to leave a couple of minutes for questions. And thank you again, Dr. Jenny, and thank you all of you for your time today.
You are welcome, Laura. So thank you for this. This is a different perspective and outlook because we're always talking about Parkinson's disease, but this one is at the backside, supporters, the caregivers themselves. You know, we're always thinking the Parkinson's disease as a patient is the one that always have the problem, the issue, but you will never know that the caregivers themselves are really exhausted. So this is a different overview, right, Laura? This is
That's
a different.
totally right.
Yes, yes. So do you have, let me see, do you have any questions, guys? Of course, LSVT itself, for not familiar, that is a Lee Silverman voice technique, the acronym. And Laura, can you tell us a little bit overview where it came from and who is Lee Silverman?
Yeah, of course. That's a very common question. Lee Silverman was a woman with Parkinson's disease who inspired the treatment. She lived way back in the late 1980s. She's no longer with us today, but at that time, there were no evidence-based treatments to improve voice and speech in people with Parkinson's. In fact, it was thought to be hopeless. And so Dr. Lorraine Ramig, who was the inventor and developer and lead researcher on LSVT Loud, developed a treatment approach. And she found that, hey, if you treat people intensively, frequently, really keep the focus simple on amplitude, it works, right? And so a protocol was developed called least liver and voice treatment back in the early 1990s that is very effective. It's the gold standard of speech treatment globally. It's the only speech treatment with level 1 evidence for Parkinson's disease. A ton of research. LSVT big was developed based on those principles that work so well for speech, but applied them to movement. And so now we have LSVT loud, which is the speech treatment, and LSVT big is the physical and occupational therapy treatment, focusing on amplitude, super intensive, 1 month treatment time, incorporating principles of neuroplasticity. And that's the shortest way I can say it to you.
Yes, yes, definitely. And guys, I would like to share with you that they also have, of course, they begin with the in-person, right, Laura? And
Yes.
they're also doing a hybrid program, which they
Mhm.
can do online. And Laura, is there an opportunity? I know that you go to Japan, you even go to, I think, Russia at one point, but globally,
Yeah.
that's why it is LSVT Big Global. So can you
Yes.
tell us more? Is there, how can they access if they are interested in Philippine based? Because I think I remember
Yes.
to connect with you, and we would love to have those program bring to Philippines.
Yes, yes. We have 3 learning options, same course. We have an online course that's completely asynchronous. It's in English, and it takes about 15 hours to do. You have 60 days to do it. And that's our most popular course for international learners because you don't have to work around time zones or anything like that. That's the one I would recommend the most. We also have a virtual live course, which is Zoom based, just like you and I are here today. We have several of those courses throughout the year. And then we have several in-person courses as well. This fall, I will be going to Japan and also for the first time, South Korea. Those courses are in English, but they're translated consecutively to the language of the country. So you're always welcome to come to those as well. We just need to know ahead of time that we get you an English binder. But you can find all of those on our website. There's a big red button that says Get Certified.
Yes, thank you so much. Yeah, I think it's difficult to be in South Korea and Japan, and then
Yeah.
they will translate more. But if you go to Philippines, we can understand right away. We are in.
Yeah, I would love to go there someday.
Although we love K novella or something. Yeah, I have one question from Chris. Dr. Laura, I have a question here. What role do sensory systems play in the progression and symptomatology of Parkinson's disease? And how can understanding these sensory changes improve patient management and treatment outcomes? And that's our last question, Doc.
Yeah. That's a very, very good question. And it's complex. I would say we don't fully understand the underlying pathophysiology of that. However, it really, really impacts movement. If a person has lack of proprioception and kinesthetic awareness and do not feel that their movement is too small, do not perceive that they're not swinging their arms, do not feel postural changes, you can't correct what you can't detect, right? And so that's a big part of what we do in LSVT Big is focus on that sensory motor mismatch through a process called calibration training. It's very intensive. It's very unique to LSVT Big and LSVT Loud, but it's also very effective, not only clinically, anecdotally, but in the research studies as well. So we're constantly using a lot of feedback, a lot of cues, like, did you feel that big posture? Did you feel those big hands? Did you feel that big arm swing? That's what it needs to feel like all the time. So we're training a new internal cue for amplitude, even though they recognize eventually that, hey, if this feels too big to me, it's probably just big enough. And so that's really it in a nutshell. But as a therapist, if we do not address those underlying sensory motor mismatch issues, those issues with kinesthetic awareness, you're doing your patients a great disservice.
That's great answer. Yeah, and then also, Chris, we have a great topic from Dr. Erica DeMarch yesterday from the Step Connect and those sensory proprioception. That's amazing to incorporate. So that's why you can do like
Yeah.
deep, you know. All right. Thank you,
Yeah.
Laura. We
All right.
appreciate
Thank
you,
you.
and definitely please put on our webinar chat all the information and your social media. Thank you.
Okay.
All right.
Thank you.
So, guys, I would like to also thank Larry Gusay and the company are LSVT Big Global. They are one of our great sponsors, and they always support us every year for our annual summit. So some of you came here and most probably are beneficiaries of their sponsorship. So thank you so much, LSVT Big, for supporting us all the time. We appreciate you. All right. So let's see. All right. And certificate of appreciation was being presented to Laura Gusay. She's the Chief Clinical Officer of LSVT Global, and for sharing her knowledge and the updates of LSVT, Parkinson's disease, and here today for the Geriatric Rehab Summit 5th annual event here in Delaware. All right. Thank you, Laura. We appreciate you. So this is the one that we're talking about. So they are one of the sponsors, and LSVT Global, we will put on the chat how they can help you, how they can be what you call can check on hybrid program, online program, is it in person, whatever works for you. All right. So they are available there. Thank you. And for our next speaker. So all the time as a physical therapist, we always deal with pain. But the question is, how can we talk to our patients how to manage the pain? What will be our verbiage? And we're always taking, what is your pain level right now? And sometimes I don't want to ask that. They don't really have the pain, but later on, because I asked her, sometimes they will feel it. So for today, this morning, Dr. Kenton Pinko will going to discuss the pain neuroscience storytelling. He's a doctor, physical therapist, and therapeutic pain specialist. He is our next speaker, and we're going to learn more about him. So before becoming a clinician, Dr. Ken served his country as a United States Marine Infantry Squad leader. Dr. Ken, thank you for your service, by the way. Dr. Ken chose to study in the Philippines and graduated with a BSPT from Fatima University. So if we have Fatima University here, say hi, shout out to you guys. In 2001, he earned his TPS, Therapeutic Pain Specialist Program 2018 from ISPI, which was integrated into the curriculum of Doctor of Physical Therapy degree 2019 from the Evidence in Motion. Dr. Ken has over 15 years of clinical expertise as a Maitland COMT or Certified Orthopedic Manual Therapist. His hospital's partnership council experience has enlightened him about the value of blending communication science, customer service, psychosocial pain model to maximize his patient's treatment experience. Dr. Ken feels that evidence-informed clinical reasoning is how best practices for physical and movement medicine are applied. I totally agree with that, especially when treating complex maladaptive, non-specific musculoskeletal pain. He works at PIH Health Hospital in California in their spine care center and is open to collaborating with other professionals who share the same passions and interests. So if you have lots of questions about pain, Dr. Ken is good to go. Is the person to go. All right, Dr. Ken, welcome. So let me see. He will be, you are the co-host already, Doc Ken. I can see you here. Let me check on you. Yes, amazing. And I met him. We are good. He's a family friend. I have those friends here. Here. You're still on mute, so I'll
Oh,
put
there we
you.
go. Can you hear me okay?
Yes, co-host. Yeah. You're a co-host now. I thought I put you as co-host a while ago.
Okay, there.
All right. I can see you.
Hi. Well, thank you for the intro. And there, that's one less thing I'll have to do. And it's a bit embarrassing because now that was such a great presentation by Laura. To follow in her shoes now, right? But I was, let's see. Let me get my notes out here. Can you see my presentation up in here?
Not yet.
Oh, not
But I
yet.
can see
Okay.
you.
Let's see. Share.
Mm-hmm. And you're a co-host. You can share your screen.
Okay, I've got it, I think. All right. Sorry. And
Mm-hmm. It's sharing now.
okay. And let's see. Yeah, so let's see.
All good.
Still there? Okay. All right. So yeah, this is I have a passion of talking about pain, pain neuroscience in particular, and how sort of how it works. So this first slide is mostly a picture that I put together that might be something you would see maybe on Facebook or Instagram, maybe X, when I'm sort of scrolling through my phone. And these are sort of really wonderful, motivating posts to see, but it often doesn't really show how the person is and how they feel and how hard they had to work to get from that very first picture you see on the left side over here, which is a picture of an MRI. And this was taken maybe about 2 months or so after I injured my knee. So in social media, everything is sort of fast forward. Everything seems like it's instantly done. And when you see the picture on the right side, it's a picture of my daughter and I running through the finish line on our first 5K, which was done incredibly slowly, after being able to bounce back from that injury. Now, again, these images pack a ton of information, such as movement being necessary. You can see me yelling that out over there to promote our craft that we do. And that they don't always convey, though, the amount of time it takes is all. And again, it seems like it's more instant and magical when people bounce back in there. So a bit of a note about this image, this radio opaque section over here, you'll see a large Baker cyst that formed about maybe about a week later after my injury. And I want to bring up that pain neuroscience education alone, and I'm going to shortcut it to P&E alone, didn't help me physically recover, become stronger. What it did is help me realize, that it was safe to begin movement once again, understanding that pain was just mostly my protector during the moment when recovery, during the time when I was suffering the most. So evidence influenced physical medicine, and mostly time is what really helped me bounce back. And this is 8 months later of time, not that magical instant thing that the internet sometimes advertises out to us. And it was mostly movement modification, progression, resistance, training, sleeping well, and of course having a good social support, mental state, and grounded finances helped create that healing environment around me. Most importantly, time is what helped me physically recover from being able to complete that slow 5K about 8 months later. Now, history kind of repeats itself. I'm going to give you the story of what happened this year, January 1st, 2024, New Year's Day. I went from having a wonderfully happy New Year into a painful to a stressful, a very frustrated, some self-pity, depression, and maybe even a smidgen of hopelessness sort of snuck into my brain over there during that time. And today, I want we as clinicians to become sort of more well-versed at being able to reframe these stories that we see. And we see these unfold in our hospitals, our clinics, and our nursing facilities, and by using, I think, words that heal, that's what I want to bring up. And of course, living in a world of suffering can take a long time. And 9 weeks to me felt like an eternity, especially after having a year like last year. But slowly, my happy, optimistic state became a bit more joyous with every rep I was able to achieve. And this is what I was doing to be able to prepare myself for that 5K. Now, advances in our busy, like modern world, you see how busy all this stuff is in this slide. It's sort of created new problems as well as all the cures that it's brought to us, right? Such as maybe sedentary lifestyles. And as rehabilitation specialists, our job is basically to get people moving, since this is our form of particular medicine. Now, science advances in technology have allowed our society to be able to receive instant solutions to a lot of medical problems that are out there. And it seems like almost like there's a pill for just about everything we can take, for every diagnosis on the ICD-10. But unfortunately, it also exposes us to maybe numerous side effects, which may outweigh sometimes the benefits. And I do feel like society sometimes pushes a lot of instant gratification on us as entitlements that we should receive, and that includes our health and the speed of our recovery. Therefore, for me, it becomes important for us to be able to bring perspective to unrealistic expectations, to be able to show tissue recovery at its normal pace. So recovery from injuries are closely associated with the amount of health, the amount of healthy muscle composing our bodies, the quality of sleep, and our socioeconomic status, like I was bringing up earlier, like maybe the family and spiritual support that we also receive. And showing people this timeline, of course, the biomedical side, courtesy, of course, of the prehab guys, of what it normally takes for bone and soft tissue to recover, helps me ground these unrealistic expectations early when I meet with them before we even start creating our SMART goals together. Now, evolutionary growth is slow, peaceful, while revolutionary changes, historically, when you look at revolution, it happens during war and can be a bit more violent and abrupt. For example, it'd be pretty unhealthy if I was to change the direction of my life, like if I was in a vehicle, like a car going down the freeway, to slam on my brakes, shift the car into reverse and just hit the gas pedal and try to go backwards in the opposite direction. A much more adaptable and maybe a safer option on the freeway here in California would be to change over to the lane, exit, maybe hit the brakes, make a U-turn back onto the freeway ramp. You start merging back into the traffic over there, and then gradually you're now going in a different direction. So it takes time, and people are like plants. We're more closely related to like organic biospheres, that we have all this living organisms and bacteria that live in us, just like the planet Earth. We tend to bounce back from injuries much slower, and it's going to be just like what the timeline suggested. All right. So I want to revisit the slide again that you saw just minutes ago. This time with just a bit more detail. So I'm sure we've all had that patient, right? As far as I've been practicing about 20 years, and I still get them coming in, and I used to not enjoy it as much, where it's going to start with, they're 80 years old and they're going to tell me that, it started about 60 years ago, 50 years ago back when I fell out the back of a pickup truck, right? And you got to brace yourselves, because it's going to be a long one, maybe even have a seat. But we as clinicians tend to sometimes interrupt, and sometimes listening to the whole story is a biggie for patients to feel in there, because they're telling you something very important about their life in there. So brace yourself, because I'm literally about to unleash the full uncut details of my injury about 8 months ago in here. And a lot of times I hear, it almost sounds like when we as clinicians hear the story from coming out of the patient, where let's start with, once upon a time in a mountain resort not too far away, in my case known as Snow Valley, I recently re-injured my right knee this January 1st. That's right, New Year's Day, by crashing my snowboard. And it filled my heart, my soul my spirit with a ton of stress for maybe the first 2 months. This year, because literally, me being more serious, I just spent 14 months recovering from a meniscus and a back injury, meniscus injury and a back injury. That was radiating all the way down to my right foot down here. This is because I was on a stool and I was awkwardly standing on it while working on a car, and I was doing some heavy mechanic type work because that's partially my hobby. And the stool broke and collapsed, so twisted my knee, etc. Now my son received a new snowboard this year from his uncle Dennis for Christmas, and we decided to hit the slopes because my knee was finally feeling much stronger, and we were having the most joyous endorphin-filled time on the snow, causing us to feel maybe a bit more daring. And we decided to learn maybe how to jump. So we went to the snow park, which literally elevated my already joyous day to like this adrenal dopamine epic experience, something like I missed when I was younger, maybe in the military too, is when I was feeling those same type of chemicals running through my veins to where stuff starts shaking like that, right? Now, the success of being able to jump nearly 5 inches, like this much air in there, filled my brain maybe with more endorphins, to the point of the adrenaline rushes in there maybe clouding my common sense. I sort of turned to my son. I said, "Hey, you know what? Let's hit the black diamond." And I double thought it, and they said, "You know what? Let's go to that big one over there. Let's hit the double black diamond right now before we leave." So it was our last run, and I confidently like rolled off the lift down the slope, and it felt like it got steeper and steeper and steeper and steeper. And I eventually found myself traveling at what felt like warp speed. Maybe the last time I was traveling on a snowboard this fast was well over 25 years ago. And it caught my snowboard's edge, trying to slow down through some moguls. And these are sort of bumpy things in the snow, like a bunch of speed bumps all in a row, just making my kidneys want to fall out. So this, I'm going to give you the finger guy rendition on a snowboard, flying through the air and striking my right knee onto Mother Earth's ice. And I've hit Mother Earth a few times, and she seems to always win. And you can almost say that my emotional state went through a revolutionary reversal, just like that car being thrown into reverse on the freeway over the next 6 weeks. When my knee puffed up, I had to use my mom's walker to get around the house. She was walking better than I was. Life instantly became a lot more grim. And I messaged a photo to my primary care provider the next day to see if they could examine my knee. And since they also have an urgent care built in to their office, his assistant messaged me back immediately and said, "Hey, go straight to the ED. We are not prepared to handle an injury like that, and I don't know if we can even help you." And of course, what ran through my head was, okay, this must be serious. They want me to go to the ED because they can't even handle me in their clinic over there. Now, the ED was quite efficient, I must say. I was probably in and out of there in just over 2 hours. So it was an amazing ED over there. Receiving a really thorough ortho exam, some crutches, an X-ray, and then, unfortunately, when I left, an unsettling comment from the NP, the nurse practitioner, that I needed to set up an appointment with the orthopedist because of a bone fragment that was detected on my X-ray. And I had this wild imagination that starts dreaming of all kinds of things, and kind of with a nervous tone, I asked, "Hey, is this a bone fragment or like a loose body? And does it have any risk of swimming around and shearing or tearing any, maybe of my non-regenerating tissues, like maybe my meniscus or my cartilage is in there, stuff I'd like to keep for a longer period of time, maybe for the rest of my life?" So the only answer he could give me was, "Well, you got to ask the orthopedist. I'm not sure. That's all I saw in there." And of course, the earliest appointment I could make with the ortho was like 6 weeks out, which means that for the next 6 weeks, I have nightmares of this sharp, abrasive, bony fragments, slicing around my cartilage as it floated on my joint. Now, fortunately, I know better, because with every week that went by, my knee started feeling better. I was taking pictures of its progress. And that's why I had all those pictures in stock there. I didn't even need to use my cane by the time I walked in to see my ortho consult. I I was still hobbling though, and I was limping in. I couldn't walk very fast. That's the only thing, but I could walk, and I was able to do it without really having to use my cane, even though I brought it with me. So she was a really kind and amazing active listener, like one that didn't even interrupt me in there. And probably also because she was quite attractive, that had a lot to do with it, but that's a different story. Anyway, I walked out of her exam room feeling much more hopeful than I can return to my recreational pursuits. Like I heard Dr. Jen mention that I like hiking and I like the outdoor things. I like paddleboarding and all those fun activities. And having that out of my life feels like I wouldn't have much of a life anymore, So the big takeaway from that is the power of words and understanding from a clinician, listening to me without interruption, maybe also because of her amazing smile, had a powerful impact. I really consider myself as somebody who is very well versed in being able to understand the concepts of pain and suffering, but all that knowledge, literally went out the window. And knowing this much about pain did not exempt me from temporarily going through all that suffering. The human being in me needed help from another medical professional, maybe to help me cope with my own pain, to overcome my own suffering more rapidly. And there's also much more to the story, of course, than just a knee contusion. You see, last year had a horrific season when I lost my dad. I lost also my neighbor, who was like my second father to me. And there's even a lot more soul bending things that had happened maybe over the last 2 years that I don't have the courage to share publicly, of course, but you get the point, right? And I hope that this course, or at least after this presentation, you can be that person to your patient. The tough part now is building the patience to having to listen to that entire story the same way you did mine. Difference is, of course, you're a bit more of a captive audience, right? So over here, maybe another game changer for my consult was that orthopedics took her evaluation up a notch by deciding to perform like that ultrasound of my patella tendon, especially after seeing maybe my facial expressions and how concerned I was about that bone fragment that I kept bringing up in there. So with that smile again, she mentioned that I had an enthesopathy, which is not a floating loose bone fragment, but rather it's this calcific deposit, close to where my patella ligament is sort of attached to. And ladies and gentlemen, I want to introduce you to the miracle of what's called, you got to look this word up, is mechanotransduction. It is basically our bodies adapting and changing based on the environment that it's placed in and what it's exposed to. And that's how it evolves. It changes our body that way, and that's what exercise can also do to us. My patella tendon decided to rebuild an impact area with material stronger than more tendon material. It chose maybe calcific material because during the past reconstructions that it did in there, from maybe multiple motorcycle, bike, and I've been in like 50 motorcycle, bike, and car accidents probably in my life because I didn't make the wisest decisions as a youth, with racing dirt bikes and motorcycles around either. I decided to, my patella tendon, instead of wearing and tearing, it was wearing and repairing from maybe also other countless like knee strikes as a Marine close combat instructor. And maybe the countless kicks I did when I was competing in my college's taekwondo team as well. So you can you can really tell the difference though, right? Between the two different stories you heard. One from the NP, when they told me about just the amount of information, versus to the more detailed information the ortho gave me, plus showing me images. My overactive imagination finally was put to rest in there, and I was able to sleep much, much better. So what if your patient now brings in an x-ray, brings in an image of an MRI, because they got questions? How are you going to answer that? I often like using this infographic by Lowe et al. In 2017 depicting arthritic changes of the spine as we age. Over here you can see that when we are at a young age of 20, there's less degeneration seen on imaging, and this slowly increases over here in time. You can see those dots over there depict with every decade that we get older. The blue line over here you see is the intensity of the pain reported by patients, that 1 to 10 scale, in different stages in our life. An interesting thing happens over here at about the age of 55. You can see where they cross right there, where the green and the blue lines intersect. This is where people start telling researchers, maybe clinicians like myself, that their pain is actually decreasing or going away as their arthritis changes and gets worse in time using MRIs or X-rays. So in my opinion, this plants a seed of hope that back pain here in the Spine Center, where I talk about that all the time, can still decrease as we age, even though the MRI of the back is quite, it shows that it's quite getting worse, to look at. I always want to bring up the point that an MRI of the back, an X-ray, is a quite poor predictor of these symptoms. And that's where we have to explain the symptoms into them, and they have to correlate with what goes on in there. So here's a pro tip as far as being able to explain stuff. My client came in concerned about their diagnosis of low specific back pain and was wondering why he only had an X-ray and not an MRI to find out what was causing his back pain. Why did my physician only do that? Not necessarily an easy question to answer as a young clinician, because a lot of the MDs, the clinical practice guidelines, did not yet recommend PT first. Now, the evidence strongly supports the notion of PT before MRI because we're more familiar with it. We now have basic imaging in our DPT curriculum, so we can explain it much more efficiently in there. CPRs, such as the auto ankle rules, the knee rules, the Canadian C-spine rules, all that stuff. I usually tell my patients we are now trained to also detect if red flags present themselves that suggest we need to have imaging done. And I will always check for that first on our initial evaluation. And if I happen to find something that looks out of the ordinary, I will always contact your physician and refer you back to the MD if we happen to find anything at all. Otherwise, nonspecific back pain does not mean we don't know what's causing your back pain. We're not completely clueless when we're doing treatments to go in there. Rather, it means that there are a multitude of factors influencing your particular pain that we know now, such as maybe the nerve has restricted or poor blood flow, stresses that we're experiencing, temperature changes are highly influential to causing emergency signals to be created. Beliefs and sleep have much bigger impact when you combine all those things on pain than any of the specific things that are not red flags on imaging suggest. So specific back pain suggests that you now have a serious medical pathology if you have something specific. So I like telling my patients, you do not want specific back pain at all, because if you do, now we got a serious problem in our hands. And this is what MRIs do best, since we now know that arthritis alone, disc bulges alone, herniations, fissures, annular rings, pinched nerves alone have very low influence when they're just singled out. And I always make this a promise. I promise to continue monitoring your pain over the next few PT treatments, interventions. We'll continue exploring a multitude of treatments, because now we know that we have all these options that we can use for you that can be much more effective. And I will always be vigilant every time you come in, because if your physician never sees you this physically active, and we can sometimes bring on those symptoms a bit more when you're doing the things you love and enjoy, rather than just sitting there telling a person of how bad it feels. Over here, these are a collection of some really useful metaphors. And some of the most brilliant pain geeks in this world have put together. Now, I like using this because these stories, when you tell them, they seem to have much more of an impact than just giving a bunch of data out, right? So sunburn, describing ion channel expression to protect our burned skin. Our ion channels actually shift and change the sensitivity of our nerves in there. And they can change it for up to 48 hours, maybe up to 72 hours. So when it starts dwindling down. And these shift all the time. to make our nerves more sensitive or less sensitive. Having dinner with pain. I thought actually this was funny, and I got a kick out of it when I saw it. Having dinner with pain, but don't go on a date or even build a relationship with it. And I use this story with people who are fear avoidant. Expose yourself with your pain. Get it in bits and pieces and chunks when you have to face that fear. Every time you run from fear, it has this fear avoidance loop. So I have people try to face it a little bit. Brushing your teeth. This is describing pacing for pain. By brushing your teeth maybe twice a day to 3 times a day, 3 to 5 minutes at a time, rather than just brushing your teeth 1 time a week only and just waiting the whole week to go 2 hours straight, and I can see where that would be very unhealthy. Your gums wouldn't be able to handle it. They'd start bleeding. You wouldn't be able to eat very well. When that happens, you'd have some malnourishment issues, and it just cascades into a whole sort of things, right? There's the sore but safe, describing the delayed onset of muscle soreness, which is sometimes the side effect that exercise can give. And I want to mention to them that there's different kinds of soreness. There's soreness that gives you health benefits, longer life expectancy, reduced risk in cancers, decreased risk for dementia. Those are the sore but safes that you want to feel that you'll receive, that I want to give you, rather than the pain-related disability where you'll feel sore, but now it's disabling you. Pain-related disability is the one I don't want to have you go through. A lion in the room triggers that fight or flight response, right? And you got this cortisol response, and you're tense, you've got all this adrenaline because you've got this big lion and you're fearful of it. That's what normally happens to us. We produce all these adrenalines internally. But imagine this. Maybe a lion or gigantic black bear is going to be really scary. But if you can shrink that problem to become a tiny baby lion cub, or a tiny bear cub, you might trigger like an adorable response instead of that cortisol response, right? Making an activity that's dangerous and threatening to somebody shrink down. If they're afraid of picking up a box, if they're afraid of bending forward to pick up their shoe, start bringing the shoe closer to them. So when they pick it up, it becomes easier and easier. Start having them maybe lay down and come up and touch their own shoes to try to tie it. Have them cross your legs and bend forward into their shoe to tie their shoe. That shrinks their problem down and makes it easier and allows them to overcome in bite-sized chunks. Don't burn the popcorn. Another good one for pacing and auto-regulating. So, I mean, when you do just the right amount of microwaving in a popcorn, you get just the right of kernels to popped corn ratio, right? You don't want to be opening a bag full of burnt popcorn or unpopped kernels in there to sort of munch on when your movie starts. Having a pain meeting, when I say I get really tired because the brain has 9 sections of the brain that get hijacked and create a pain neuroattack, the brain gets tired, the whole body gets tired, and you'll have this chronic fatigue syndrome sometimes come up with that. Movement makes medicine describes, again, powerful morphine production in runners when they produce enkephalin with movement. And this is on a side note, runners produce about 10 cc's worth of morphine is what I tell them. So let's try walking. Maybe if you only produce 2 cc's of morphine, that's the kind of, that's the dose that they give you in the emergency department when you start moving around. Movement makes morphine is one of my other mantras. Pace, not race, to help reduce the boom-bust cycle. And then planting seeds should be done by all clinical staff to help cultivate that environment of rich learning, to use safe words. And that's where Pain Neuroscience Education Plus comes in. It's not just going to be Pain Neuroscience Education or PNE. It's going to be PNE Plus. And it's going to be plus movement, plus reinforcement, that carries over this learning really well. Sensitive nerves, describing the amplified signals, once again. Tease it, touch it, nudge it. That's one made by Adrian Lowe. He made it popular to where you want to be able to expose somebody to it. And there's different metaphors that sometimes explain the same thing, but you'll have all these different people all over the place that may not get it, but they may relate to one of the metaphors that have meant something in their life. Right? So what is pain? And let's maybe describe it according to the International Association for the Study of Pain. The definition is, this is a quote unquote, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And what's an example of that? When patients sometimes hear actual or potential, you mean potential meaning that it's not damaged and I have pain? Like, do you think I'm making this up because you don't see any damage on me and it's just potential? No, potential damage means this. I'm squeezing my ear, and actually right now I'm rubbing in my ear. It actually doesn't feel too bad. But let's say I squeeze it a little tighter right here. Now, pulling on it on this ear lobe, it doesn't feel very comfortable now. And if I pull a little bit harder, now it actually feels like it's painful. Ugh. And after a few seconds or a minute or so, it goes away. So I felt pain there. It was potential to damage it, right? I felt pain, but no damage was really done to my ear unless I yank it all the way down to here. Now, there's a good chance that if I did that, I would actually have some real damage happening in my body, right? So now that we know what pain is, you might be wondering, what is pain neuroscience education? You know, in 2017, Lowe, Niche, and Putzadura best define it as, this is a long quote, so brace yourself. P&E teaches people in pain more about the biology and physiology of their pain experience, including processes such as maybe central sensitization, peripheral sensitization, allodynia inhibition, facilitation, neuroplasticity, and more. P&E's neurobiological model often finds itself at odds with traditional biomedical models, odds meaning that they don't always agree upon each other when used in physical therapy. Traditional biomedical models focusing on anatomy, pathoanatomy, and biomechanics have been shown to have limited efficacy in helping people understand their pain, especially chronic pain, which may in fact increase a person's pain experience by increasing fear, avoidance, and pain catastrophization. You know, sounds a bit like my story though, right? You know, now for me, understanding this brief history about pain helped clear up why we still have that strong confirmation bias toward the old biomedical model and pain, right? And how expectancy violation, which is a surprise when people, their expectancy is sort of violated in their beliefs, may occur in many of us hearing it for the first time. So moving from a biomedical model of pain to a more multidimensional model has happened slowly over maybe the last 400 plus years. Rene Descartes was the first person who provided that scientific explanation for pain by providing a model that was, he said, it was mechanically transmitting pain to the body, from the body to the brain, when that body part was being placed into like something like fire, some kind of painful stimulus like that. Next, in the middle over here was Gifford's, the late great Louis Gifford's mature organism model. This was introduced several hundred years later because scientific advances happened really slow, like long ago and in the past. Then finally came the neuromatrix model, you know, a couple of years later after the mature organism model popped up in there. And this is where it finally showed that inputs from the tissues are nociceptive, right? What we feel in there, what we felt in my ear. Inputs from the nerves of the nervous system are neuropathic, like maybe with diabetes, or other like there's also post-stroke nerve pain that comes up from there, right? And inputs from the environment now are socioeconomic, influencing the neuropathic inputs from past experiences, conflicting information, failed treatments, all the stuff that we hear, all the stuff that we see and learn from our parents' upbringings, from our cultural beliefs, from other clinicians. You know, all of these things have influences on mind-body map smudging, and we can go over that a little bit in there too later. Threats on our safety of all of us as a whole organism. In a nutshell, you can say that the mature organism model evolved into the neuromatrix, and finally, our most currently accepted biopsychosocial model. You know, and this is, you know, Descartes' model, on a side note, is still being taught on a lot of medical schools, but fortunately, this is now slowly shifting. I'm hearing a ton of students coming up, or fresh grads that are coming up, that are now much more familiar with the biopsychosocial model. And can you see, though, like 400 years versus just 50 years of the mature organism model and the biopsychosocial model being present, where the 400 years has still a much more stronger impact. And that's why that when I explained an expectancy violation, a great example of that was, you remember when you're a child, or maybe when you were a child, the first time you found out Santa Claus wasn't real, how crushing that might have been, and the facial expression of what your child might have looked like during that time. Okay, this is the same facial expression, the same experience that some clinicians, and mostly patients who we care for, may hear for the very first time. Right, and we all know that scientific data doesn't necessarily change things. It's these stories that end up doing that, right? Because we all know the scientific data behind sugar and smoking, but yet I still eat donuts all the time, right? Now over here, this is back to the neural matrix, which, by the way, shows that there is no necessarily pain centers in the brain. We can't cut a pain center out, and there's no pain centers in the body that we can find in anatomy. But rather there's 9 sections of the brain that produce a neurotag. And this is a sequence that you see over here on this drawing, courtesy of Ben Cormack by Corkinetic, thinking about like riding a bicycle would produce a different neural sensation around my brain in here. Thinking about eating ice cream would produce a different neural network where parts of the brain connect to create those thoughts and experiences that we have and we go through. So what are the parts that are involved? I said there was 9 sections, right? Number one, the premotor cortex helps organize and prepare movements. So we can't think of what the next movements are as easily. Our coordination goes out the window. The cingulate cortex is for concentrating. I have patients tell me that they're very forgetful now, and that explains why that is going on. The prefrontal cortex is for problem solving. I have people tell me that they can't balance their checkbook. They can't read a book anymore because the pain is it's so intense that it's distracting them now. The amygdala, fear conditioning, addiction. This is changes all kinds and promotes all kinds of stress chemicals to become present in our system, to become created in our system. The sensory cortex, our 2-point discrimination. That's why in treatment we also test that in there, and we try to improve that in there as far as treatment goes. The hypothalamus, the thalamus, our stress responses, our autonomic regulation. We're always on fight or flight response. The cerebellum, movement and cognition. My neck hurts now, and when I try to shift lanes and merge on the freeway, I look like this now because it changes all that and it reprograms, and it actually changes our brain. And when pain has been there for a long period of time. The hippocampus is responsible again for memory, spatial recognition, fear conditioning. And the spinal cord is that gating, the gate control theorem, where we have interneuron. And that interneuron is designed to regulate the amount of signals that go into my brain in particular. Otherwise, it like ADHD, it gets overstimulated in there. Now, Hebbian theorem, if we can remember that, neurons that wire together, right, fire together. And Olympic athletes use this for visual imagery. They practice weightlifting techniques to get their weightlifting techniques polished. Gymnasts polish their routines as well when they're going through their routines on a balance beam. Jumpers and hurdlers know exactly how far their steps are and how many steps they take around the track to be able to make it over those tracks. And what they do is they play it over and over. Pianists also do this. They can, you see those people who play the air piano, the air guitar, maybe the people who play air drums. They had a research study showing that the people who practice that stuff, even when their instrument is not in front of them, get better than the people who only play when their instrument is in front of them. Unfortunately, this also works the same way when pain neurotags are often repeated over and over. Asking people about their pain from 1 to 10 deepens that programming when they hear it for the first sentence that our therapist says when they walk into the room. And as a funny thing, Dr. Janet brought up, I had a patient that was coming in. I was going to see them because their therapist was out sick and they were assigned to me. They weren't able to contact them and to tell them that their therapist wasn't there. So I introduced myself. Hey, I'm Ken. I'm going to be seeing you over here because your therapist is sick. And are you so-and-so? And he didn't even say yes. He just said, it's a 7. I said, oh, okay. Is this your name, Mr. Smith? Yes. Yeah, it's a 7. Yeah, that's me. I'm him. And I asked him, well, what's a 7? And I was like, well, my pain. I was like, oh, okay. Yeah, I was going to get around to asking you that. Sorry. And it was like, well, you're going to ask me anyway, right? Because it happens all the time. So that's deepened in him. So now my job is to see if I can deprogram that part in there. So over here, when we're talking about the neurometrics evolving into the biopsychosocial model, this is what it looks like, in the bio part. And we're taught this in school, so we're very familiar with the biomedical pain model in school. And this is a model where range of motion, manual muscle testing, 2-point discrimination, all that stuff that we see. And I want to make sure we do not forget it, because it explains acute injuries so well. It explains trauma that just happened so well. But I want to add into it and make sure that we don't forget the bio part. The psycho, which is the psychological influences, this is well documented in scientific literature, such as, in physical and psychological abuse during war, violent trauma, panic, bereavement, depression. These are all threatening experiences that we may find in this day and age over here. Now, I suspect the most surprising thing in here is going to be the socioeconomic influences of pain, because this is something that was not necessarily thoroughly covered during my school when I was taking my BSPT 22 years ago in the Philippines, right? And these are pain influences that I often see in my patients, such as food insecurity, housing instability, transportation needs, job loss, scarcity of utilities, interpersonal safety. These are now all basic necessities that need to be fulfilled in our modern world. And we as humans have changed, and these are threats. All this creates stress chemicals, neuroinflammation, and influences on our ion channel expression, those things that make the nerves sensitive or less sensitive. And there are videos that I do also recommend to watch that hopefully I can give that to Dr. Jen, and she can also share that with you, that will hopefully reinforce all this stuff, because I'm going through this somewhat fast. I don't know if you noticed. But how powerful is this social aspect of BPS in the BPS model? Taylor et al. In 2013 shows this graph over here showing where high satisfaction groups who are partnered versus low satisfaction partnered groups. And then there's also the unpartnered groups, which differ. Thus, being in a well-adjusted relationship appears to have the modest buffering effect on pain-related increases in disability compared to being in a less happy relationship or unpartnered. So the findings that they had in this particular study, in this graph, were that both partnered groups also showed more adaptive pain relief or pain-related changes in positive effect compared to the unpartnered group. So it's better to be in a partner than being unpartnered, like me right now. But the impact of relationship status on pain-related changes in physical functioning was partly mediated by the pain cognitions, catastrophizing, and coping difficulty. These results indicate that happily partnered pain patients show less pain-related physical disability and more adaptive, effective, and cognitive responses to daily pain changes than do unhappily partnered and unpartnered patients. So living basically in a happy union may bolster the capacity of patients to sustain a sense of pain coping efficacy during pain episodes, which in turn minimizes pain-related physical ability limitations. So my suggestion is, during the next 5-minute break, is for anyone in a beautifully healthy relationship to go ahead and text or call your partner and just tell them how lucky you both are, right, in there. Now, what kind of words are we using? I often hear these type of words in our clinic over here. And thank you also for Dr. Jared Hall for being able to allow me to use this infographic in here. I often hear wear and tear, bone on bone, pelvis is out of place, you got a blown out disc. What that does is, when you hear these things, we create this environment, and this environment between you and I right now is our therapeutic alliance, or basically is our clinical alliance in here, because we're all clinical rehab people in here that care for people. We create this world, and we can create the words and the environment and the situation for healing. And words like this, we're finding out, do not create a world of healing around us. So we control all this. And these, I think, are the words that we should use instead. And this is my mom over here, and she shows all her arthritis and all her joints in there. but she does a really good job at creating a safe world around her. And she creates wonderful narratives, and it doesn't stop her from going to church, from going to the grocery, like yesterday, for example. But if you could get familiar with these words and maybe replace those other words with these, with resilient, balanced, robust, and healing, adaptable, which is what our patients are, then it can start changing the world within our patients as well. So now, according to Lowe et al., and this is during a recorded webinar, I highly recommend you take if you happen to have this MedRich account, where experiencing pain in a negative environment increases pain by 8-fold compared to a positive environment. And that's why I'm such a stickler for creating that positive word environment around people. This is our take-home message. Again, we as medical professionals need to make that for our patients. If they can't bring a positive environment to us, we can bring them into our positive environment and accept them in. And when they leave, we hope that they take part of that positive environment with them home. Now, these are posters that I often use to answer my patients' question. And I wish I could hang them around my clinical walls and everything. But they're purchased mostly at OPTP. And I feel it helps promote an environment that when patients are walking around, like if there was in a waiting room or a reception area, they can look at it and say that, hey, what does that mean? What does this poster mean over here? And I do a class that explains this much more thoroughly. Over here, you're getting very quick rundown. I wish I could explain much more about it. But the very gist of it is that if we look inside our bodies, when I use those posters, I explain and I zoom in on this section over here of that poster, showing that we'll see a vast network of neurons when placed end to end. They're like 45 miles worth of this stuff. They connect about 400 special nerves called nociceptors to the spinal cord and eventually to the brain when the secondary neurons bring them up over there. They protect us from internal as well as external dangers, that we learned earlier right now, just a few minutes ago. All these nerves have electrical impulses and they transmit data back and forth. They are affected by changes and stresses around us. For example, when I get out of bed, they start walking to the bathroom, electrical impulses go up. And if I step on the cold floor, the temperature shifts and changes will ramp emergency signals to go up a little bit more. And me shivering may also ramp up my electrical charges. So when you think about it, if I was to relax, which I couldn't do because I was thinking about the argument I had with a friend of mine, and then also maybe the unfinished work I have for this morning that I got to go back to work, and then I get stuck in traffic, it's very difficult to downregulate. The only time I started feeling better one day was when I walked into the door and I got greeted with a smile from our joyous front office receptionist. We got the best office receptionist here, with a good morning and a smile. And finally, my nerves started to calm down. And then what made my day that even better, I log in. Here I am taking a sip of coffee, which works a little bit different with me. It tends to calm my own nerves. I see my first patient cancel of the day. And now I got this extra 30 minutes or so to be able to finish the project that's supposed to be due, and I got to submit to my manager, right? So all is now happy. When everything is happy, we get calm, sensitive nerves. And we create an environment again that's happy and calm. When we bring patients in to see us, it creates that calm, happy environment for them. They now have dopamine, oxytocins, and it reduces that state of alertness. Now, over here, we all know why we have pain right now, because it protects us, right? And I would want pain personally, because if I sprain my ankle like I did when I was running, here's what biologically happens. That impulses go up to my nerves, ramp it up. Nociceptors reach the action potential, sending those danger signals up. And when my brain receives a flood of emergency signals, it might decide, hey, I'm going to cause pain on Ken's ankle over here because I want to warn him about it. I want him to not, I want him to stop running. I want him to limp back home, or maybe to the ED where they can wrap it, maybe give me some crutches. And then finally, as my nervous system downregulates in time over the next couple of weeks, because my tissues heal, it should downregulate, right? Now, there's a really good story. It's about 5 minutes long that I made on another video that you can also check out about my, on this left of the slide. It looks horrific, right? This is my friend's big toe dislocating while he's in jujitsu practice. And spoiler alert is that he did not feel any pain at all. In fact, he didn't really want to go to the emergency department. His wife insisted and took him there. And his wife actually also wanted to reduce it on her own, which is, it's a good thing she didn't, because there was all kinds of blood that started spewing everywhere. But here's the biggest surprise anyway. He didn't feel any pain at all, even while at the emergency department, while waiting there, until they gave him a pain injection. I don't know what was in there, maybe Novocaine, Lanacane, Marcaine, whatever. He said that when he got that injection full of painkillers, he was in the most excruciating, he yelled out and everything. And the medical practitioners over in the ED could not explain why that was happening. Why was his foot now so painful after receiving pain medication? And this is something that the biomedical explanation could not explain really well. So a lot of times I explain it to this, that pain works like an alarm system in my house, which was installed like to protect my family from fire and toxins. When it's triggered, it warns me of an emergency, right? Now, however, our bodies do not have flashing lights. Instead, it has pain that it gives us to be able to protect us from that actual or perceived emergency. The motion sensors, the cameras, and the doors, none of those things, when they wake up and send electrical impulses to the computer, and the computer says, whoa, we got tons of electrical impulses and emergency signals from our sensors on the door and the smoke alarm, let's sound the alarm because there's an emergency. Now, that, like my brain, only the brain in my home alarm system over there that you see in that picture in the center can sound the alarm. My sensors directly connected to the siren cannot actually sound the siren. The same way that only my brain can sound the alarm in my system. And the difference, again, is it produces musculoskeletal, visceral, or somatic pain. So you got to listen closely here, because this is the part where we got to be careful when telling our patients that 100% of the time, only my computer in the house is the only component that can set off my alarm, the same way that my brain is the only organ in my body that can produce pain 100% of the time. Now, over here, let's go back to how I sprained my ankle. I was running with my dog, twisted it on a sidewalk, and after laying there, I limped back home. And fortunately, there was there was no speeding cars in my neighborhood, so it was safe, And my dog also pulled me back home. Now, I'm going to ask the question: would it be painful if I stepped off the curb to cross the street and twisted my ankle? And most people would say yes, right? Because it hurt me. But the correct answer would be it depends, right? So if you look at it from a different situation, what if I was running across the street, twisted my ankle, but there was a bus sliding out of control as I'm laying there on the street with me and my dog looking at me? Would my ankle still hurt if that was the case, right? So just like my home alarm can be turned off by the members of my household by punching in that code or saying a code word over the phone, the adrenaline endogenous opiates can suppress emergency signals when the brain decides that causing pain becomes more life-threatening than not causing pain during this particular situation over here. So social environments, you can see, affect our perception of pain. Now, let's say I'm running on a treadmill at the gym, and I saw this on social media, I guess, where I got distracted. Maybe I see somebody attractive, I lose my step, and I twist my ankle as I fall off the back step of the treadmill. Will I still feel pain in my ankle? Now, this time, it could be, again, a maybe, right? Because now it looks like I might be trying to impress whoever it is I saw that distracted me, that caused me to fall off the treadmill in the first place. My manly instincts would maybe suppress the pain instead. Dr. Tasha Stanton is a senior fellow in the Mind Body group in Australia, shared this personal story that's maybe about 19 minutes, and I have the link here if anyone's really interested. It's a really good podcast to listen to, where there was a small tear in what she thought was her own foot ultrasound on a research study. She began feeling more severe pain to protect her foot the next week when she tried running. And then she asked if that same image can be brought up on the slide again. And she later found out that it wasn't her foot image she saw. She saw another participant in their research study's foot instead. And her own foot did not have a tear in there. So a seasoned clinician, just like what I was going through, also was influenced by the social environment, by what she saw in there as well. And but by the way, her research study, I thought it was interesting. She put a foul odor in the air, and then she put a pleasant odor in the air, and the reflex, the emergency reflex, protective reflex, changed and shifted when there was a foul odor in the air, because now we're smelling something toxic, and our senses make us more aware, and it puts us more in a fight or flight situation. In foul odors, when that's introduced, pain can sometimes go up, is what patients tell me, when I ask them if foul odors make things worse. Now, how do we know when a clinician is able to answer a patient's questions without causing a nocebo response? I suggest that a lot of you take time to take this 12 or 13 true or false thing. It's a study called the NPQ-12 by Lorimer Mosley that he put together, and scoring more than 70% will suggest that you are qualified to give a really good scientific explanation for somebody's pain when they ask about it. So I'm going to go through this really quickly, but is it possible for pain to have, is it possible to have pain or not and not know about it? Okay, the answer is false. We always know when we have pain. When part of a body is injured, special pain receptors convey the pain messages to your brain. That is also false. It's nociceptors that do that. Pain only occurs when you're injured or at risk of being injured. That is false, as you saw in those examples. Special nerves in your spinal cord convey danger messages to your brain. That is true. Those are the nociceptors. When you are injured, special receptors convey danger messages to your spinal cord. That is true. 6, nerves adapt by increasing their resting levels of excitement. That is true. When we were talking about those ion channels, expression changes. Chronic pain means that an injury has not healed properly. That is false. We have all kinds of people that show their MRI is healing their surgery in the shoulder, but yet their pain is becoming worse and becoming more maladaptive. The body tells the brain when it is in pain. That is false. Nerves adapt by making ion channels stay open longer. That is true. Descending neurons are always inhibitory. That is false. Pain occurs whenever you are injured. That is also false. When you injure yourself, the environment that you are in will not affect the amount of pain that you experience as long as the injury is exactly the same. That is false. And finally, the brain decides when you will experience pain. That is true. You got all the answers that I hope that when you take this test, you will be now fully qualified to be really good at being able to explain pain when a patient asks you why something hurts in their body. Now, the most important reason for me to teach about pain is because people want to know about it. And unfortunately, I often hear clinicians teaching about just biomechanics or kinesiology, and that's it, and maybe just some anatomy, but they don't explain the whole psychological and the social aspects. They just explain the biomedical side of it thing in there. So a patient recently expressed their gratefulness to me for understanding pain in the appropriate time frame for tissues healing, because from what he was telling me, he was suffering in what he thought was some of the darkest days he had immediately after his spinal surgery. Now, he told me that he wished the surgeon taught him more about pain and suffering, because this would have made the surgery more easy to be able to handle afterwards and what he felt. Now, the takeaway is that P&E is an important communication tool to be able to answer those questions. And I wish it could be also included in our pre-op education, but we sometimes don't have time to that. Most importantly, it should be included because it is shown to increase patient satisfaction towards their surgeon or the physician. And of course, what surgeon or what physician would not want their satisfaction scores to go up, and who wouldn't want their patients to love them, right? Another good reason is because P&E Plus teaches us that growing evidence out there shows that, like in this JOSPT infographic, that our best tools is to get people moving, and it's now strong evidence that's in there, right? Now, how effective is this stuff? In my opinion, very effective. Over here, you can see in this graph, over here by Lowe, Diner et al. In 2011 for chronic and musculoskeletal pain disorders, compelling evidence that educational strategy in addressing neurophysiology and neurobiology of pain can have a positive effect on people and their disability, catastrophization, and physical performance. So over here, you can see that P&E plus movement is effective for 1 of every 2 clients, like 50%, right? For that NPT, while the biomedical model is not yet known. And for treatment of pain, 1 out of every 3 clients respond to P&E plus movement would reduce symptoms by at least 50%, while only 1 out of every 6 respond to gabapentin and 1 out of every 7 respond to antidepressant selective serotonin, those reuptake inhibitors, those SSRIs. So not only does PNE work, but it works quite well, maybe even twice as good as you can see some of the best medication that is provided for pain out there right now. So in our world, I like explaining this to patients a little bit differently than clinicians. I like happy faces. You can see that improving function, 2 to 1, improving pain, 3 to 1, improve acute pain. Unfortunately, it takes 3 sad faces before we can come up with 1 number needed to treatment for 1 happy person that's in there, right? Now, here's the best gold standard for what gabapentin looks like. Number needed to treat, we got to come up with 5 sad faces before we come up with a happy one, and 7 patients are needed to treat with the SSRIs, in there. Now, here's one that I recently ran into, last but not least, is epidural injection, the steroids, which is required its own slide basically to fit how many sad faces before 1 happy face can go into there. And according to Price et al. In 2005, ESI, or epidural steroid injection, led to a transient benefit in the ODQ and pain relief compared with placebo at 3 weeks. So it helped in 3 weeks. It was wonderful. But after 3 weeks, there was no benefit over placebo between week 6 and 52. Popular question also is, hey, this stuff is complicated. Can somebody even learn this stuff? And the answer again is yes. It showed that 5th graders, when we were learning about pain, did just as well, and sometimes better than 6th, 7th, and 8th graders during a research study that I was participating in when I was doing data collection and the format for that. And it showed that this just means that our patients with a 6th grade junior high educational level, at least that, will probably have a good understanding of this stuff. And if somebody has maybe a stroke or neurologic deficit, or maybe has dementia, it may not work quite as well because they have to understand it to be able to clear up all the danger signs that they were imagining, like I was imagining, to clear that out when you see what's going on internally. So knowledge empowers is what I believe in there too as well. So since we're on the topic of children, 1 in 3, by the way, suffer now from pain, and it's pain is now the best predictor of pain in a child, is how a mother responds to pain. So my takeaway from this literature, though, is how we can sometimes teach our children how to maladapt. And it's as parents and as their primary educators, as far as healthcare providers, we have to be able to teach our children how not to maladapt, how to adapt very well. And when we believe it and we apply it to ourselves, I feel like they can see that and they can sense it and they learn from that the most. All right. Dr. Jen, how am I doing with time?
We are already extended. That's why there's
Okay,
no
you're right.
Q&A on anymore. I put on the chat about that. If they have any questions, they can put on the chat. But we ran out of time, and we have already
Okay, and I tried to
Sorry,
condense this
guys.
back in there. So
Yes.
if there's any more questions, I'm going to fast forward this over here. And I was trying to talk to as fast as I could too. Oh, where's my last
Yes,
slide?
yes. So guys, if you have any question, I put it there on the bottom. Some questions you can answer, but we almost like 15 minutes behind.
Yes, I'm sorry for that.
Yeah. So, but I message Dr. Anna and Dr. Oscar that they can still have all those for the lymphedema. We just move back a little bit.
Yeah, so if anyone
Any
has
closing?
any, in closing, if anyone has any found this sort of interesting, and it was actually about getting ready to go into the data of all this stuff in there in the research, was please feel free to. I have a seminar that I'm going to do in about 2 weeks. You're welcome to join me over there if you find this stuff intriguing, and I'll go through the treatment and the testing as well. And I want to thank everyone for putting up with such a long-winded thing, but I could talk all day on this stuff, as you can sometimes tell and hear about it, right?
Yeah.
But
So
I'll-
thank you, Dr. Ken. This upcoming 2 weeks, that will be in California, and he has the whole day, the whole day. That's why it's so long, because this should be 8 hours in his course, and
yes,
just
yes.
wrap up for 45. That's really not enough, but he just want to give you a bit of that. And thank you so much, Dr. Ken, for this basic and overview. That's
Yeah.
that you need to squeeze. All right.
Yes.
And our next speaker will be about lymphedema. I supposed to give you a short minute break, guys, but we just need to squeeze your time if you want to do a quick break. But definitely this is amazing. Thank you so much, Dr. Ken. I can't really in between to squeeze, but because those are all great topics, you know. I don't know how to cut you there, but I learned a lot too. So we would love to give the certificate of appreciation to you, Dr. Ken. Thank you so much for sharing your knowledge about pain science and for today's Geriatric Rehab Summit 2024 fifth annual event here in USA, Delaware. So guys, thank you for listening, and we would love to learn more about Dr. Ken. He will put all his information, social media on the chat box. Ask questions there as well. So thank you to all our sponsors. We have the low intensity vibration from Maradine Live. We discussed this yesterday as well. And our next speaker will be, if you know, and if you watch us 2022, I did a lymphedema workshop. Dr. Anna is there as well. Anna Pozzoli is a certified lymphedema therapist and lymphedema and lipedema specialist. We did a wonderful webinar about the description of that. We will also have Oscar Pozzoli, and they are going to discuss today the different lymphedema mix, mix because it is a guide to CDT, complete decongestive therapy. All right, so let's see, discuss more about that. And we, Dr. Anna Pozzoli is a graduate from Polytechnical Institute of Holland. I can pronounce this, but I think Enschede, Holland. She's the owner with Oscar Pozzoli of the Omnitherapy Physical Therapy Clinic in New Jersey. So if you have patients in New Jersey, you want to learn more about lymphedema, please connect with them. She has 30 years licensed physical therapy experience, 25 years as a clinical educator. She's a specialist in orthopedics, lymphedema, lipedema treatment. All right, so I'm giving the floor. Thank you.
Good morning, everybody, and good evening to our colleagues in the Philippines that are watching us. So we are here together with Oscar, and we're going to be presenting on lymphedema. So let me share my screen with you guys. Let me know.
Yeah, I think you're a co-host already and you can share as well. Thank you so much for waiting, Oscar and Anna. Live in
no
New
problem.
Jersey.
It was a great presentation. Do you see my screen there, or let's see?
Not
Let's
yet,
share.
not yet.
Okay.
Okay, it's coming.
Okay. All right. Let's go into from the beginning. Do you see it now? Okay.
Yes.
Great. So today we're going to discuss a mix of lymphedema that we treat at Omnitherapy. As you had mentioned, we have been doing this for a good 30 years, good 22 years of that as a specialist in lymphedema, and also we can say lipedema as well. Okay, I'm Anna Pozzoli. My husband Oscar is here, and we're both co-owners of Omnitherapy Center. And so, hold on. Okay, so we have nothing to disclose. The pictures that we are using and videos presented are not to be reproduced. So, hold on. Okay. All right. So this is our objectives that we're going to go over today. We'll go right on to the first one. What is the definition of lymphedema? A lot of times it is not well known because in a lot of physical therapy programs and even in medical schools, it's not well educated about. But lymphedema is a chronic condition which is caused by a failure in the lymphatic system. So it's the body's network of organs that help rid the body of toxins. And can you still hear me okay? All right, so it gets rid of toxins, waste, and other unwanted materials. When it's not draining properly, it causes abnormal accumulation. And that's what the accumulation that forms there is called lymph fluid. in the tissue. And when it stays in the tissue, it can lead to swelling and also thickened skin. Most of the times you see it in the upper and lower extremities. However, it can appear in other body parts that may be affected as well. If not properly treated, it can lead to other debilitating complications, as you will see in our presentation. Hold on. Yeah. Okay. All right. So we have two types of lymphedema in their classifications. So the main one that is called the primary, that is a congenital. And I don't mean to say main, that it's the most constant, the one that you'll see. But primary is congenital. It can be sporadic, meaning it can happen anywhere in the body. It could be one extremity, two extremities, sometimes 3 or 4 extremities. This is hereditary, and it's usually accompanied with different syndromes like Turner syndromes, Milroy. So there is a whole classification, probably not seen as much in the elderly population. Usually if you see it in the younger stages, you'll see it more in pediatrics, but it can also get aggravated at the end, and it becomes an issue with mobility and other aspects of life. The main one that we do mostly see that are referred to us as therapists is called secondary or acquired type of lymphedema. And there are two types. It could be benign, meaning it's not being caused by any malignant tumors or anything of that nature. Instead, it can come about from an infection to a body part. It can become present after a trauma. And when I mean trauma, it could be a fall. It could be also a surgery. So undergoing some type of surgery can lead to some swelling. If the swelling is not managed properly, it can become lymphatic in nature. And most commonly now, what we're seeing is with the rate of obesity almost at 42, 43% in the United States and globally also increasing, obesity is becoming an issue as to why we will see secondary type of lymphedema. It has a lot to do where the position of the lymph nodes for the lower extremities are, which are in the groin. If you sit, you're sedentary, or you have an overhanging belly, that can restrict the flow of your lymphatic system. And so those would be the reason why a benign secondary type of lymphedema would occur. On the malignant side, you see usually primary tumors. So any of your breast cancer, throat cancer, and the female gynecological cancers, you would see that. And if there is a tumor and then there are treatments for it, whether it's chemotherapy, radiation, or actual removal of lymph nodes because they are affected by the tumor, that can become an issue with your lymphatic system. Again, sometimes it may clear up, but then you start to see reoccurrence of tumors. It can again exacerbate or even present, if the tumors are in another body part, can present with lymphatic congestion somewhere else. Same thing as metastases. If you have metastases anywhere else in the body, so if it's a breast cancer, now it has metastasized into the abdominal area, you may see some ascites and some fluid that will build up in that area. All right. 1 second. What happened here?
What happened?
Let me press enter. Oh.
1 second.
Sorry, guys.
I don't know why it's not going to the next screen.
Here
There
we go. So here are some of the images that you see with primary lymphedema. On the left side, the upper extremities. These are patients that have been born with this type of lymphatic congestion, and it has only become worse as they have progressed in life as to adulthood. And many times, parents will seek out to treat them as children, but when there is not a whole lot of information about it, that can be an issue. So upper extremity, you may see it in the just one arm, and in the bottom left, you see just one extremity, although the other extremity is also beginning to manifest some lymphatic swelling. Secondary lymphedema images. So you have one related to breast cancer, up on the left side, which is on the left arm. You see the congestion of the arm and also not so much the hand, but from the axilla down to the wrist. And then you have breast cancer patients that may have radiation. The radiation in the neck area can manifest to have fibrosis, and you get swelling buildup in the neck area, so which it will restrict movement. And then on the right upper box, you see what is called a massive localized lobule. This is related to obesity. So a patient underwent gastric bypass, and after the loss of possibly 80 to 90 pounds, there was still obesity-related lymphedema in the form of a lobule. And patient will be undergoing surgery to have that removed. But actually, and you'll see later on that, we have been working on it to try to reduce it as much as possible prior to the surgery. And then in the lower extremity pictures, this is what happens with poor mobility. The elderly, quite often, it starts to occur. They become a little bit more sedentary, and also with addition of weight. So this patient is obese, unable to get to her feet. So there is congestion, as you see happening there. Okay, and so the other lymphatic disorders that we get to see at OmniTherapy, which is pretty common nowadays as well, and maybe because we are the specialists in our facility, we see it a lot more. It's lipedema, and it's not to be confused with lymphedema. Many doctors sometimes will say, well, you're pronouncing it wrong. It should be lymphedema. In reality, it's a whole other disease by itself that, like Dr. Ken, I can spend hours and hours talking about it. So lipedema is an abnormal accumulation of adiposity, so fat tissue, rather than lymphatic fluid. However, in the later stages, advanced stages of lipedema, you can lead to a lymphatic accumulation, also known as lipolymphedema. So this is where your legs look like tree trunks, and sometimes you'll see the women with the upper portion of their arms, almost like a flapping tricep, and they'll say, I don't know where this came from, and it will manifest and keep growing. The major difference with lipedema and lymphedema, with lipedema, there's a lot of pain, there's a lot of bruising that occurs with its manifestation of the disease. Also very difficult for them to lose weight with traditional weight loss, and not well understood. So again, lymphatic disorder, however, in a different body part. And then there is phlebolymphedema, which is a condition that is a result of chronic venous insufficiency and lymphedema. So this is where you may see some patients with open lesions in the legs, ulcerations. The swelling is present there, and it takes a little bit longer to heal from that. So these are the other two types. So this is why we call it a mix, because there is lymphedema, lipedema, phlebolymphedema. So we can go on and on. And here, some of the images. This is what lipedema will look like. So again, the tree trunk legs. On the other picture on the right side, you see that the hips, this is what we call saddlebags, a formation of lymphatic and also fat deposit that is occurring. So she's in the later stages. And keep in mind that this is attributed a lot of times to predominantly females, and it's hormone driven, and as well as, it can progress with every hormonal event. So whether it's at puberty, childbirth, or even being on birth control pills, this can actually aggravate the lymphatic system and the adiposity that will grow there. And it's extremely difficult to tell a patient like this, well, you just have to stop eating, because it's not related to the food intake. As you could see with the patients with the saddlebag, her waist is quite small. So there is a discrepancy of upper body and lower body when you see this. So not to be confused with just obesity or just lymphedema. So then there is phlebolymphedema, which here we are showing some of the ulcerations that would occur in presentation of these patients. And in addition to that, also hemosiderin, so dark deposits of the skin that almost look like a permanent sock. But as you can see, that their skin also becomes a little bit harder in texture, sometimes a little bit raised. And these are a little bit more challenging to work with and treat, because not only is it difficult for them to heal effectively, to get to their extremities, it's also very challenging. All right. So here I'm going to let Oscar do the explanation of what a certified lymphedema therapist does.
Hi, everyone. How are you? Hopefully everybody's doing okay. I'm sure that I'm from the Northeast, so I'm gonna talk a little bit faster in Jersey compared to my spouse, but I hope everybody's doing good. I think the presentations are wonderful, and welcome all. I'm sure you probably have a lot of questions. So Anna spoke about all the conditions that we see: lymphedema, lipedema, phlebo. Also, we do vascular swelling as well. And but this is what we do. The role of a certified lymphedema therapist. It is a professional healthcare provider. Not necessarily does it have to be a physical therapist. It could be an occupational therapist. We have massage therapists. We have yeah, pretty much, right? And they become certified. And what we do here in Omni Therapy Center, we do what we call the gold standards of lymphedema. We do the gold standards of treatment, which is basically complete decongestive therapy. Complete decongestive therapy is based upon manual lymphatic drainage, as you see there. It's a gentle manual drainage technique. It is not a massage. It is a drainage technique. We emphasize a lot of this because there's much talk about, oh, go get a lymphedema massage. That's quite different. We do drainage techniques. And we also utilize compression therapy. We utilize German-made short stretch bandages. We do not use ACE bandages, although there are times that you can use it, but most of the time, 90% of the time, we utilize short stretch bandages technique. And we also use other garments to reduce and control edema. Exercise. We emphasize a lot of breathing techniques so we can stimulate the sternocali, which is a sac right in the center of your core. It's a sac like sternocali, which works kind of like a pump. This is a pump, kind of like here in New Jersey, we have basements, and we use a water pump. Sometimes when water comes into the basement, this water pump flushes this water back up towards the street. So kind of like it works the same way in our body. The sternocali, as we do exercise and we do breathing exercise and pushing, we allow this sac to push this lymphatic fluid from the lower extremities back up towards the thoracic out. And exercise, skincare. We focus, and I'm going to show you a couple of videos on skincare. Skincare is very important when we do it. This is, again, part of the complete decongestive therapy. We educate the patient on the proper lotions, what to utilize. Do you use creams? Do you use a lotion? Do you use an ointment? Right? And why do we do this? To prevent infections, to improve the skin texture, and so forth. And the next thing we do, garment choices. And this is very important because there are a lot of times where doctors will say to the patient, you have swelling on the legs, just go to the pharmacy and get yourself some compression socks. Please keep in mind, compression is not a regulated form of a product. It's just the name compression, right? And so what happens is that there are many companies out there that take advantage of the word compression, and they'll create any type of compression sock. Now, as a therapist, you have to determine, does this person, can they contain their swelling with compression socks? And if so, what type of compression socks? Are we looking at, because there are mercury of pressure with compression socks, are we looking at 15 to 20 mercury of pressure, 20 to 30, or 30 to 40? All of this is knowledge that is needed to treat your patients with lymphedema. And of course, patient and caregiver education, extremely important because we have phases of treatment. We do intensive phase, is that what we do here? The intensive phase is where we do our complete decongestive therapy. We do our drainage techniques, we do our compression techniques, skincare, exercises, and then once we determine that the limb has reached its maximum decrease of swelling, then we have to think about, okay, we need to provide now the tools for this person to maintain this new size of the leg down. And this is where the professional comes in, where it says, should we use a compression sock for maintenance? Should we use a Velcro garment? Should we use flat knits? And so forth. And so let me just keep turning because I'm trying to, all right, let me go back, sorry. Okay, when we deal about educating ourselves and how to become a lymphedema therapist, how do I become to do this complete decongestive therapy? And I say it many times because we find ourselves with many of our certain places around here in New Jersey and New York where they have patients go to a physical therapy clinic, they put them on this pump, and then they put them on this pump for 45 minutes. Of course, the extremity is going to be reduced, and then that's it. And then they make them go and do exercise. Please, folks, that's not complete decongestive therapy. These are the schools that teach the complete decongestive therapy. Okay, we have from Dr. Vada School, German, where my education comes into play. We also have the Foldy Clinic in Europe, very well, excellent schools. You have the closed training lymphedema certification, as well as the International Lymphedema Wound and Training Institute. They teach you both how to become a lymphedema therapist as well as a wound specialist. Then you have the Academy of Lymphatic Studies, ACOL, and you have Norton School of Lymphatic Therapy. These are the schools that if someone was to ask me, if a colleague was to ask me, hey, I want to learn what you do, these are the schools that I would mention to them. So a day at Omni Therapy Center. Obviously, Anna does the evaluation part. I think you want to take over this? Okay, well, I'll speak about it. So Anna does all the evaluation, the history, the diagnosis, comorbidities, the girth measurements, very important, girth measurements, right? Why? Because we have to have objective numbers, right? Insurance companies are not going to just basically say, hey guys, what do you do? Well, that's great, we're going to pay for it. We need to have objective numbers, right? So we take girth measurements, right, before and after. We also have to be very important, differential diagnosis. There are many doctors that send us patients saying lymphedema, evaluate and treat. Well, is that the lymphedema code? Because once we do the history, we get to realize, wait a minute, this person is lipedema. So we change it. The plan of care changes. Talk about, right, knowing the contraindications on lymphatic treatments, right? Is this a cardiac patient? We're dealing with an arterial situation and so forth. We need to establish a plan of care goals with the physician according to the deficit, the functional status, and very important, mutual and realistic goals. Because there are times that patients come in here and say, I just want to, have, well, in reality, they want to become, say, 100%, no swelling, but in reality, there's a lot that plays not just lymphedema treatments of what we do, but nutrition. Anna talked about how here in the United States, the morbid obesity rate just continues to climb. So we next things, we understand the involvement and potential outcomes secondary to the patient's motivation to achieve mutual goals. What does that mean? Well, we can create a plan of care. Let's say sometimes patients, we need to see them every single day. Why? Because this person may have open sores. They may have oozing. They may have weeping legs, right? That's lymphatic fluid coming out of the legs. So we need to see these particular patients every day. So if a patient comes to us and says, I'm sorry, I have to work, and it makes it difficult and challenging for us, to really get that limb under control. So those need to be achieved as mutual goals between the patient and the therapist. That needs to be clarified. The cost of treatments, bandages, garments, and I don't want to go into a lot of details with this because many of you may know that Medicare now, pays for certain things, but it's a circus. And why do I say that? Because it's not that simple. You need to know what kind of tools you need in order to treat this patient. It's not just one thing does it all, okay? Not just one pump does it all. It's not just one particular bandage does it all or one garment. We need to understand, as I mentioned before, the understanding of the history, the understanding of what the patient's goals are, and so forth. And the cost of treating, very expensive. We have bandages and we have garments that are on the hundreds of dollars. And yes, insurance company may say, "Oh, well, we'll pay for that." Okay, but we also need to establish who's going to measure for the patient. Who's going to, where are you going to get the product? Is the product the right product for the patient and so forth? So the cost of treating can become quite expensive. And the dedication of time, effort, and involvement of family and caregivers. I know, Jenny, that this is being seen, all over the world. Here I can only speak about the local community. I can tell you that we have families that come in here and they'll do everything for their parents, for their spouse, and then we have patients that come in and nobody visits. They have no one. So now we have to think about what tool can we provide to this patient, okay, that's going to reduce the swelling, but at the same time be able to for them to put them on. Because if you have a product, you have a compression sock that the doctor says just get it and put it on. I'll guarantee you that 90% of the time, those compression socks are in a drawer somewhere because they never put them on, because it's extremely difficult to put on. So that's where we come in. Do we utilize different tools to help these people? I always say to patients, listen, I would love to get you at 100% better, but if I get you at 80% and above, goals accomplished. Okay. All right. Again, here is, let me stop this for a moment. Hold on. Now, I'm going to show you here a couple of videos. All right. A typical day at our center. Now, we've been doing this since 2001. And so we have thousands and thousands of videos and patients. So yes, I'm showing you here a little bit of the extreme. Okay, the extreme, because not everybody can work with certain patients like this. Okay, because it's difficult. You ask yourself, where do I start? What do I do with this gentleman? You see on the left side, the leg. Where do I start? It's difficult. How do I bring this how do I bring this lobule down and so forth? There's a lot of questions to ask. As we see it also on the right, we see a what we were talking about, skin, right? We're talking about right here where there's hyperkeratosis. How do we remove that, right? So basically dry skin that just builds up on the leg. And many people say, oh my God, if this person was to shower every day, would this be a problem? Maybe not. But we do see these patients come in. And yes, we can say, please, if we can get a chance to get in and shower more often, sure, we do that. That's part of the patient education. But we need to break this down. So this is skincare. You see, this is a particular type of skincare. You see it there with the tool. I don't know if you see with the tool. And then right here, we have a type of special pad that's made in France. That what is that? I forgot the name of it.
Dermabrasion.
Dermabrasion. So we utilize this kind of like sandpaper, right? And we break down, dry skin, right? We want to get to a nice, clean, bed that the leg will heal much faster. Then we have things like here. I don't know if you can barely see here. This is also from France called Mobiderm. This is an area where we need to break down fibrosis, right? And so we utilize Mobiderm to help us break down that fibrosis. So there's a lot of tools, you see, that we utilize, not just a bandage technique. There's a lot more to do. So let me just give you a little bit of right? So this is a little bit of what we would call a manual lymphatic drainage, right? Where always, as you notice, my hands are picked up. It goes from distal to proximal. Always, we never massage down. We want to always try to get that fluid, that extra lymphatic fluid towards the groin area. Okay, so all right, and then here we have a video of breaking down of, and this is something I don't think we have dentists, right, in the panel, but this is a dental tool. Okay, this is a dental tool. I have a good friend of mine that says, and I tell him what I do, and he says, I think I got the perfect tool for you. I said, really? Because guess what we were using? And I always laugh at this. We were using
Coffee stirrer.
Coffee stirrers. Somebody's having coffee, I'll probably say, ooh, oh my God, coffee stirrers. Yes, because it's made out of wood right? And there's no abrasion whatsoever. We use no scalpel whatsoever, no cutting whatsoever. And so this is a tool that is used, right? Soft area, we're just breaking down, skin. Just removing it and so forth. I kid around with patients. I tell them, look, I got your DNA on the floor. So I get the vacuum cleaner. I have to vacuum your skin. I got to vacuum you off the floor. So we have a little fun while we do treatments as well. Okay, and let's see if I can bring Anna back. I talked to him. Let me see. All right, Anna. Oh yes. Oh, let me stop this for a moment.
Yep.
Hold on. Okay, hold on. Go ahead.
All right. So with our patients, a lot of exercise and education goes into play with what's going on. So it's not just dealing with the lymphatic. What I'm going to show up here is this is a patient who has had breast cancer treatment, a mastectomy, radiation, and chemotherapy. So there's a lot of weakness related to her function and her mobility. So as you're going to be able to see over here, and doing the exercises, just having the patient do a simple scapular retraction, you could see that there is such a difference in one side versus the other. And I make these videos for the patients, for them to see what's going on, because a lot of times they're not even aware that this is happening. So it starts to change their posture as to how they conduct everything. And then of course, it trickles down to upper extremity dysfunction, neck pain. It's a whole cascade of events that can occur after someone who has had breast cancer treatment and the development of lymphedema. Also, you could see that I implement kinesio tape just to give them a little bit of feedback as well. So it's not just a simple treatment of saying just lymphedema. You really have to step up all your other skills as a therapist, your education part, your exercise part, the functional part that is involved. Let me stop this one. And down here, again, this is a video that I am making actually for one of the patients. She lives in a nursing home, so she was sent to us for fitting of an upper extremity Velcro so that the family can help. She's also using a Wear Ease t-shirt. Let me just, there we go. So she is also using a Wear Ease t-shirt, which has compression throughout. She has undergone treatment, so even she had a mastectomy, although it appears to be almost a breast, actually that is edema in the chest wall that she has developed. So in order to implement not just the arm, we have to incorporate something in the trunk of the body as well. So as you can see here, and the video is being made because when she goes back to the facility where she lives, the nurses need to know how to reapply this on a daily basis. She's now at the final stage of therapy. She's going to enter into her maintenance phase. So our job was done by bandaging first, reducing the arm, and now wearing a garment. Okay, and here there are some other outcomes that you can see after using our complete decongestive therapy. On this one picture here on the left side, this is a patient combination, one of those combination patients. So it is lymphedema, phlebolymphodema, meaning chronic venous insufficiency. So you can see all these little papillomas on the skin that are almost erupting because the skin wants to get rid of that extra fluid that's built up under there. So what happens, it changes the skin integrity. Sometimes actual pore may open up and you start to get leakage. That leakage is lymphatic fluid that's coming out. Many times you will see someone coming in and they are like, I don't know, something is, my socks keep getting wet. Well, that lymphatic fluid carries a lot of toxins. So it becomes very hard on the skin. It also breaks down further the skin area if not treated properly and absorbed or maintained. So what ends up happening is it's a very foul smelling lymphatic fluid in the area, which can further deteriorate the rest of the skin. So again, as we did an evaluation, we found out, okay, yes, it's not kidney related, it's not heart related, it's really a combination of chronic venous insufficiency and obesity, poor mobility. So the patient wasn't walking as much, moving as much. So therefore, we were okay to initiate treatment with CDT. So what we did was we started bandaging, but not just regular bandages. We also incorporated what's called Mobiderm. That's why you see this pattern. So Mobiderm has these foams embedded inside. They're in shapes of cubes. And these cubes actually apply pressure in order to help break up any fibrosis. What is fibrosis? Fibrosis is accumulation of fluid that is trapping protein. And as that protein sits there, it becomes harder. Now, with these patients, you will have pitting edema, and you would also have what's called a stemmer sign, where you cannot pinch like the top of the toe, the second toe. You cannot pinch that because there is so much congestion there. So these are some of our differential diagnostic tools that we incorporate to make sure that we know what we're dealing with. And then I'll let Oscar go ahead and explain of his patient here on the right side.
Oh, yeah. Okay. So this is one of many. Again, as you can see, we put actually dates here, some we have. But here, for instance, the patient typically comes in. This is a typical situation where I see the first or the second day after the initial evaluation. And while we begin the treatment, as you can see, right over here, within, on the February, and this is maybe 2 weeks, give or take, you can actually see the difference already. Okay, and this is done with complete decongestant therapy. And so, assuming we're taking measurements here, we take every 4 centimeters, we'll take measurements. Every 4 centimeters. Now, how many times? You can actually see the dots here. You can see the dots right over here that will take measurements, okay? Why do we take measurements? Objective, right? We want to make sure that we have objective numbers, measurements, right? Insurance companies want it, and even for our own sake, so we know that we're advancing. And then in this situation now, what we want to do is we want to measure and say, okay, what is best for this person? Should this person utilize compression socks? Here's the thing. What kind of compression socks? Are we looking at the kind of compression socks? Yeah, go ahead. Go to Amazon and buy some compression socks. Yeah. Or do we do flat knits? Or do we do something else? Well, it's not just about the product itself, but we have to ask ourselves, what can the person don and be compliant? This is the key thing. Be compliant. Because now this person is going from the intensive phase, of which what we do here in our clinic, now they're going into what I call the maintenance phase. Okay? This is where we teach the caregivers, this is where we teach the patient, okay, of what to utilize, okay, to best keep these legs from getting worse. Now, notice what I just said, from getting worse, because this is a chronic condition. It's not going to change. But if you don't do nothing about it, it can become this again and can even get worse. Okay? So we like to teach the family members, the patients themselves, how to utilize. To give you a little bit of feedback about this type of garment, this is what we will call a daytime and a nighttime garment. What does that mean? Basically, it can be put on the day, just like bandages, and it could be left and they can sleep with this on. Now, many of you may not or may know, compression socks, you are not to sleep with compression socks, especially any compression over 20-30, okay? Not to be slept with. So those compression socks become daytime wear only, okay? So here, we teach the patient again, what is best? What's best tools for this family, for this person? So this also is part of it. So I can go into a lot more details about it, but let's move on. Here on the left side, we have a gentleman who came in and this was a very interesting case because this gentleman was a believer of if I put Bengay, if I put ointments, three vitamin D ointment, if I put my leg on a hot shower, it was gonna get better. So it comes to us and okay, now I need help. Well, sure, okay, so we need to you know to inform the patient what is best practice for them, right? What would be best for them? And here, right after, and the treatment, the intensive phase treatment of CDT, I ended up utilizing something called 3M compression. 3M compression is a little bit different than short stretch compression, even though it does the same results. The difference is that I can put this 3M compression system on this patient, and because he couldn't come to us 2 or 3 times a week, he could only come once a week, I utilize this compression system, and once a week you will come in and you can actually see the results, okay? And this is like a week later after we put this on and removed it, you begin to see the difference, right? And then from here again, we utilize it for another week, 3M, and here we go. And we can see the difference between, and these are the toe wraps that we use because you also have to incorporate the toes, okay? And you can see the before and after. So we can basically say, okay, this person now can go into the maintenance phase. Now let Anna speak about the upper extremities since she basically sees the ladies for that treatment. All right, how we doing? Okay.
Jen, how we doing with time?
Yeah, max 5 minutes.
Okay.
Yeah,
Okay.
so
Perfect.
for the closing as well. Thank you.
Perfect. So, this one patient, she actually is a patient who doesn't even live in the United States. She comes from Puerto Rico to see her family and heard about OmniTherapy, came to us. We did intensive therapy 4 times a week for like about 2 weeks to try to maximize as much as we could in order to get her into a flat knit. A flat knit is very different than a circular knit. So they have sleeves that you can buy that are off the shelf, and those are easy. These are measured for the patient. So custom made measurements are required, very intricate, especially when it comes to getting them into a glove. So that alone will take you a good 30 to 40 minutes to just do with your patient. So we consider that sometimes one of the visit, just to have them come in for measurements only. Then they get sent to Germany. These happen to be a Medi, and they get sent to Germany. They're made for them. They come back for the fitting, and you pray that everything is perfect because this patient was only here for a matter of 1 month. So when we got her fitted, we were able to give her that so that she can take with her. So you always recommend two of these garments. They're not cheap now, thank God for the Lymphedema Treatment Act. There's some coverage for it, but you want to have one to wear and one to wash. So again, like Oscar mentioned, these are daytime garments. She also has a nighttime garment, which is a big puffy pillow-like device that she puts on at night so that her arm will not swell up. And here we have our own, this is our measurements that we do, circumferential measurements. We do it for upper extremity, lower extremities. Sometimes if we have someone with neck issues from throat cancer, we will incorporate different type of measurements for those patients. And so here, going back to the different types of lymphedema that we see. So this is the patient that we started seeing due to obesity. This is called a massive localized lymphedema, and you may come across these patients from time to time and not know what to do. So manual lymphatic drainage really helped tremendously, teaching the patient how to do it, elevating, getting the patient into a pump for home. These are their tools. They come in here with an empty toolbox, and we provide the tools that they need and incorporate. So she went from, and you can actually see her wide stance in the first picture with the green on. And then now that she has lost 35 pounds just from that lobule alone, to be able to stand. So that has improved her balance, her dynamic movement. She's not afraid to go out. She has even like slimmed down in her belly. So therefore, you're creating all these changes, and it's great to see it. Also, when they follow along, that's part of your treatment, making sure. And this is what we talked about: the mutual goals of patients and yourself. Are they ready to commit? And the commitment is, yes, using something every day. And I mean, this device is called a reduction kit. It is for lobules that it is used. Patient has to keep adjusting probably every 2 hours because her lobule keeps changing as it's draining, and that means she's going to the bathroom quite a bit. She has to readjust it for it to continue to be effective. So these are the kind of patients that you may come across in a lymphedema setting. This is why it needs to be a specialty. You cannot say, well, yes, I'm a, everything kind of therapist and I will see all patients, because these patients require one-on-one 60 to 75 minutes per treatment. So, all right. And here we have other types of patients currently treating a patient who has on the left side, you see one with a primary lymphedema, and nowadays they are doing surgeries for these patients, but it's called debulking. They're debulking some of that fatty deposit that may be there. She's had this primary lymphedema, younger 32-year-old, since she was a child. And after her pregnancy, it became worse. She underwent a debulking procedure at the Cleveland Clinic with Dr. Chen, and she has reduced quite a bit, but it still requires bandaging and management. And she is great at it because she had this since she was a child, so she understands the involvement. And I'll do, Oscar will do this last one.
Now we're going to continue. As you can see, the before and after. We're showing you here on the right side. You can see the papillomas. You can see the difference, and you can see how shining that is. Oh, and one thing, please note, many therapists may bandage all the way to the thigh. Okay, they're taught in Germany. My professor that taught me, if he realized I'm only going to the knee, will probably say, "What are you doing, Oscar? You need to do it all the way to the top." Well, you're going to find a lot of times that patients don't tolerate that. At least here where I live, again in the local area. Okay, in Germany it was different. Germany, if you wanted to bandage all the way to the pelvis, there was no problem. The patients were like, "Yeah, let's go." Okay, so let's move on. And okay, and this is our little one, Dorita. That's our other therapist. When they come in, she sits around, and as you can see, we even bandage her. No, I'm only kidding. But yeah, that's it. So if you have any questions, I guess we can leave it to the end, or please. I don't know if we have any time, but it was a pleasure, Jen. Thank you, and great panelists. We appreciate it. Thank you to all your colleagues for everything that you do, as far as teaching and showing all of us. But
Thank you so much. Thank you so much, Oscar and Anna. So one of the questions here a while ago, I have my colleague Virginia. She's a PTA as well. So she's asking if a PTA can be a CLT. Definitely, Oscar, you can talk about that briefly. And also we have another question about the dermabrasion, the tools and everything. If regular therapists can do those, or a certified lymphedema therapist only can do those. So I answered a little bit of those, but you can answer a little bit of briefly as well.
Well, as far as the PTA, oh my God, God bless. Yeah, it's great. It's wonderful.
Oscar's a PTA, so
I'm the
yes.
PTA.
That's what I'm about to say to
really
her.
appreciate it, but,
Yep.
but no, yeah, no, I've been a PTA since 1992 and love it. I get to see so many patients, but to answer your question, of course, there's no doubt. When I went to the courses, the course was 6 weeks long, but because I already had anatomy, human anatomy, and so forth, I only needed to do 4 weeks. 2 of those weeks was every single day. Every single day. Didn't matter whether you were a doctor, you needed to be every single day, so you learned the whole techniques about it. And as far as the other questions, please, Anna.
So the tools that we use in regards to that question, once you become certified lymphedema therapist, yes, if you're a therapist, occupational, PTA, doctors, massage therapists, not so much. Some states allow the use of those tools, others do not. But these are the things you are taught and actually those schools that Oscar pointed out, they bring in all these companies to kind of demonstrate. It's a show of their information, of their tools that they use. So you're going to see all of the garments in addition to like the foams. All of that is part of your learning if you are a certified lymphedema therapist. And keep in mind, the tool that Oscar was using is just a simple, it's a dental tool, but it really is just to scrape the skin. We are not cutting. There is no blood involved. There is nothing, no scalpel. I won't do that.
No.
Yes.
No, not at
But
all.
in
Great.
general, all the things that we discuss here is as a CLT, like that the certified lymphedema therapists are allowed to do, something
Yeah.
like that, right? Yeah, that's what I
Absolutely.
want to emphasize, guys, because they need to refer to you, a lymphedema patient, to a certified lymphedema therapist. That's why our discussion is what a typical CLT does in a day-to-day, and these are what the description and what we do usually. That way you have an idea if this is for you and what to refer for CLT specialist. All right.
Yeah, and Jenny,
Thank you
just wanted to
so-
mention
Mhm,
something.
Go
We
ahead.
before we go, it's extremely important that you give the time. The time is key because we run into situations where patients are coming from other facilities and they're saying to us, "Oh my God, I didn't get this kind of a massage." They'll call it a massage, right? "Yeah, I didn't get this. I didn't." And then we realized after so many years that my wife and I, we see one patient per hour. I see one patient, Anna sees one patient, and that's it. One patient per hour is minimum. Sometimes we stay till 75 minutes, but you need that time. And so what happens is for many of you therapists out there that you work for facilities, please, before you commit to coming into this type of field, make sure that if you're working, make sure that you talk to your employer and emphasize the importance of seeing one patient per hour. Because if you do anything less, you're not doing the job.
Yeah.
I think many of you therapists will say, "Hey, I learned so much in school, but my God, if I see 3, 4 patients an hour, I'm so much losing, all my skills, right?" So this is a very special skill. So just to let you know, as a PTA, well, here's my boss. So, but at any event, please keep that in mind. Thank you, Jenny. Thank you so much.
Yeah, you're welcome. Another question here. So it's okay. After this, we have a 5-minute break. So we have question from Dr. Net. Do you do lymphedema therapy inside the pelvis, or is there a certain certification for pelvic floor lymphedema therapies? Why you want it inside the pelvis, Net? Can we just
No.
put it like on top of pelvis? Yeah. So go ahead. Mhm.
So there are techniques that are to be done, especially after there is radiation for any of like gynecological types of cancers. But I usually would refer to a pelvic floor specialist, and they usually do that as well. So because it is very intimate, we predominantly work with the extremities, the neck area, things like that. But if it is for a female gynecological, or even sometimes males after prostate, they may be needing a little bit of a specialty. They're pelvic floor specialists. So even within our specialty, we have subspecialties as well.
Yeah, that's why Dr. Net asked that, because she's a pelvic floor specialist,
There you go.
and that's what she does regularly. That's why she questioned it if there's like lymphedema specialist that does that as well. So you refer to them because they're the specialists for that.
Yeah, we have 2 in
Wonderful.
our area. Great.
Yes, yes. She's based in I think Illinois. So that's wonderful. So guys, if you have any more question, please connect with Oscar and Anna, and she's going to put all the questions here, your questions here. And Anna and Oscar, please put your information on the chat box. And guys, we have 5-minute breaks, please, before our discussion for the next speaker, because we have a very long topic for one small word, neuropathy, and we will have 2 hours and 3 speakers just discussing what is neuropathy. And to say thank you for our awesome speakers. Let me see here. Thank you so much, Anna. And of course, we have we would like to offer this certificate of appreciation to Anna Pozzoli, a certified lymphedema therapist. And guys, if you see Alana, that's an lymphedema, what do you call this again? The lymphedema, is what they call this, the test that they passed as a certified lymphedema, and also is different when you are a lipedema specialist too, and Anna has that. Thank you, Anna, for sharing your knowledge and expertise as one of our speaker for our Geriatric Rehab Summit 2024 fifth annual event. And we have Anna as well for our previous workshop for lymphedema therapy. And of course, we have Oscar Pozzoli. He is a VODR certified lymphedema specialist and an expert clinician. So we have him working with Anna for the Omni therapy. So Oscar is a licensed physical therapist assistant. Here you go, Virginia, with an impressive track record spanning over 30 years in orthopedics, wound care, pedortics, and lymphatic disorders. He is the proud co-owner of Omni Therapy Center, alongside with Anna, a physical therapist and a certified lymphedema therapist. They're originally hailing from Uruguay. Is it correct, Montevideo?
Yeah, Montevideo. Yeah.
Oh, I thought it's a typo. Montevideo, Uruguay. He obtained his CLT training from VODR in 2010 and achieved NLN expert clinician status in 2022. Oh, I need to learn. That's really good. It's more on the lymphedema network, right? He and his wife, Anna, have actively participated in various domestic and international conferences focusing on lymphatic disorders, delivering educational presentation for Dr. John Schubach and for, is it Tuan?
Tuan.
Tuan.
From France. Yes.
Oh,
From
I
France.
really need to improve, learn my,
That's okay, you got enough.
I need to write it down. So I have two now, Montevideo and Tuan. Yeah. And then he's also doing the podcast in the Lymphcast and contributing to faculty of the National Lymphedema Network. So connect with them, guys, if you want to learn more about lymphedema. They're really great mentors, and they will explain to you. Then check it out first. The certification is, I did mine in Academy of Lymphatic Studies. It's almost a week, like a 9 days. And then that's upper, lower, but it's not enough. You really need lots of experience and to see patients to learn the best techniques. It's not like, oh, I'm done. No, they have 30 years, imagine, experience for you to be like, and thank you so much, Oscar. And here's your certificate of appreciation. Thank you so much for sharing your knowledge, Oscar Pozzoli.
Thank you, Doc. Thank you,
And you
Doc.
are welcome. This is for the Geriatric Rehab Summit 2024 awarded August 17 here in Delaware, USA. Thank you, guys. So we have
Thank
a
you.
5-minute breaks. Yes. And then we will going to have our next speaker soon. And then we will going to see you soon. And that will be our next speakers will be 3 great speakers. If you remember Dr. Morris, he's our keynote speaker. He is one of the speaker with Dr. Logan and Dr. Chloe today, all right? Yeah, so just want to check on that while you're having your break. We would love to say thank you again for our sponsors. We have Age Wiser. We showed the great video yesterday. So Age Wiser is an innovative platform dedicated to enhancing the lives of older adults. This is amazing. This is from Swati Balantrapu. She innovated this. She's a physical therapist based in California. She just passed her geriatric clinical specialization this year. And she did this with her team. She Age Wiser AI powered senior care. So I installed this last night, but I know this almost like months ago because we talked about it. And then we tried some webinars before and learned more, but now it's up and it's not, what do you call this when you're practice? So now it's up, you can download it and you will see that it's good for the brain and it covers the 4M framework: mental health, I practice that, and you can use it for your patients and you yourself. I use the mental. I said, is it for my patient or for me? So this is for everybody who wants to decrease falls. And falls is not only for balance, it's also for your mental. And we can learn more about it later, all right? So here, let me see, talk more about that later. And thank you for our sponsors. We'll learn more about them again later. And definitely, we are going to talk more about our next speaker. So if you are ready, guys, we are going to discuss more. So you're good, Dr. Morris? So Dr.
Oh, yes. Can
Morris
we
will
share the
be
screen?
here.
Oh,
All
sorry.
right. So I would love to introduce our topic for today, of course, will be help. My patient has a neuropathy. What can I do for it? So now for these 2 hours, like a summary, as a physical therapist, we will learn more about what we can do for it. A basic what is a neuropathy first, and we know about it, but we always need to learn the deeper meaning of it. Oh, that's the numbness. Oh, that's a sharpshooting. Is that enough? So we will learn more from these amazing 3 speakers. So Dr. Morris is our speaker yesterday, our keynote speaker. Did you remember all his credentials? A physical therapist, a doctor of physical therapy, and a dual certified specialist in geriatrics and neuro. And he was awarded of the recent Lucy Blair Award recently this year. And you know that he is the past chair of the Neurologic Specialty Council and the Geriatric Specialty Council of American Board of Physical Therapy Specialties. Not all of you are here yesterday. We need to run down all of this. He currently serves as a board member of the ABPTS. Dr. Biaro is a recipient of Outstanding Educator Awards from the Academy of Neurologic Physical Therapy and the Florida Physical Therapy Association. He has received the Distinguished Mentor in Residency and Fellowship Education Award from the Academy of PT Education. He has been published in peer-reviewed publications. I see his resume when I sent this CEUs. Lots of publication and awards and research. Amazing, guys. Journal of Stroke and Cerebrovascular Disease and Journal of Acute Care Physical Therapy. This can be 2 pages, but he just sent us the summary. Welcome, Dr. Morris. Yes, you can share your screen and you are a co-host. Let me see,
Oh,
I can
thank
see
you.
you. You're welcome.
It says
Okay.
the host has stopped me from sharing videos.
Ah, because you joined again. Let me see. Yeah, you just joined in.
Oh, yeah, that's true. That's true. Because I got rebooted. I'm sorry.
No problem. Okay, I saw you. Yeah.
The computer decided to update. So I'm going to
Update
share
when
my
you're about
screen.
to present, right?
Yeah, exactly.
Okay. That's quick.
That's
Then.
okay. Because
All right. I
Logan
can
and Chloe
see it
here.
now, Dr. Morris. But you don't have a camera, okay? I see the PowerPoint now.
Okay. Let me see. Why is my camera not working?
Yeah, only the camera. I see the
They don't
PowerPoint.
need, I guess they don't need to see me.
You're good.
Oh, there you go. Hi, everyone. So today we are going to present on neuropathy. Thank you for the long introduction. I told Jenny, just tell them, right? Like I was seeing patients the other day, this week actually, right? So I work in the summer, I work in the nursing home, in the outpatient as well as in the ALFs and home health. So I'm co-presenting today, right, with my colleagues from the University of Central Florida and Orlando Health. A lot of people were asking me yesterday, like, where is UCF? UCF is in Orlando. It's one of the Big 12 conference, right? So it is the state university in Orlando, for those of you who are not familiar. Today, we're going to talk about the different types of neuropathy. I know we have a limited time, so we're going to talk about the most common ones that we see in geriatric rehabilitation. So talking about neuropathy, let's do a little bit of a review, right? What is a peripheral neuropathy and what are peripheral nerves? So when we talk about peripheral neuropathy, think about peripheral neuropathy, just like Dr. Youssef said earlier, right? Some of the patients are going to complain of tingling sensations in the hands and the feet. Sometimes some of the patients will complain of tingling in the trunk. But other times, right, there is a motor weakness, right? Weakness of the arms, and weakness of the leg, the hand muscles, the feet muscles. But what I think, if there's one thing that we want you to remember when with regards to neuropathies, there are about 100 types of neuropathies. We do not treat them the same way. They do not have the same clinical presentation. Yes, the nerves are affected, but each of them have their own diagnostic criteria. Each of them has their own clinical track of progression. The symptoms are different from each other. While they're all affect the nerves, think of it as different conditions. There's about 100 of them, and they're not all the same. So when we talk about diabetic neuropathy, we talk about Guillain-Barré syndrome, we talk about chemotherapy-induced neuropathy. While they're all neuropathies, they're not going to present the same way for those individuals, right? Each of the diagnostic categories of neuropathy is different from each other. As a review, right, you look at the brain and the spinal cord. These are your central nervous system. The sensations that we feel on our hands and our feet, right, travels through these peripheral nerves, right? But I think what's important here is that if you look here, right, this is when the nerves are exiting. I think of like C1, C2, C3, C4, C5, and then all the way to the sacral. And then they all join to become the brachial plexus and then separate again to become the individual nerves of our body. And then you think about here, here's your peripheral nerves, but each of the peripheral nerves has three components, right? Two mostly, the sensory component and the motor component. So when the nerves are affected, think that there is going to be some sensory component in some of those types of neuropathies, but other neuropathies may just have a motor component, but some neuropathies might have both. And in the thoracic spine, right, we know that there are the autonomic nerves, right? They join the sensory as well as the motor. So there are also autonomic neuropathies. And I want you to keep that in mind, that neuropathies are not just always sensory, they're not just motor, but they can also be autonomic. So think of the peripheral nervous system. There are 31 pairs of spinal nerves, right? But those 31 pairs of spinal nerves, as they exit, they blend in together to become the brachial plexus, or blend in together towards the lower extremity to become your lumbosacral plexus. But after that, they separate again. So if you look at the map on the left side, a lot of you are familiar because most of you are PTs and PTAs. So when you look at this is a dermatome map. That means that is the spinal nerve coming from one spinal segment, right? Let's say C5. So when you're doing your sensory testing and only the C5 is affected, that means the lesion is around here. It can be a radiculopathy coming out of the C5 nerve root. However, when you look at the right side, this is the map of your peripheral nerves. Our neuropathies, the lesions are usually in the peripheral nerves, right? The lesion is not here, so it's not going to present as a dermatomal pattern. If your patient has neuropathy, and then they're presenting, right, when you're doing your sensory testing, they're presenting as a dermatome, that's probably not a neuropathy. Most likely, the lesion is either in the spinal cord or it is a radiculopathy, right? It's getting trapped in the nerve root. But if your patient, you're doing sensory testing and the mapping shows that, let's say here, the deep peroneal nerve, right? Neuropathies usually affect the distal segment. So if you're doing your sensory testing and it looks like it's the map of a certain nerve, then most likely it truly is a neuropathy, because neuropathies affects the distal nerves, right, as they become their individual nerves versus a radicular symptoms or the spinal segment, which is your dermatome. So not here, but this one. Okay, again, right? When we were talking about neuropathy, yes, you could see, right? If the lesion is here as they exit, right? And if it's a dermatome, then most likely it's going to be a radiculopathy or a lesion in the spinal cord. However, true neuropathies, the lesions will come from the peripheral nerves, either one, more, or symmetrical. So what type of nerves are affected? We know sensory, right? A lot of the neuropathic patients, they complain of sensory symptoms, tingling sensation, right? So we know there's a sensory component. We know that because sensory nerves transmit light touch. And so the patients are going to complain, Dr. Jenny, right? I can't feel my feet, or I have numbness and tingling, or sometimes they get sensitive to cold, like especially the patients with undergoing chemotherapy, right? There's certain medications, there are certain chemotherapy drugs that affects the cold tolerance of the patient. So they're going to complain that their feet are hurting when they're exposed to cold environments. So we shouldn't be giving them cryotherapy, those individuals. And then, of course, the pain, right? They're always complaining of pain. But then again, we talk about motor nerves. So the patient might have an impaired balance. Why is my patient falling? They have neuropathy, right? They have sensory problems because some of the neuropathies, right, affects the motor nerves, the muscles that they supply. And so the patient might have an impaired balance, right? They might have an impaired coordination. They're tripping because the deep peroneal nerve is affected. And then some of the patients don't have sweating, they have dry skin, the autonomic. But also remember, the autonomic nervous system controls breathing, heartbeat, and function, the different function of our glands, right? Just like we said earlier, like sweating. Okay, other types of neuropathy, we think about inherited or acquired. So some patients are born with neuropathy, right? We cannot change those trajectories. Those patients are born. We cannot prevent them. An example is the Charcot-Marie-Tooth disease, right? They both have sensory and motor. Friedreich's ataxia, where the patient has both sensory and motor, but sensory that they have, they lost their proprioception. They don't know where their legs are in space. Giant axonal neuropathy, right? That where the neurons become bigger and bigger and they become impaired because they become like literally a giant axon. And then the most common ones we see, right? Us as geriatric physical therapists, the most common ones we see in the clinic are the acquired peripheral neuropathies, right? So that means patients are not born with it. They can develop it. For patients who are undergoing chemotherapy, 2/3 of those patients will develop a neuropathy. It's called the chemotherapy-induced peripheral neuropathy. And then we have Guillain-Barré syndrome, which Dr. Logan Brown will talk about more. And of course, almost half of our patients in geriatrics have diabetic neuropathy, and Dr. Chloe Artrick will talk about that. But there's also the mechanism of how the axons got injured. There's a couple, right? But we're going to concentrate on two. One of them is demyelinating. So let's review the neurons, right? So here's the cell body, right? Neurons are cells of the central and the peripheral nervous system. So here's the cell body, and here's the axon that transmits the information going into the next neuron or the muscle or the skin. So when you think about demyelinating, that means the lesion will be here on the myelin sheets, not on the axon itself, but the myelins, right? Like, for example, in GBS, right, the demyelinating neuropathies, it attacks the myelins that covers the axons. But then there is another type called axonopathy. So that means in that type of neuropathy, the lesion is in the axon. It's not here, right? It's not on the myelin covering the axon. It's in the axon itself. So why is this important, right? Why are you talking about this, Dr. Rick? Well, the thing is, if it's a demyelinating type of neuropathy, right? This one, it attacks the myelin, it's going to strip the myelin, but then the axon will still be there. So that means it can recover. The symptoms are not going to be as bad versus in this type of neuropathy, if the axons are affected, right? Sometimes the axon don't recover. So it's going to be a slow recovery, or sometimes the patient will not recover at all. They're going to have those permanent neuropathic signs. So it is important to know whether it is a demyelinating type of neuropathy, right, which affects the myelin but does not affect the axon, or it is an axonal neuropathy which affects the axon itself. And sometimes there are worse neuropathies where it affects both the myelin, right, and the axon itself. So that is kind of important to know. When you look at the neuropathy, the first thing you ask yourself, is this demyelinating or axonal? It will tell you whether the patient's going to recover or not. Because when we write the plan of care, if you know the patient's not going to get better, we need to really start compensating. But if you know that the patient has a chance for recovery, then we go focus on rehabilitation. Now, what type of nerves are affected, right? The most common one we see are the gloves and stocking pattern, right? Some most common neuropathies that we see, right? These are called length-dependent neuropathies. That means the farther and the longer the nerves are, the farther they are from the brain, the most distal segments are the ones that are going to be affected first. These are the most common neuropathies that we see. That's why our patients are complaining of tingling of the feet, tingling of the hands. Another interesting thing with this length-dependent neuropathies is that the most distal segments get the most severe signs and symptoms. So the toes and the fingers, right? Those are the ones that will lose sensation. Those are the ones that are going to have cramping before it goes proximally, right? So this is not as bad as the distal segments. So those are your length-dependent neuropathies, which are the most common neuropathies that we see in geriatrics. And Dr. Brown and Dr. Artrip will talk about it. And when we also have the non-length dependent neuropathies, right? It can start around the torso. The patient may say, Dr. Jenny, I can feel something here. I have tingling on my trunk, right? And it can spread in any parts of the body and move around different parts of the body. But remember, the more common one we see are the length-dependent neuropathies. So, right, if there is one image that is easiest to remember, right, this is from Mowerman and Burns. I think this was published in 2021, right, from the Academy of Neurology. There's 100 types of neuropathies, and it's so hard to, as a physical therapist, okay, what type of neuropathy is this? What type of neuropathy is this? But Mowerman and Burns gave us a map, right? It's not 100% follows the rules, but this gives us an understanding. It helps us map out the different types of neuropathies. You're going to look, why? Is this an inherited type of neuropathy? Is this a metabolic type of neuropathy, which is this section? Is it a immune-mediated neuropathy, right? Which is this section, neoplastic, right? Cancer-related, or an infectious type of neuropathy. So you can see as you go towards the right side, these have a rapid progression. So when you're taking the history, if the patient was fine yesterday, they started to become weaker, right, today, and then tomorrow they're in the ICU. Most likely those are the infectious neuropathies or neoplastic or immune-mediated neuropathies. But when you think about the patient said, yeah, I started to become, to have tingling sensations maybe 2 years ago, right? So it's a slow, insidious onset. Then most likely these are your metabolic neuropathies like diabetes, vitamin B12 deficiencies, right? Or the Charcot-Marie-Tooth disease. So here, as you go towards this side, this is more distal, right? And symmetric. This one is probably not distal, but they're most likely symmetric. So this is a good map of how to understand neuropathies, and they're not all the same, right? Neuropathies are not all the same. Another version of that map, right? We talk about the demyelinating neuropathy, where it strips the myelins, but then again, there's a chance that it will recover partially or fully. And then the axonal one, right, which is worse because it destroys the axon and affects the axon, which might have slow progression and does not recover. So when you look at the red neuropathies, those are the demyelinating. So the type 1 Charcot-Marie-Tooth, right? The Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathies. Those are demyelinating, right? Yes, they're going to be worse, but they have a better chance of recovery than the axonal neuropathies, right? So think about the axonal neuropathies, the blue ones, the ones that are caused by syphilis, right? West Nile virus for the infectious disease, right? Hepatitis C. But you also look at the Charcot-Marie-Tooth type 2, the alcohol-related neuropathies, right? B12 deficiencies, they destroy the axon. So if you think about those types of neuropathies. So moving on, we're going to look at one of the most common types of neuropathies. For those of you who are familiar and those of you who are not familiar, who have not had patients with chemotherapy-induced peripheral neuropathy, it's commonly termed as CPIN, right? So if you are dealing with cancer patients, you'll notice some of the cancer patients will tell you, like Dr. Jenny, my hands and my legs, they're tingling. And you're like, well, they never had tingling before the chemotherapy. What is happening, right? When I was a new therapist, I'm like, oh my goodness, why are all my cancer patients complaining of tingling sensation? And then they describe their legs as walking with cinder blocks, right? So the leg feels so heavy. They walk like they have a cinder block. And so they're actually chemotherapy-induced peripheral neuropathy, right? They are caused by when the patient takes chemotherapy, when the cancer patients take chemotherapy, a lot of those patients, 2 out of 3 patients who are undergoing chemotherapy will develop CPIN, the chemo-induced peripheral neuropathy. Right, 1/3 of them might not develop it, but there's always a side effects to cancer treatments, right? When it's radiation, there's an exposure of the healthy cells to the radiation, so they might develop a tumor from those radiation, a secondary tumor, even though the primary tumor is being treated by radiation. The same for chemotherapy. There's going to be side effects for chemotherapy, right? So what is CPIN? It is a damage, right? It is It is a neurotoxic, right? Side effects of some of the chemotherapy drugs. We don't have a choice, right? Because we have to treat the cancer with a chemotherapeutic agent. But remember, they have a side effects, right? Liver toxicity is number one, but the second most common side effects of chemotherapy is neurotoxic, right? It affects the peripheral nervous system, resulting in our patients having neuropathy. Well, how many of my cancer patients undergoing chemotherapy are going to develop a CPIN, right? Dr. Beato, it's going to be 2 out of 3, more than 2/3. Look at that, 68% of patients undergoing chemotherapy are going to have this peripheral neuropathy. There's the lucky 1/3 that will not develop that. But you look at the timeline, right? Like if your patient suddenly had a neuropathy in 3 days, that's probably an infectious neuropathy, like a Guillain-Barré syndrome or chronic inflammatory demyelinating polyneuropathy, right? A chemotherapy after the completion, within the first 30 days, think of your 1 month calendar. Within 1 month calendar, right, the patient will most likely develop CPIN in that 30 calendar days after finishing chemotherapy. So think of 1 month as your timeline for CPIN to appear after they complete the treatment. It is a length-dependent neuropathy, right? We talked about what type of neuropathies earlier, like which are length-dependent and non-length dependent. Length-dependent, again, meaning that it starts on the distal aspect, right? So most likely they're going to complain of the glove and stocking pattern, very similar to GBS. But here, right, which is interesting, the higher the dose, that's why we need to be checking the medication. And I think that's one of the great things about geriatric specialists is that we do look at the medication, especially the home health. You don't have a choice. You have to reconcile the medication. So when you look at the medications, right, the higher the dose of the chemotherapy, the more the symptoms are going to be worse. They're going to be severe, the higher the dose of chemotherapy. And another interesting thing with this type of neuropathy is that, right, it may progress proximally, but we know the distal components are affected first. But before it progresses proximally, right, going into the trunk, most likely it's not going to be the trunk because CPIN usually just stays in the distal segment. The most distal segments will become severe first. So they're going to become worse first, right, before it ascends into the different parts of the legs and the arm. So it becomes worse first, the most distal segments, that's why they're in red, right, before it goes to the proximal areas, which are your yellow. So we talked about sensory, motor, and autonomic, right? Which one is affected first? In CPIN, the sensory, right? Sometimes the patients will not sometimes, oftentimes the patient will talk about sensation, right? The tingling, the numbness, right? They feel like they're walking with cinder blocks because it affects the sensory nerves first. And then with a lot of patients, the motor symptoms will come, the weakness of the legs, the weakness of the arms, those will come as well. I had to drink, sorry. So anyway, so the motor symptoms will be affected as well. What about my patients who had diabetes and now they're undergoing chemotherapy? Or what about my patients that had Guillain-Barré syndrome before and now they have CPIN, right? Because they're undergoing chemotherapy. Well, the patients with pre-existing different type of neuropathy, when they develop the CPIN, it is going to be worse. It's going to be more painful. It's going to be more numb, right? There's going to be more weakness. So the patient has already an existing neuropathy, it is going to be worse, the signs and symptoms. Most likely, some of the patients, right? The literature is it's varying. They said most of the patients will improve or completely resolve. So only 30% will have existing or persisting symptoms. But some literature says 83% will still have remaining symptoms of neuropathy, right? So it could be sensation, it could be motor. But let's talk about chemotherapy, right? So this is why it's important that we review the medications. There are 4 major categories, right? These are not all your chemotherapy drugs, but these are the 4 chemotherapy drugs that has been implicated causing CPIN. Right? We don't have a choice, right? Because the patients need to undergo chemotherapy. The antimicrotubule agents, you can see, right, varying. Like the vinorelbine, it's only 25%. 1 out of 4 will get CPIN. But when you look at the paclitaxel, it's about 60% of patients will develop CPIN. And then you have the platinum compounds, right? You can see 74%. This one, the oxaliplatin. Usually these are the patients that are cold intolerant. So you must really look at the medication. But then the carboplatin, it only 4% will develop CPIN. And then you look at the target targeted therapies, which is about 31 to 55, and then the immunomodulatory agents like your thalidomide, which is about 25 to 83%. So these are the four class of medications of chemotherapy drugs that have been implicated in CPIN. And then when you look at this bigger table coming from the Academy of the Apta Oncology, Academy of Oncologic Physical Therapy, right? You can see those four agents, right? You can see mild to mild numbness and tingling, even lasting 4 to 6 months, decreased sensation, numbness and tingling. All of them will have numbness and tingling. There's weakness, myalgia, muscle cramp, weakness, right? So 3 of them will have weakness. This one would have painful muscles and muscle cramps. And then you can see this list. This is actually, if you go to the Apta Oncology, this is a free resource. You can see all this resources from the Apta Oncology. They are all free for CPIN, right? So please do access them. But remember, there are so many types of neuropathy. And so you must assess, right? Is it a dermatomal pattern? Then that's probably not a neuropathy, right? Or it is a peripheral nerve pattern. So you look at the pattern of presentation, you look at the timing of onset, right? Within 30 days, right? Then most likely, right, it is going to be CPIN. Progression of the symptoms, is it just 2 days or 3 days, right? Those are the fast neuropathies, the infectious ones, and the neoplastic. So they're not caused by chemotherapy. And the list of drugs, right? You look at the drugs. Well, if it's none of those 4 agents, right, most likely there are other causes of the neuropathy. So you ask the patient what their subjective complaint is. Sensory, right? There's numbness or tingling, which is similar to other neuropathies, fingers and toes. There's going to be pain, right? Some of the neuropathies will be painful, and CPIN is one of them. The difference, though, that as a physical therapist and PTAs, right, you have to make sure to pay attention to the symptoms. If the patient is only complaining of pain in the hands and not the legs, remember, this is a length-dependent neuropathy, so the legs should be affected. If the hands are the only one that's painful, then maybe you should do a differential diagnosis. Maybe it's not CPIN. Maybe it's not the chemotherapy drugs causing the pain. It might be arthralgia, right, coming from arthritis, or myalgia, right, be pain coming from the muscle and not from the chemotherapy drug. So it should be both legs and hands when they complain about pain, and not just the hand. If it's just the hand, then maybe you should do more differential diagnosis. So we support doing differential diagnosis. What about the motor components? Well, it is a symmetrical neuropathy. That means the weakness of the left will also be presented on the right, right? And it will be the distal muscles. It should be the hands and the feet muscles that are affected first. Well, we're like, well, the shoulder muscles started to become weak after the chemotherapy or after some of the medication. Well, it might not be the chemotherapy drugs, right? If there are proximal muscle weakness first, it might be caused by steroids, right? Sometimes there are patients in oncology rehab get a lot of steroids, and so it might be a steroid-related myopathy. What happens if it's just unilateral weakness of one arm or one leg? Well, you have to do a differential diagnosis. Probably it's not CPIN because it's a symmetrical, right? Both sides weakness, right? It could be a tumor of the brain or the spinal cord, right? So it will be a central nervous system. So the tumor might be here, not the neuropathy here. And so when you're testing, there's going to be an increased reflex, hyperreflexia, because it's the spinal cord, versus a lower motor neuron lesion. When you test the deep tendon reflex, there's going to be hyporeflexia. So if it's hyperreflexia, most likely it's a central lesion. And then it might be, if it's just one side, it might be a tumor of the brachial plexus or the lumbosacral plexus. Because remember, CPINs need to be both sides because it is a symmetric neuropathy. So for assessment, there are a lot of available tools. If you want to assess the pain, you can use the Dolor Neuropathic 4 or the Self-Report Leads Assessment of Neuropathic Symptoms, the SLANS, if your concentration is pain. What if you want to concentrate on the activities? How does the neuropathy affect the activities of the patient and their participation, right? They're causing participation restriction. It affects the social participation of the patient. Well, there is a validated tool. It's called the CPIN-NAT. So chemotherapy-induced peripheral neuropathy assessment tool. So the CPIN-NAT will tell you how much of the neuropathy is affecting the daily life of the patient. I like that tool. But there's also other neuropathy measures. You really want to see the whole picture of how the neuropathy is affecting the life of the patient. So this one, right, you can use the modified total neuropathy score, the total neuropathy score clinical version, and the 5-item reduced total neuropathy score. For the motor components, it will affect the balance, right? So the apto-oncology gives us the list of the measures that we can use. The TUG, the Balance Evaluation Systems Test. This is quite long though, and the short physical performance battery. It also gives us the BERG, the ABC, the 5 times sit to stand. Neuropathic patients can be considered, right? Peripheral nervous system pathology. So we know that the core outcome measures from the Academy of Neurologic Physical Therapy recommends to use BERG, the ABC scale for their balance confidence, and then for transfers, the 5 times sit to stand, as well as lower extremity strength. So, but you can use any of that according to the APTA oncology. Intervention, right? So what do I do now that my patient has neuropathy, right? Well, you have to remember the patient will have decreased touch threshold. They're not going to feel a lot of things, right? Similar to patients with diabetic neuropathy as well as leprosy, right? There's going to be impaired touch. The temperature is also going to be impaired. You look at the medication, oxaliplatin. If your patient has a chemotherapy drug, oxaliplatin, they are going to be hypersensitive to the cold. So you must not use cryotherapy, the mouth, the throat, the hands, right? So don't give them too cold of a drink, and don't give them cryotherapy, and maybe treat them in a room temperature where it's not colder, because those patients are going to be sensitive to cold. So self-care tips to avoid and protect from the cold within hours of the infusion of oxaliplatin, because those are the temperature-based ones. So what are these? The infrared ones. For those of you who have not seen it, but probably the home health therapists have seen this used. They are little infrared lamps, right? They're called monochromatic infrared photo energy, and you wrap it in the patient's leg. It increases the circulation. When I was a newer therapist, I was like, what is this? Why is the infrared lamp being wrapped on the leg instead of being focused on the leg? With a certain distance. But the literature is actually supporting that it improves neuropathic pain, it improves their touch sensation, and eventually improves their balance, right? So this actually has literature to support that the infrared wrapping on the legs, the monochromatic infrared photo energy, improves the patient's pain as well as the threshold for touch. Looking at low-level laser therapy, which are being used in outpatient orthopedics, they can actually improve the patient's hypersensitivity to touch and cold, so they can tolerate touch sensations and cold sensations in those patients taking the oxaliplatin medication. What if my patients have cramps, right, of the calves and intrinsic muscles? You can use night splints. Night splints has shown that it can be effective in controlling the symptoms of cramps, as well as unrelenting somatosensory complaints like pain, crawling sensations at night. So splinting can help relieve the symptoms a little bit. Randomized controlled trials, right? Here's your pyramid of evidence, right? In this study, there were 50 people studied. They were divided into endurance and balance exercise, and then the control group, which is just balance exercise. What they did is twice a week of physical therapy for 12 weeks. That's very doable, especially if you're in home health or outpatient, 2 times a week. And the nursing home, then you can see the patients a little bit more frequent. But 12 weeks, twice a week, one group received both endurance and balance exercise. So your aerobic exercise, your endurance, that could be walking, could be cycling, and then the balance exercise. And let's see what happened. The endurance and balance group, right, they improved their symptoms. They said their neuropathy improved, and the balance group as well, right? They both have improvements, and their sensation improved. They're not as tingly anymore for both endurance and balance. And then look at the balance and endurance group. Those who did balance exercise and aerobic exercise, right? Their balance got better, right? Their semi-tandem stance got better. Their single leg standing on a foam got better, right? For those who did balance and endurance exercise on an unstable surface. They decreased their motor symptoms, so they got stronger a little bit. Their maximum power output also got better. But let's take a look at the balance group. Did they improve with the other categories? Well, they didn't improve in these aspects, right, compared to the balance and endurance group. But in here, sorry, this is not balance. This should be endurance. So correct that one. So the endurance group, they can sense the vibration a little bit better, right, than the balance and endurance group. And they even have a higher jump height. So the endurance group, right, they also got better, but for vibration and jumping height, compared to the balance and endurance group, which improved in a lot of the balance categories. This one is just a systematic review of 5 different studies, so higher level of evidence, 3 high qualities, 2 low qualities. They look at the different types of exercise we use in physical therapy: endurance, strength, right? And then the sensory motor exercise. Those are like standing in the foam, standing on different surface. What they found out is that all these types of exercise, endurance, sensory motor, the things that we do in physical therapy, they improve the posture, they improve the quality of life, especially the strength exercise, they improve upper body strength and lower body strength. But what they saw is that if we combine endurance, strength, and sensory motor, the improvements were much larger than if we use just one of these components alone. So yes, we can use endurance exercise, your biking, your walking, exercise, your new step exercises, right? The strength exercise and sensory motor, right? Training them on the different surfaces. And of course, the wonderful resistance training, right? We want to make sure that we're actually giving them the right amount of resistance. So any of those exercises will improve your CPIN, and those modalities will also improve the signs and symptoms of patients with CPIN. And that's it for CPIN. I am going to give this to Dr. Brown and Dr. Archer to talk about the other types of neuropathy. If you have questions for CPIN and the other neuropathies, just type it on the chat and I'll answer it. Thank you.
Thanks, Dr. Rick. Yes, let's see. So Dr. Logan is the next speaker. All right. And then the QA will be later, right?
Yes, they can just type it.
Okay,
They can type
guys.
it on the thing and they'll
So
answer it.
we have already a few chat questions there. So that will be Dr. Morris for that, and then Dr. Logan will be our next speaker. Okay. Would love to introduce them quickly. Okay. All right. So Dr. Logan, so let me see. All right. Let me check. Would love to introduce you and Dr. Chloe as well in between.
Thank you.
All right. Thank you. So let me see. Thank you so much, Dr. Morris. And this is another certificate of appreciation for you. That's really nice. I'm learning more. I didn't know that the CPIN is the main term for that. And majority of our chemo patients, that's one of their main concerns. So thank you for sharing your knowledge about neuropathy here in the Geriatric Rehab Summit 2024. We're always learning great things from you. We really appreciate you so much. So I just put here demystifying neuropathy because it's still we have neuropathy with Dr. Chloe and Dr. Logan. So we have Dr. Logan Brown today for our continued discussion, and we will learn more about diabetic retinopathy, and I think he will have a different topic about that too. But who's Dr. Logan? Dr. Brown works as a member of Orlando Health's neurologic rehab team. His experience includes the Advanced Rehab Institute's Neurodegenerative Diseases and Movement Disorders Clinic, the Orlando Regional Medical Center Level 1 Trauma Center, and the Inpatient Rehab's Brain Injury and Spinal Cord Injury Program. He received his bachelor's degree in health sciences at the University of Central Florida, where they all work together. He completed his Doctor of Physical Therapy from University of South Florida. And Dr. Logan is a communications officer for the Academy of Neurologic PT Degenerative Disease Special Interest Group. That's amazing. His clinical experience includes being a resident of the UCF and Orlando Health's Neuro Residency Program. He served as an adjunct faculty member for the neuro-based courses in the UCF DPT program. You know that it's the University of Central Florida. Dr. Logan, nice to meet you and so excited to hear from you. Go ahead, and you are already a co-host.
Yes, thank you for the introduction. Nice to meet you as well.
Yes, my pleasure.
Let me just get the presentation pulled up. Okay. Are you able to see this full screen?
Yes.
Perfect. So to carry on what Dr. Beato started, we're now going to discuss neuropathy, but neuropathy following Guillain-Barré syndrome infection. So starting off with history, as Dr. Beato mentioned with that summary slide, it is an immune-mediated polyneuropathy. So with Guillain-Barré, it is impacting, again, the peripheral nervous system. And even though it is considered immune mediated, it is often preceded by a viral or bacterial infection. So typically, the most common that you'll see is a gastrointestinal or respiratory infection, typically about 2 weeks prior to the onset of their GBS, but it can be more acute than that. And then the progression of the disease is expected to worsen within the first 2 to 4 weeks until they reach a plateau of severity, and they then start their functional recovery from that period. As far as the symptom profile goes for these patients, they do experience progressive ascending motor and or sensory impairment. Symptoms can range anything from a very mild weakness to total flaccidity of the limbs. Additional to the motor and sensory impairments, you can also see respiratory complications, even requiring ventilation. You can see cranial nerve dysfunction that presents like a Bell's palsy, autonomic dysfunction, and then a lowered fatigue threshold. And then, as Dr. Beato summarized and mentioned, that typically GBS is a demyelinating disease that's going to impact the myelin sheath specifically, but there are axonal variants of GBS as well. So just like he mentioned, it's really important to consider when framing your plan of care, which variant of GBS your patient was formally diagnosed with, as that can impact their expectations for their timeline of recovery. Looking at epidemiology, who's impacted, why does this matter? As far as general population worldwide, it's anywhere from 1 to 6 people per 100,000. It can occur at any age, any period of the lifetime, but it is most common in individuals greater than 50 years old. Looking at the prognosis for patients diagnosed with GBS, because most of the cases are that demyelinating form, about 80% do experience a full functional recovery, but we'll be looking at more of that residual disability, which is around 20% of people who do experience residual deficits. And that's ranging from anything from weakness and fatigue that impact their daily function, their walking, their transfers. And then, of course, we'll focus on that neuropathic pain aspect. I wanted to mention things that are associated with a less favorable prognosis, and we'll talk about this a little bit further. But things like an initial incidence of diarrhea, as we know, this can be associated with gastrointestinal preceding infection, requiring mechanical ventilation in the acute phase. And literature suggests that having an age greater than 60 to 70 years old is also leads to a less favorable prognosis. So looking again at the temporal pattern with GBS, that acute phase is where you're going to see the ascending motor and sensory progression of symptoms, again, ranging from mild weakness to full flaccidity. And as it does progress more proximal, this is where you can start to see the respiratory complications as well. Again, typically by the 4th week is when patients will reach the nadir, which is maximum severity of the symptom progression, and that is considered then the plateau of their symptoms. And from there, they will start kind of the descending recovery phase as they start to regain some function. As far as physical therapy assessment, looking at specific validated outcome measures or scales more so to use with these patients. There are 3 main ones that you'll see in the literature. The first one is this Guillain-Barré syndrome disability scale. So you rate it from 0 to 6th as far as their functional abilities. So 0 being normal, the slight clinical symptoms, then looking at their ambulation ability to being bedridden, and again, ventilator dependence. The Erasmus score is another outcome measure that they look at. And this is again looking at the severity of their GBS. So it considers age, it considers if they had diarrhea present or not, and then their disability score, which is including that previous scale. And then the modified EGOS is again kind of combining these scales where it looks at age in the presence of diarrhea again. And then it also considers the muscle scoring, which is that MRC score for key muscle groups. The Erasmus score does help predict the ability to ambulate independently at 6 months. And then the modified EGOS has been shown to predict ambulatory ability at 4 weeks, 3 months, and 6 months, prospectively in the literature. When looking at our assessment, again, we want to assess and treat the impairments that are present because each patient is going to present a little differently. So just conducting a comprehensive exam, as we know. So looking at sensation, the light touch, proprioception, protective sensation. Again, this is a very common population with the sensory involvement that you'll hear them describe their legs as feeling, I just feel like I have bricks at the end of my legs. They're so heavy to carry. I get so tired when I walk. Again, cranial nerve involvement, muscle function and strength, functional mobility and balance. And like Dr. Beato mentioned, the core outcome measures as described by the Academy of Neurologic PT can be used for peripheral neuropathy. It is less common to find these recommended MCIDs for Guillain-Barré just because there is a lack of literature with Guillain-Barré. But some studies do suggest an MCID of 10 for the Berg scale if you're considering, again, that plan of care and goal writing for these patients. So moving into what we all want to hear about, which is kind of how can we help? And this is specifically going to be looking at some physical therapy modalities. Current literature does already support the use of physical therapy rehabilitation for patients with Guillain-Barré, especially a multidiscipline rehab center. So kind of looking at what modalities could be used to help the neuropathic pain symptoms that they experience. So starting with this first study, this was conducted in 2019, basically looking at the feasibility, safety, and effect of NMES on muscle atrophy in the acute phase of GBS. So there's 17 participants in this study. They tried to get them within a 2-week onset of their diagnosis. And with the intervention, they randomly assigned NMES to the left or right quadriceps, and they spent 40 minutes applying the NMES every weekday during the admission, and then it gives their parameters as well for treatment. When looking at this, they did a median time of participation of 27 days, and for the stimulation, 17 days. As far as their results, they looked at that GBS disability score. So baseline started at 3.6 and post-treatment was at 2.7. To look at the effects of NMES on muscle atrophy, they used ultrasound to look at the quad cross-sectional area. And then they also used the Biodex dynamometer to look at the maximal isometric muscle strength. So from the control side to the treatment side, they did see positive changes for both. The clinical bottom line from the study that they discussed was that NMES appeared to be safe, well-tolerated, and feasible, and noting that this should be an adjunct, again, to standard rehab in the acute and subacute phase, just as Dr. Beato was mentioning with balance training and other functional skills. The next study we'll look at is percutaneous nerve stimulation. This was a case report. Again, literature of GBS is kind of lacking globally, so there aren't always the highest level systematic reviews, but anything you can get is definitely useful. This specific case was a 22-year-old male that presented with subacute progressive quadriparesis. They did require ventilation, had dysautonomia, and intractable neuropathic pain. They're 22 years old again. This was from 2020. For this, they implanted that temporary PNS device. It was 2 weeks after the official diagnosis, and they had received the typical pharmacotherapies, which include usually the IVIG antibodies, as well as plasmapheresis and steroid therapies. They implanted these devices bilaterally around the sciatic nerves, femoral nerve, and brachial plexi, and then they tracked the results of this. So they used a global impression of change scale, looking at the results of neuropathic pain specifically. So they looked at four main things: the number of pain meds that were required by the patient, the pain interference scale, a neuropathic pain rating scale, and then motor deficits, again, using that MC or MRC score through manual muscle testing. So with this, they saw that by day one, that the patient was utilizing 33% less of their medication. And then by day 21, they were utilizing 76% less of their medications. That pain interference scale decreased from 8.6 to 1.4. And then their pain rating scale decreased from 7 out of 10 to 1 out of 10. And then their motor deficits increasing for cervical, upper extremity, and lower extremity. The clinical bottom line, again, for this study, this one more invasive than NMES or a TENS unit, but still minimally invasive, temporary, and reversible. This again should be used in conjunction with typical recommended IVIG and plasmapheresis, but they suggest that it could be used as an alternative to opioid-related medications, and that it did provide an immediate alleviation of pain when they initiated this. And this final main study, again, being a case report, this was on a 52-year-old male post-COVID-19 that actually had an overlap of a GBS and acute transverse myelitis. This was from this year, and it was conducted in an outpatient setting 4 weeks after their diagnosis. So with this, the patient presented with prominent paraparesis of the lower extremities, sensory disorders in the legs and hands, as well as bladder and bowel dysfunction. Their inpatient treatment included intravenous immunoglobulin therapy, plasma exchange, and standard pharmacotherapy. The TENS therapy was started 61 days after onset of the disease and 32 days after their plasma exchange. So they did try to apply a high-frequency TENS as well as low-frequency TENS, 40 minutes for 30 sessions. So this is showing the electrode placement that they chose. They did bilateral peroneal and tibial nerves, bilateral median and ulnar nerves, and they alternated the upper extremity and lower extremity every day, so 15 sessions each, considering they had 30 total. When looking at the results, they looked at motor deficits, they looked at the decreased sensation as rated by the patient, just on a 10-point Likert scale, a neuropathic pain rating scale, and then a bowel dysfunction rating scale. So I thought what was most significant about this was the patient rated their decreased sensation on baseline as a 10 out of 10 loss on the right lower extremity and 7 out of 10 loss on the left lower extremity. And after using this TENS unit, they reduced that to 5 out of 10 and 3 out of 10. Additionally, with this, you can see that the lower extremity manual muscle average score did increase, as well as their neuropathic pain rating scale. Clinical bottom line from this study was seeing that there was a high efficacy of use for TENS with this patient population. It appears to be safe. They didn't know any adverse effects of using the TENS unit. They did, of course, continue to recommend to use it in conjunction with pharmacologic management, as this patient had already received IVIG and plasmapheresis. So, kind of to summarize, the purpose of these studies just hope to show that physical therapy modalities can be safe and effective in reducing the disability when used in conjunction with medical management, and of course, still recommending typical physical therapy intervention for balance and functional training. And of course, just wanting to note that clearly further research is needed specifically with persons diagnosed with Guillain-Barré syndrome, especially what can be safe in that acute setting, as we know that typically functional mobility while they're worsening is not recommended. So what interventions can we use to help as they go through their recovery and prognosis?
Thank you, Dr. Logan. All right, so those are the references that you showed the last part, right? Yes, yes.
Yes.
Okay. Because you're muted on the last part. I thought you're
Sorry.
Yes, yes. Thank you so much, guys. So if you have any questions, you can put it there or you can ask Dr. Logan right now, definitely. So we saw majority also in even in acute setting, Dr. Logan, some patients with GBS in acute rehab. I work in acute rehab and I see some of those sensory deficits and then those things. So these are really great to add more skills for us, what to use, what to do whenever they are challenged with that. All right. So guys, please write some questions there if you have any questions, but definitely we would love to say thank you to Dr. Logan. Definitely, that's really amazing to learn more about you, and you're also part of the in the neurologic PT degenerative disease too. So that's really good. So we're learning more and more, and thank you. We would love to present this certification, a certificate of appreciation, Dr. Logan Brown, and for sharing your knowledge and expertise in the Geriatric Rehab Summit 2024 5th annual event. Today, August 17, live in Delaware. All right. I know you're in Florida, or am I right? So I
Thank you
know
so
you're in
much.
Florida. You are welcome. Thank you. We appreciate you. All right. And to continue neuropathy and Dr. Chloe, we're going to discuss, I believe, the diabetic neuropathy, and more than 50% we have that in geriatrics. So who's Dr. Chloe Artrick? Dr. Chloe Artrick works as a member of Orlando Health's neurologic rehab team. Her experience includes the Orlando Health Advanced Rehab Institute Brain Injury and Spinal Cord Injury Program, Orlando Health Neurodegenerative Disorders and Movement Disorders Clinic, and the Orlando Regional Medical Center Level 1 Trauma Center. Wow! She received her bachelor's degree in health sciences at University of Central Florida. She completed her Doctor of Physical Therapy from the UCF School of Kinesiology and Rehab Sciences. Beauty and brain, look, this beauty is just like celebrity already, right, guys? So her clinical experience includes being a resident of the UCF and Orlando Health's Neuro Residency Program. She is selected as the recipient of the Academy of Neurophysical Therapies Federal Advocacy Grant for Neurologic Residents and serve as an adjunct faculty member for the neurologic-based courses in University of Central Florida DPT program. Wow, that's a really amazing at a young age, Dr. Artrip. Thank you and welcome to Geriatric Rehab Summit. All right, so let me see, where are you, Dr. Chloe? And I believe you're already a co-host.
Yes, can you see me? I'm
Okay.
sharing.
Yes.
Hi.
Hi. All right, go ahead. And let me
Very
see.
nice. I was gonna say, nice to be here. I'm just going to pull up my presentation now. Okay, can you guys see my screen?
Yes, we can.
Beautiful, thank you. Okay, so I'm going to be presenting on diabetic neuropathy, and there's going to be some overlap from what Dr. Beato was sharing earlier. This might be one of our more familiar neuropathies. So just to kind of go over some epidemiology, as you guys know, this is very prevalent. You can't escape diabetes in any setting that you treat, any population that you're going to treat. This is information from the American Diabetes Association. The most recent information was taken in 2021. So about 11.6% of the population in the US has been diagnosed with diabetes. 1.2 million Americans continue to be diagnosed each year. And prediabetes is huge as well. 97.6 million Americans starting at ages 18 and above are diagnosed with prediabetes. And this comes at a huge cost for healthcare dollars in the US. Diabetic care and for these patients account for 1 in every 4 healthcare dollars in the US every year. So just a little bit background knowledge behind diabetic neuropathy specifically. I know it can get a little dense with the picture that I have there on the right, but it doesn't just affect the blood vessels, it also affects the nerves. And this is due to the formation of glycation end products. It creates a lot of inflammatory cytokines, a lot of inflammation in the body. This can also lead to oxidative stress. So this is going to damage the actual axon, the Schwann cells, the myelin, the glia, and their vessels around the entire nervous system. So there's multiple types of diabetic neuropathy. Most commonly known is peripheral neuropathy, but it also can give you focal neuropathy, and less commonly thought about, I believe, is autonomic neuropathy and retinopathy. And here's just a little depiction of the different types. So starting with focal diabetic neuropathy, it can actually affect the cranial nerves. Most commonly, if it's going to affect the cranial nerves, you'll see it in maybe like cranial nerves from 3 to 6. So it's going to be those ocular eye muscles. And that can cause things like double vision. It can also affect your peripheral nerves, such as your gives you femoral neuropathy. It can affect the nerves in your thoracic and lumbar spine, your peroneal nerve, which will give you that classic foot drop presentation. And it can also give you compression mononeuropathy, aka carpal tunnel, looking at the median nerve. And then the chronic sensory motor neuropathy, so more classically, the diabetic polyneuropathy. And this is going to be that glove and stocking classic presentation. Some early signs and symptoms might consist of burning, tingling, pain, but also weakness, specifically as it relates to the foot intrinsics, the dorsiflexors, that glove and stocking distribution, as I already mentioned, but it's not just touch sensation. It also affects temperature, it affects vibration and proprioception, which are all super important to prevent falls, and we need those. It can lead to swollen feet, loss of muscle tone in the hands and the feet, loss of ankle reflexes, and balance deficits due to everything I listed above. So just some sequelae after being diagnosed with diabetic polyneuropathy. Once you're diagnosed with the neuropathy aspect specifically, it increases your incidence of developing a foot ulcer from less than 1% all the way up to 7%. And 60% of the amputations in the US are actually attributed to diabetic foot ulcers. Falls, as I mentioned, due to the decreased sensation in the feet, proprioception, ankle and foot muscle strength, puts our older adults already at a larger risk for falls. And then something else not as commonly thought about is Charcot's joint, which is termed neuropathic arthropathy. So due to the loss of the sensation in the feet and that loss of the intrinsic foot muscles, the ankle muscles, which really support our entire ankle system, over time, this is something that happens chronically over time. Joints grind on the bone. This causes more inflammation, and eventually the foot structure can collapse and you'll see bone breakdown. As you can see on the bottom right of my screen at the end, that's kind of the foot deformity that you would see. And you can also see this in Charcot-Marie-Tooth disease. And then the less commonly talked about, but so important, is autonomic neuropathy. So cardiovascular autonomic neuropathy, or termed CAN, can increase the risk of exercise-induced injury or adverse events through decreased cardiac responsiveness to exercise, postural hypotension, impaired thermoregulation, and a greater susceptibility to hypoglycemia following exercise. It can present as reduced variability in heart rate and also have resting tachycardia in the early phases, which underlines why they're having the reduced exercise tolerance. Later stages of CAN can involve sympathetic denervation, and this will cause dysregulation in your hemodynamic systems, and more importantly, it's causing silent myocardial ischemia. And because of that, CAN is an independent risk factor for cardiovascular death. The macrovascular changes can lead to coronary artery disease, atherosclerosis, ultimately heart failure, and stroke down the line. So that's why it's really, really important that our diabetic patients are getting a cardiac investigation, just sending them to a cardiologist, making sure that they're up to date on all of their testing. And if they have severe, prolonged chronic diabetes, the American Diabetes Association definitely suggests that having a formal cardiac evaluation prior to undergoing any kind of physical activity that's more than they're used to is really important, because many patients may not even be aware that this is a thing. And the autonomic neuropathy can also affect your GI system and your bladder. So within your GI system, it's going to present as constipation or diarrhea. It can present as swallowing issues, fecal incontinence. With your bladder, it can damage the nerves around the bladder, which leads to issues with feeling that sensation of total voiding and hence frequent UTIs. So educating our patients on the signs and symptoms of UTIs so that they can catch things early is super important, because we all know what can happen after an untreated UTI. So especially within this patient population, just kind of gauging what their knowledge is around that and educating them if they're not educated already. And diabetic retinopathy. So the hyperglycemia, the free-floating glucose in our blood, can damage the little blood vessels in our retina, and that over time will cause those blood vessels to become stenotic, and that damages the blood vessels. And then when they try to heal and they sprout new blood vessels, those can be damaged. And when they're damaged, those can leak fluid into the eye. And this over time can lead to scar tissue. And most diabetic patients additionally have hypertension that adds to this. Over time, it can lead to very serious consequences such as retinal detachment and/or permanent blindness. So what are some considerations when we're treating these patients in the clinic? So for autonomic neuropathy, and for all patients really, but vitals are vital. So even in outpatient ortho general clinics, it's super important to be taking, our vitals maybe before, in the middle, and at minimum before and after. Noticing if there's any undiagnosed high blood pressure, changes in heart rate variability, so that we can refer appropriately so things can be caught and treated early as possible. Also, exercising in temperature controlled environments is very important for autonomic neuropathy. In regards to retinopathy, the American Diabetes Association exercises caution with any exercises that are heavy lifting, cause heavy straining, the Valsalva maneuver, isometric exercises, jarring high impact activities, or any activities where the head is below the waist. Specifically thinking about our older adults who are more at high risk for things like BPPV, and putting them in the Epley maneuver where their head has to be below neutral. That could increase that pressure in those blood vessels and in your blood pressure in general. So they recommend wanting to educate your patients on doing more low impact activities. So water aerobics is great, cycling is great, walking is great. And I actually had a patient, I treat a lot of concussion patients, a lot of which are also older adults from car accidents or falls. And I had a patient who had a long history of type 2 diabetes and actually diagnosed retinopathy. So that was helpful that it came up in the chart. And coming in, she had headaches. It was behind the eye, which is very classic for a concussion patient in general. But she was also having vision changes, which can be related to concussion as well, but she was seeing dark spots. So because of the diagnosis of diabetes and retinopathy, I referred her to an ophthalmologist right away because part of my treatment would be a graded exercise program. And lo and behold, she actually had early stages of retinal detachment and had to have surgery. So the American Diabetes Association does recommend, prior to engaging in intense exercise, they might need to consult with an ophthalmologist, especially if they already have the diagnosis of retinopathy. So some just general exercise guidelines with your diabetic patients. These are, very general, even with our general public, the 150 to 300 minutes of moderate exercise per week, 75 to 150 minutes of vigorous and aerobic exercise, plus resistive strength training, twice a week, is super important to educate, to get our diabetic patients, especially those with neuropathy, on a regimented exercise plan as soon as possible. Studies have shown that even just moderate intensity walking every day would not lead to an increased risk for foot ulcers or re-ulceration with those with peripheral neuropathy, as long as they have the proper footwear. And with that, with our patients that have loss of proprioception in the feet, decreased kinesthetic awareness, when we're doing our gait assessment, important to just make sure that whatever exercise that they're going to be doing is safe and not going to put anyone at risk for increased skin breakdown. So proper footwear is super important. There was also a study that looked at structured exercise interventions for at least 8 weeks, has been shown to decrease your A1C by 66% in those with type 2 diabetes, even without a significant change in their BMI. So even just moderate exercise a couple times a week can make a really big difference. And so these are like the general exercise guidelines when it comes to glucose levels. I'm not going to read the entire chart, but just to kind of sum this up, if your patient is between 90 and 100 milligrams of glucose, they need a carb snack before initiating any activity. If they're between 150 to 250, they're safe to exercise, but it's not recommended to have any carbohydrates consumed until their glucose does go below 150. And then anything above 250, you're going to want to have them test for ketones. So realistically, in a therapeutic setting, you probably would not be exercising them until their glucose has decreased or referred out. And this is a nice little infographic that kind of summarizes that information. So some assessment considerations as it relates to physical therapy, always doing an INTEG assessment, just general, making sure that we are checking the entire foot out for any areas of redness or rubbing or foot deformities, and making sure that they're having proper accommodative footwear so they're not at a higher risk for skin breakdown. Protective sensation, utilizing the 5.07 Weinstein monofilament, and vibration. So using an 120 hertz tuning fork. The test for vibration loss with the tuning fork, you would test from the distal hallux first initially. They can't feel it. You keep going proximally to map out where they're not able to feel the vibration again. It's just to know, as soon as there's vibration loss proximal to the ankle, it's possible that the motor neuropathy is also progressing proximally. Making sure that we are also assessing reflexes, since it can affect our ankle reflexes, your general MMT with your foot and ankle considerations. Your general balance assessment is super important since it can affect proprioception. Maybe we're working on compensating the other two balance systems, strengthening the use of vision, or more importantly, their vestibular system. And then cardiovascular, which I already kind of touched about earlier. And then outcome measures. So this is a screening tool. It's called the Michigan Diabetic Neuropathy Score. It can be administered from any healthcare provider. I put a screenshot of the physical assessment portion. So part 1 is a 15 part or 15 question self-administered yes or no on foot sensation. It includes questions about pain, numbness, temperature, sensitivity. And then part 2 is your physical examination, where you are looking at their vibration sense, their reflex test, and the monofilament test. This is free. You can find it online. It's a very accessible PDF, and it might be a useful tool if your patient has diabetes, is not yet diagnosed with neuropathy, to kind of provide when you refer them back to their physician. And some interventions. So there was a systematic review and meta-analysis. It had 41 random control trials, and it looked at multiple types of neuropathy. So 27 of those studies, which consisted of over 1,000 patients, were for diabetic polyneuropathy. 9 studies was for the CPIN, as Dr. Beato talked about earlier, and then it just listed all other neuropathies for the 5 studies. And the quality of these studies were from moderate to high. And the intervention, so now I'm just looking specifically at the diabetic polyneuropathy interventions. So 15 of the studies included 8 included endurance only, 2 were combined endurance and strength, 3 were just resistive, and then 2, to my surprise, were whole body vibration. And so the duration of the interventions, they range anywhere from 3 weeks to 12 weeks. And most studies were 2 to 3 times a week for 8 to 12 weeks. So that's very doable in most of our outpatient ortho clinics or home health or in our skilled nursing facilities to get in a week of these types of exercises. So I provided a chart of, this was from the study that had the actual interventions. So like the type of exercises, and then if you were interested, I do list it in my references for you to go back to the individual RCTs to look up the physical parameters. So there's resistance training. It was one study that looked specifically at hand, finger, and foot exercises. In the aerobic exercises, most of them did consist of moderate intensity, that 40 to 60% of your heart rate reserve. And then just some more of the study interventions. So this was the results of the entire systematic review. So they found that sensory motor training alone did increase and improve balance. Their outcomes were sway paths, monopedal stance, so single leg stance, the Berg balance scale, and the tug. Balance training plus another intervention that they listed as either being gait, whole body vibration, or resistive training did increase their center of pressure, their single leg stance, and improved scores on the functional reach test, on the timed up and go, vibration perception, which we learned is very important, gait speed, and older adults' fear of falling. Whole body vibration, to my surprise, there's actually good literature to support this. Timed up and go, it improved the 5 times sit to stand, the Berg. It increased strength for the anterior tib and the quads, and actually decreased HbA1c. And the studies that looked at endurance training of moderate intensity, so 40 to 70% of their heart rate reserve, those decreased the HbA1c, the fasting glucose levels. It improved their neuropathic pain and symptom severity, which is important. It improved their vibration perception, improved their quality of life. When they looked at endurance plus strength training, it enhanced their epidermal nerve fiber density and increased their treadmill test duration. And for resistive training alone, there just wasn't enough data to make a definitive conclusion, but the other interventions that included the resistive training demonstrates improvement in balance and overall functional mobility. So the big key takeaway is for diabetic polyneuropathy, a combination of endurance and sensory motor training is going to be the most beneficial for your patients. And then something else I found was a systematic review looking at low-level laser therapy for patients with painful diabetic polyneuropathy. It's fairly recent. It was done in 2019. They started with 627 studies. They ended up with 6. And the interventions, they also ranged a little bit. The wavelength in most of the studies ranged from 800 to 900 nanometers for a duration of 10 days to 4 weeks. The outcome measures, they all looked at the difference in their pain scores, the nerve conduction velocity test, and quality of life questionnaire. And this is a chart of just some of the specific parameters and the energy settings that they used for the low-level laser. And the results of this study found that evidence obtained shows that low-level laser has a positive effect in controlling diabetic neuropathic pain with moderate efficacy. But the limitations, they listed that there needs to be more research on the neuron-specific proteins and the angiogenesis with larger double-blind randomized controlled trials to kind of confirm their findings. And so moving on to the education piece with diabetic neuropathy patients. So exercise guidelines, as I mentioned, it's so important to start them on a structured exercise program as soon as possible. And do they actually understand the like the cause and effect of what's going to happen if they don't manage their blood glucose levels with exercise and lifestyle changes? Like, do they understand the implications of that? They might not. So it's a really good entry point, especially when sometimes they're coming in to see a physical therapist, like in an outpatient setting, and they may have not seen their primary in a year or two, because now we have direct access in most states. A daily skin assessment, telling them to actually check between their toes, use a mirror, a handheld mirror, if they can't physically reach down, especially for some of our older adults. Wound care management, proper footwear, and fall prevention. So the things we're already good at: home modification, balance, setting up an HEP, and things like that. And that is it. And here is my contact if you have any specific questions, and my references.
Wonderful. Thank you so much, Dr. Chloe. That's really very straight to the point, as what Dr. Frecci said. Great presentation. So guys, if you have any question, we have the chat, and definitely they can check on that. We have a break after this. That's your lunch break if you're US based, and of course in Philippines if you're having some nighttime break too. Dr. Chloe, thank you so much, and we would love to present this certificate of appreciation. Thank you so much, Dr. Chloe Artrip, for sharing your knowledge and expertise as one of our speakers for the neuropathy, and today for the Geriatric Rehab Summit 2024 5th annual event. So this certificate was given on August 17 here live in Delaware, USA. Thank you, Dr. Chloe. Appreciate you.
Thank you for having me.
You're welcome. We're learning more, and then some of us say, oh, that's good to know. We have laser at work from Dr. Rose. So we're chatting here. All right, guys. So if you have any questions, definitely Dr. Chloe, Dr. Logan, please put your information on the chat, and definitely they can ask more questions. Guys, we have a let's say here, most probably 20 minutes break. We can join around 1:15, 1:20 for your break. It's supposed to be around 30 minutes, but join us soon so we can begin for your next speakers, all right? So we have another batch of speakers. Take your lunch, and then we'll see you around 1:15, 1:20. Okay, thank you so much, guys. All right, thank you, and see you later.
Staying on top of your health is important at any age, but it becomes even more crucial as we get older. AgeWiser's Vitals feature makes monitoring your health convenient and effortless. AgeWiser Vitals utilizes innovative video-based RPPG technology to measure your vital signs remotely. This eliminates the need for uncomfortable contact-based methods. With AgeWiser Vitals, you can easily track blood pressure, heart rate, oxygen saturation. Why choose AgeWiser Vitals? AgeWiser Vitals offers several advantages. Remote monitoring. Check your vital signs without any physical contact. Comprehensive data. Track key health indicators like blood pressure, heart rate, and oxygen saturation. AI-powered insights. Detect potential health risks through advanced AI and machine learning technology. Convenience. Perform regular scans from the comfort of your home using just your smartphone. How it works? Getting started with AgeWiser Vitals is simple. Open the Vitals menu. Navigate to the Vitals section within the AgeWiser app. Take a quick scan. Use your phone's front camera for a short scan. Get your report. The app analyzes the video using RPB technology and generates a report of your vital signs. Monitor regularly. Perform regular scans to track trends and identify any changes. User testimonials. Here's what our users are saying about AgeWiser Vitals. Additional tricks. Here are some tips for maximizing your experience with AgeWiser Vitals. Well-lit area. Stand in a well-lit area for optimal scan accuracy. Proper positioning. Ensure your face is centered in the camera frame for best results. Regular monitoring. Conduct regular scans to track trends and identify any changes in your vital signs. Ready to monitor your health effortlessly? Don't wait. Take control of your health with AgeWiser Vitals. Open the Vitals section in our app today and experience the convenience and accuracy of remote vital sign monitoring. Download AgeWiser today.
We all know someone with dementia. It's on the rise.
Older adults are very concerned about their brain health. Nobody wants their bodies to outlast their minds.
None of us want to lose our minds, and there isn't a convenient place to go to address these concerns. There are no brain gyms. Until now.
To put it simply, Marbles is your brain gym for cognitive health.
So this is the first of its kind gym.
Marbles wants to give people affordable access to the best technologies to stave off dementia.
When you're doing these cognitive games, you're engaged and you're challenged and you're making mistakes and you're laughing, but you're also moving at the same time.
And it requires some work, but it allows them to succeed just often enough to satisfy their preferences. So Marbles is never going to be harder than you need it, never harder than you're capable of, but just powerful enough to stimulate connections in the brain, neuroplasticity.
So the big inspiration is to make these technologies available, accessible, affordable to the public to help prevent the onset of cognitive decline. Franchising is the fastest way to get it to the public.
There are many reasons why this is such an amazing business opportunity for potential franchisees.
We've designed Marbles to be a low entry price, low overhead, affordable to the customer, and extremely simple to operate.
That's why I'm here as the medical director for Marbles to design the programs, to identify the equipment, and to help you achieve your optimum in brain health.
You know, there are a lot of franchise models out there, but this is really a one of a kind.
Marbles is basically my what was I made for moment.
We all know that physical exercise is good for the brain and mental exercises are good for the brain, but when you combine them at the same time, that is the holy grail to keeping your marbles.
HelloNote is a truly therapist-friendly practice management solution with integrated EMR that will enhance workflow, efficiency, and patient care. HelloNote reduces error and allows you to spend more time with your patients. It comes integrated with billing. Claims are generated once a note is completed. You can bill with one click and a patient portal, which streamlines the patient intake process. Beautifully engineered and cloud-based for easy accessibility, the software works on all platforms. You can access patient records from anywhere. We also offer 24/7 support. HelloNote is the practice management solution that you're looking for.
All right, guys. All right. Thank you so much, guys, for staying. And that's all our break. Quick break for your lunch break here in US base, and of course dinner time. I know it's really midnight snack on there globally. So we have the first batch and we're heading now for our next batch of speakers. We would like to thank our sponsors. We have Dr. Newman yesterday, and he touched base a little bit about PopDoc, which is not just a tool for rehab, it is also intended for use in preventive orthopedic programs as well, for joint maintenance and preservation. So we know more about it. And thank you, PopDoc, for also sponsoring some of our recipients. And we have this lunch break that we have. And thank you for activator polling. We have Dr. Juliet also discuss about how the activator polls help in improving the core, how you can use it during your day-to-days for our older adults. It is an award-winning 100% women-owned operated Canadian company. All right. And we saw the wonderful Hello Note videos. It is an EMR base, and we will going to put this also, guys, in your handouts, all the resources where you can talk more about and learn more about it. On our Innovators Summit, we will learn more about it. Hello Note also is one of our sponsor and benefited some of our attendees here right now. Okay, we have all the current sponsors we have. We talk about Maradyne low intensity vibration, and from Copa Health, American Institute of Balance, Age Wiser. We have a wonderful video about that a while ago. Marbles Brain Body Fitness Gym, Ludofit. We have Mark Evin, wonderful innovation, and LSVT Big with Laura Gusay. And we would love to offer thank you also with our Future Foundation Global. It is a nonprofit organization. So want to learn more, guys? I'm one of the board member treasurer. So with these small things, we're part of the proceeds, help them. And then also we have what do you call this? Some doctor physical therapy that we have scholared, and we almost have 2 now. All right. And we have more projects to go. So thank you for supporting us and learn more about us. Okay. We have a Facebook group as well. So we have now our speaker for this afternoon. So Dr. Frank Siubo will going to discuss the use of low-intensity vibration for osteoporosis and related musculoskeletal conditions. So I have one of our colleagues and talk about, Dr. Jenny, can you talk about osteoporosis, compression fracture? We have lots of cases like that. And now we have Dr. Frank, and Dr. Siuba is the owner of the HS Therapy Associates and graduated from Temple University with a master's degree in physical therapy in 1992. Dr. Shuba earned his doctorate in physical therapy from Temple University in December of 2004 and a certified osteoporosis exercise specialist using the Ceramix method. which was designed by physical therapist Sarah Mix to combat the effects of osteoporosis without taking medication. The program focuses on changing the actual curvature of the spine, something that medications cannot do. Site-specific exercise is utilized along with posture and balance training. Dr. Suba teaches patients proper bending mechanics for the ultimate goal of reducing the risk of compression fracture. Dr. Suba is a Titleist Performance Institute golf medical professional. He is able to apply his knowledge in the performance of biomechanical evaluation of golfers, as well as instruction in an appropriate exercise program to improve your game. So Dr. Shiva works with local golf professionals in the area and has trained many of them. In addition, Dr. Frank is a third-degree black belt in Taekwondo and has incorporated his martial arts training as well in all his treatments. Welcome, Dr. Frank Silva. Thank you so much.
Dr. Jenny, thank you for that introduction. I'm hoping, can you hear me?
Yes, I can hear you well. All right. And you are also a co-host now, so you can even share your screen.
All right, I'm going to share the screen right here.
Yes.
And welcome to everybody who's at this wonderful geriatric seminar that's put on by Dr. Jenny. Thank you for having me as a speaker. That was a wonderful introduction. And as Dr. Jenny had said, this is going to focus on primarily low intensity vibration therapy. It's not a new technology. It has been around for a little while, but it's becoming much more popular as the population ages. And it is becoming popular. Oh, I'm having trouble trying to advance this. Let's see here. I might have to go to something else. I'm not sure why that won't advance. Dr. Jenny did this the other day. And I might have to go to get a flash drive here and pop that in. Give me a second here. Hold on. Let's see. I'm not sure why this is not advancing. Okay. Let's see if I get it on this. Oh, there we go. Okay. So who am I? As Dr. Jenny had said, I have a master's degree, started a master's degree at Temple University, 1992, and then got my doctorate 2004, 2005. When I started out in physical therapy, I would term that I was a jack of all trades, a master of none. And as orthopedic practices that many of you work with started to go to niche practices, physical therapists started to do the same thing. We started to specialize and develop niche practices. So two of them Dr. Jenny mentioned was the Titleist Performance Institute program, where we work with a lot of athletes. And believe it or not, we have older athletes now. One of our #1 injuries is pickleball but for the older population. The second thing, though, the thing that dramatically changed my practice was the osteoporosis, osteopenia, or the low bone mass program that was taught by Sarah Meeks. So I went through all the steps to become an osteoporosis credentialed exercise specialist in the Meeks method. And under the umbrella of the Meeks method, Sarah does most of her programs focused on exercise. But we became aware of some research that was done by Dr. Clint Rubin. And Clint Rubin is a name that you want to remember right now. So if you want the research from the expert, and once again, I'm a physical therapist who uses vibration therapy, but the the specialist in vibration therapy is Clint Rubin. He's up in upstate New York at the University of Rochester. And he's a brilliant gentleman who's published over 20 articles, at least, on the benefits of vibration or low intensity vibration therapy. Now, I'm going to emphasize the word low because there are high intensity vibration platforms as well that are out there. And there's a huge difference. So I'm assuming most individuals who are taking this geriatric summit have some percentage, large percentage of their patient population, if not all of it, that work with geriatric individuals. And we know that some of these individuals are very frail. So when we talk about osteoporosis, we know that bones are constantly remodeling and we need to load bones. But we can't do high impact with some of these patients because of their frail structure. We know what happens as the musculoskeletal system begins to fail. The contributing conditions are, we notice that they have reduced mobility and systems just decline. All right, so our job as physical therapists is we're supposed to step in, we're supposed to provide them with exercises, and in my practice with osteoporosis, we're trying to develop bone best ways we can. Most importantly, reduce compression fractures. So the Meeks method is the primary goal of the Meeks method is not necessarily reduction of compression fractures. It's I'm sorry, not necessarily building bone. It's reduction of compression fractures by aligning the vertebral column. Okay. So Sarah Meeks got in touch with Clint Rubin, and Clint was talking about his research into the vibration platform and how he had done studies, animal studies starting out, that showed that when individuals stood or were on a low intensity vibration platform, that there was bone formation after a certain period of time. So this technology then morphed into a partnership with Maradyne, which is the company that makes the low intensity vibration platform. All right, continuing with this, we know that the geriatric population definitely loses muscle, lean muscle mass, and they lose skeletal strength. The problem is, how do we take a frail population and how do we try to help their bone situation? And this all leads to a compromise in the quality of life measures that we have out there. For those of us who use functional outcomes, I would assume most of you use functional outcomes right now. You'll see that there's a lot of issues with this population as far as quality of life goes. When we talk to our patients too, we realize that there are a lot of layers of the onion, we say, for these individuals. They have a multitude of health conditions that are going on. So in addition to a frail frame, a kyphotic posture, hyperkyphotic posture, they have a lot of other issues that are going on health-wise. They may have cardiovascular issues. A lot of my patients have cancer, lupus, fibromyalgia, and we have to kind of part the sea as far as where we prioritize working with them. We have a little saying in our bone program is that when every patient walks in the door, think bone. And Sarah Meeks is the one who coined that phrase, and we use it with all of our patients because we want to make sure that we are respecting the bone. Statistics state that 1 in 2 women over the age of 55, 60 will suffer an osteoporosis-related compression fracture at some point in their lifetime. 1 in 4 men will suffer an osteoporosis-related fracture at some point in their lifetime. So all of you as practitioners probably know that males get it, but the general public is unaware right now, for the most part, that males can get osteoporosis and can be at high risk. I just had a patient recently who was coming off a very bad hip fracture and is about 3 to 4 months out of his repair. The other day over the weekend, he got up from the chair, went to place a coffee cup in his sink, and he heard a crack. Well, lo and behold, he couldn't put any weight on his leg, and he was rushed to the hospital. A few days later, they ran a DEXA scan. I had suggested to his wife that they might want to look to see if he has osteoporosis, and sure enough, he does. It's pretty bad. So we, as in the physical therapy world, sometimes need to be the people that kind of advise the family as far as how rampant and prevalent that osteoporosis is for individuals right now. Local dynamic loading. We know that muscle and bone perceive and respond to local dynamic loading, and we have to develop mechanisms to do that. So we build form, we build strength and support function, and we have all used the term, you use it or you lose it. Keeping in mind, though, this population is a little bit different as far as what exercises we can do. I joked a little bit before about pickleball. It's certainly an up and coming sport for our over 50 population. I think that probably during the next Olympic, it's probably going to be a sport. But we have to be careful with the way we work with these individuals as well, because there's certainly a lot of pickleball injuries right now. All right, reductions in functional loading. We have pathological or occupational reductions in the functional loading. And what happens is bones become more susceptible to fracture as people age. There's a lot of reasons that we present in our course. I teach through my company with my colleague, Deb Galbranson, who's in Colorado. Our company is called Bone Strong Seminars. We've given the information to Dr. Jenny. We also teach through Herman and Wallace. We teach right now a 1 and 2 day course as far as the management of individuals with low bone mass and or osteoporosis. It is based on the Meeks method. And what we know for the most part is that these people are very, very susceptible to compression fracture. And our course is designed in an exercise program that, believe it or not, unloads the spine and decompresses. So our approach for exercise, and I'll certainly take any questions at the end about that if you're interested, is that it kind of goes against the grain of loading the bone initially. We want to, and Dr. Jenny mentioned in my introduction, we want to change the curvature of the spine or try to align vertebral segments first before we start loading the vertebrae. Because if we have somebody who's very, very hyperkyphotic, and we start loading them in, say, a shoulder press in a gym, they're going to accentuate their hyperkyphosis, and sometimes that will lead to compression fracture. Up to 70% of compression fractures are silent. An individual does not know that they have them until it progresses to a degree that they become symptomatic. And by that time, it's usually sometimes a very, very difficult situation, very painful. And we also have bracing that we use here in our clinic as well if we need to do that. Now, pharmacologic interventions. We as physical therapists are sometimes inundated by questions from our patients because let's face it, we see our patients on average 2-ish, maybe 3 if you're lucky now, based on financial situation, times per week, or that's what we like to do. So we get a lot of questions. We develop a different type of relation with our patient and they trust our judgment. I always initially say to individuals that I'm not a pharmacist and I'm not a physician, but I can talk to you pretty much about the medications that are out there for osteoporosis. The majority of medications, just so you're aware, they do not build up bone. They slow down what's called the resorption of bone. So people get to an age where you think about that scale when you're in grammar school. You're building up bone, you're building up bone, you're breaking it down. It's constantly remodeling. People get to an age where the breakdown starts to become larger than the buildup. So you get out of bone balance. What the medications do, the bisphosphonates and those other medications will do is they slow down the breakdown so you can normalize your bone balance a little bit. There's only one medication we're aware of. It's called Forteo, which is an injectable that you could take. You inject yourself daily for 2 years. That has been shown to build up bone. The downside is that in all of these studies, after 2 years of use in laboratory animals, Forteo has been shown to cause osteosarcoma. So it's not a great option. And right now, that's the whole thing. We as physical therapists have much better options for the individual with low bone mass than, say, the physician does from the standpoint of pharmacology is still not yet there yet. They're getting better. Now people can get the IVs and they don't have to take medications frequently. So that's getting better, but there's still no silver bullet as far as the medications go. The other issue with medications right now is that they can be off target, and we use the term off target here, and they present secondary complications. When I first came out of school, Fosamax, which was a common medication that was used by Merck, was allowed to be taken by individuals for up to 10 years. And then studies were done that showed that they reduced that to 5 years because from the 5 to 10 years, they were seeing the necrosis of the jaw and some of the other problems that some of your patients may complain about. The other issue is that a lot of our patients right now are resistant or hesitant to take the medication. I would say of all the patient populations that I have, the osteoporosis patient population may be the most, I guess, scrutinizing as far as medication goes. I'm not going to say they're the most knowledgeable, but the thing is that they're very, very hesitant about taking medications because they know it's a long-term situation. The better option we have is to physically target the musculoskeletal system and provide mechanical signals and affect the bone. Okay, so we know that some of the traditional typical exercise regimens that we see in the United States are not the best option for these individuals. They are frail if they have hyperkyphosis. Think about them going into a gym, maybe say like a YMCA or a fitness facility. We know what the training of some of those individuals is. So we have to do a really good job of marketing and promoting ourselves to the physician base, and certainly doing community and services to educate individuals about the impact that we can make on them regarding their fracture risk and certainly their alignment of the vertebral column. Many, many of my patients come to me and they don't realize that you can actually change the curvature of the spine. They think that their hyperkyphosis is there forever. We actually, in our program, every individual who comes in will get taller, will gain height, and will get better alignment because of the way we exercise them. And Dr. Jenny used the term site-specific exercise. So these are very, very small movements in the supine position that we teach individuals to actually change vertebral alignment. So it's a very, very powerful program. Low intensity vibration, this is what you're here for. So this is what a platform looks like. And I actually have a platform in my clinic. And let me see if I can do this kind of little thing here. I kind of clear at the end. So in the background there, you can see where my platform is. All right. A lot of people think they pass it if they don't know what it is. It looks like a scale, like a bathroom weight scale. And they say, wow, can I get on and, see how much I weigh? And I say, no, you can't. It's a little bit on the delicate side. And when you look at the bottom screen here, you'll see that there's some numbers there. So when Dr. Rubin did his research, he had to set variables. Any of you out there who do research know that everything has to be consistent. So he picked a time of 10 minutes to assess somebody standing 7 days per week. So most of his research that you'll read is based on about 5 to 7 days of standing. Dr. Rubin has tested spinal cord injured patients, children with cerebral palsy. He's certainly done the animal studies. And I'll show you a slide a little bit further down the road. A lot of research that he did was done in conjunction with NASA, because we know that astronauts go into space flight, and what happens? They lose a significant amount of bone mass in a short amount of time. So when he was working with NASA, he pioneered vibration platforms in the space centers so that when astronauts came back out of flight and then were cleared by the medical professionals, they would stand on vibration platforms to bring themselves back into bone balance. All right. So the low intensity vibration platform is a very, very promising exercise adjunct to our program. So in addition to exercises, all of our osteoporosis, osteopenia, and low bone mass patients stand on this platform for 10 minutes. There is a little bit of push right now. As you can see, Esther on the right-hand side is standing and there's nothing in front of her. There is some movement right now for Maridine to develop a standing hold. In other words, kind of something that would almost like the front part of a walker, where an individual could hold on and be in good alignment. Because some individuals who have poor balance or are unsteady may have difficulty with this type of a device. So what happens with the low intensity vibration platform? What we have to think about inside our bone marrow are mesenchymal stem cells. They are a progenitor for osteoblasts, osteocytes, myocytes. So they are the kind of laying the foundation for if something is going to become bone or if something is going to become a fat cell. The only way that it's going to become bone is if there is stimulation. So when somebody stands on a vibration platform, they feel very, very small micro vibrations that go all the way up into the clavicle, all the way up into the jaw. Think about it now. These are areas in the shoulder that we really don't weight bear on. So the one benefit of the vibration platform is that it really gets to areas, say in the upper extremity, creating vibration forces. I've had a lot of individuals and patients have distal radial fractures falling on an outstretched upper extremity and very, very poor and delayed healing. So they are not healed in 8 weeks, they're not healed in 10 weeks, they're not healed in 12 weeks. This sets up a little bit of a flag for us. Have you ever been tested for osteoporosis? No, I haven't. Sometimes we send them back to the doctor. We recommend them getting a DEXA scan, and lo and behold, they're osteoporotic. So we want to make sure that we're not just looking at the lower extremities, although the hip and the lumbar spine certainly are the areas that we test the most in a DEXA scan. And there's a reason for that too, which we talk about in the course. The reason is that the DEXA scan is done only at the lumbar spine and only at the hips is because it's the easiest place to envision bone loss. There's less interference from the internal organs, and for the most part, the DEXA scan was developed to look at that area. Keep in mind that the DEXA scan for your patients, if you have them and talk about their DEXA scan, is one piece of data or evidence about their condition. I have many, many patients come in to see me say, oh, my DEXA scan shows this, or it shows that. Why should I be concerned? I say, well, you know, it's one piece of evidence, but keep in mind that you're doing the right thing by being on this program. We have had a lot of people who come to the program too, and their DEXA scan scores get better. Now, we cannot claim, because we haven't done research with the Meeks method, that the DEXA scan scores will improve. But Dr. Rubin, in his research, and Dr. Jenny, I'm sure, has provided you with our bibliography as far as references go, has shown that the DEXA scan bone density has improved after use of the vibration platform. Some people will ask us, and I routinely get the question, even when we teach courses, is that, what if my patients only come in 2 to 3 times per week, and they only have a chance to stand on the platform 2 to 3 times a week? Knowing that early on when I met Dr. Rubin, I asked him that question. And as a researcher would answer the question, he told me, well, I haven't done that study yet. My study is based on 5 to 7 days of research of them standing on the platform. But theoretically, any time standing on the platform is better than none. So I would believe that they would have improvements in their bone density, but not as much as the group that stood for 5 days in a row, and not as much as the group to stand for 7 days in a row. So lo and behold, through Maradyne, individuals can purchase these units as well. All right, so Maradyne works very, very well. I've had probably about a dozen, maybe 15 people that have purchased the vibration platform to use daily. This person is the person who, A, doesn't want to take medication, B, has tried the vibration platform in our clinic, C, is looking at a long-term solution, realizing that their low bone mass is probably going to be there for quite some time. The other thing is that maybe they're diagnosed with osteoporosis or osteopenia or low bone mass early in their life. Let's take an individual who's 55, 60 years old, and they're diagnosed with osteoporosis, and their physician recommends something like Fosamax. Well, that's a 5-year, use of Fosamax. What do we do next? We can go to things like Prolia and Avista and stuff like that, but you're still on medication for a long period of time. When these individuals are looking at life expectancy now and saying, okay, I was diagnosed at 55, 60, life expectancy for me is going to be maybe in the 80s. What am I going to do for that amount of time? So the vibration platform, we've had people, Maradyne has studies on people who've had a vibration platform now for easily over 10 years. And it's functioning well, there's no problems with it, and the benefits are still there. So Ian Cutts is the individual who certainly anybody can reach out to me. He's wonderful, and he would be willing to work with you on this. So Maradyne does have financing programs that are available for individuals too, if you're interested in this, but it's a really, really neat thing. Now, the other thing is that it doesn't only work with just osteoporosis or osteopenia. There is research out there that shows that it helps with individuals with Parkinson's, that it helps with individuals with peripheral neuropathy because there's stimulation, from under the feet as the vibration platform vibrates. There's some evidence that it also helps with weight loss, but that's more you would see physicians using that. Physical therapists are not going to really be using that. There is evidence for improvement in muscle strength and blood flow in the area where you have stimulation. So there are low intensity vibrational signals, okay, that come up. And once again, I'm going to go back and talk to you about low intensity versus high intensity because there are some high intensity platforms that are out there. They are typically found in gyms. One that was very, very popular years ago was something called the power plate. Now, the power plate was typically found in gymnasiums. And for those of you, and I'm going to guess maybe it's a few of you, who lived through the 80s and know who Madonna and Oprah Winfrey were, all right, they touted the power plate. So basically, it looks like an oversized trampoline. And it's found in fitness facilities. And not only does it vibrate, but it also moves. So it's kind of this neat thing. The problem is that the force of magnitude of a power plate or a high intensity vibration platform is 4 Gs. So we talk about the G's gravitational force. Dr. Rubin, when he did his studies, and you'll see it in a slide coming up, it's in your PowerPoint, is he found that what is safe for the frail population, according to the OSHA guidelines, is about 0.4 Gs. So the power plate and other devices that you see in medical and in like fitness facilities are not appropriate for this patient population. We discussed the other musculoskeletal benefits, all right? Muscle strength, size, all right? There's an increase in neuromuscular efficiency and enhance the expression of anabolic genes, all right? It also shows that the vibration platform can repress fat development because of the fact that it's actually stimulating the mesenchymal cells to become osteogenic, so to speak, as opposed to adipogenic. So they're not stimulating fat cells. Now, we just discussed low intensity versus high intensity, and the Maradyne platform is calibrated for about a 0.4 G gravitational force. Much better tolerated in this frail population. I'm going to say the only people, I don't even know if I have a patient population really that struggles being on the vibration platform in our clinic. Well, I guess the only one that might be is a vestibular population, especially if they're an acute episode of a vestibular attack or something. And certainly we don't recommend that they go on there anyway. We talked about the high intensity platforms. They're typically found in fitness centers and gyms, and they're actually been linked to some joint problems, joint pain in some of the studies that have been done because they're too aggressive. The design, specifically designed for safety of people with low bone mass. So for those of you who treat individuals with osteopenia or osteoporosis, and once again, under the umbrella term of low bone mass, this is a great adjunct or a complement to your program. We've had individuals take our seminars through either Bone Strong or Herman & Wallace, and a lot of them have been directors or worked in medical facilities, say in hospitals, and they've since gone on to purchase a vibration platform that becomes part of their bone health program, their osteoporosis program at their facility. So it's a great adjunct for that. Obviously, it's a tool for managing bone mass. And the stimulus that you get on the vibration platform is about as strong as a very, very mild heel strike. So I mean, you certainly can have people just go up on their toes and come down and strike their heel, but it's very, very, very light. It's very soothing, and it's very well tolerated for this patient population. We had talked about what it does already and how it stimulates the mesenchymal cells to mature into osteocytes rather than adipocytes. And that's an important thing when you're asking, you're talking to your patient, they're asking you about the function of it. But more importantly, when you're talking to other healthcare providers about how this platform works and what would it do and what's the benefit of it. Remember that this patient population, at least in my practice, they're not doing body pump. Many of them are well past jogging or running, which is a really, really good thing certainly for them to do. Most of them do our HS therapy walking program, which is a program that, a walking program we designed that varies the forces on bone, because we know that bone responds better to varied forces. So those of you who advise, recommend, or have your patients walking is a great activity. But there is a lot of research now that shows that when you vary the forces on bone, you have better benefits. So our walking program includes not only regular walking, but it includes long stride walking, sidestepping, karaoke braiding or grapevine, retrograde or backwards walking as well. So we not only work on different muscles, but we load the bones in different ways when we do that. And our program is actually done in the clinic in a condensed area that individuals can do in a very small area of their home. For those of you who live in the northern part of the United States and are challenged by weather from, say, December through March, and these individuals are not members of a gym, this is a walking sequence that and certainly in conjunction with the low intensity vibration platform, can be done in their homes. So that's something we can certainly talk to you about if you're interested. It's a very low time commitment. It's 10 minutes per day. The neat thing about the low intensity vibration platform is that it has a pause on it. So let's say you got on and you were there for 2 minutes, but you wanted to maybe do some stuff on your cell phone, all right? Or you had a call that was coming in, or you had to go to the bathroom. You could get off the vibration platform, go take care of it, and it pauses for up to, I think it's about a minute and a half, and then it'll save your program, it'll save your time, and then you hop right back on. So if you got off at 8.5 minutes, it'll save your time. It just flashes, saves it, and then boom, go right back into it. Very interesting. Vibration therapy in children has a more pronounced anabolic effect because it stimulates osteogenesis and increases of the mesenchymal progenitor cells. So, idiopathic scoliosis in children is something that Dr. Rubin has also studied, and he's found that that there's an increase in bone density at the femoral neck on the dominant side for adolescent idiopathic scoliosis. Very, very interesting stuff. Postural instability, we know what sarcopenia is, and we know that as they lose muscle, that causes instability. I would say that for the majority of my patients right now, 75% of the patients that walk into my clinic are classified as a high falls risk. So the 10-second single leg stance that was developed by Carol Lewis many years ago when we had the functional toolbox, which is still used by many of you, is it's a valid, reliable test. We also do the 4-stage balance test, timed up and go. But when those people are classified in the high falls risk, I'd say 75% of my patients fall in that category. And there is evidence with the low intensity vibration platform that if they stand on this on a regular basis, that balance will improve as well. Okay, helps with the neuromuscular conditions and immobility. It's been studied in healthy subjects subjected to down, tilt, and bed rest, and shown to reduce loss of postural stability in bed rest as well. Overall, the low intensity vibration platform may limit degeneration caused by physical inactivity, which we know as physical therapists leads to falls or fractures. Some studies show that the people who are on the vibration platform over a number of visits, and I'm thinking that the studies that I read with Dr. Rubin were probably at least 3 months of use, is that there was improved reaction time as well. So for them making movements within their community, increased movement velocity, better balance. We talked about that already. They have an increase in their quadriceps strength. Okay, because for every reaction, there's an equal and opposite reaction. Think if you're standing on something and there's vibrations coming up towards you, well, you're going to try to counteract that with your muscles. So for every reaction, there's an equal and opposite reaction, and studies have shown increased quadriceps strength when measured. Once again, increased bone mass, muscle strength, balance, posture. There are also some studies that show that since it's a low intensity, that it helps with fracture healing. Okay. We talked about microgravity and the effects of that with the astronauts. They lose up to 2% per month in their hips and their spine. That's 12 times faster than the Earth's gravitation, Earth's gravity. So NASA presented a viable studied patient population for Dr. Rubin when he was looking at his low intensity vibration platform and trying to determine the best G-force and how it was going to help individuals. So there you go. People would, they would go up in a space flight, spontaneously lose bone density, and they would come back on vibration platforms. Okay, so hopefully you've gotten a glimpse of low intensity vibration platform, and more importantly, how it could be an adjunct or a complement to a current exercise or osteoporosis, or as we like to say, low bone mass program, because osteopenia and osteoporosis are forms of low bone mass. So I guess, Dr. Jenny, we have a little bit of time here left. And once again, I think I shot for about 45 minutes. Looks like I'm pretty much on time there. And we were leaving some time for questions. I'm not sure how we were going to do this, if you were going to kind of.
Yes, yes, I can ask, and then there are some questions here. So one question is from Dr. Net. Is the low intensity vibration platform only done in standing? So the position while
Yeah, that's a really interesting question. Yes, the way it's designed right now. I had a patient who was a spinal cord injured patient years ago, Ian Cutts, who is with Maradyne, who's your contact. I called him up and I said, Ian, I said, I know Dr. Rubin's looking at some spinal cord stuff. I have a patient that we could do some work with. So what we did was he came to my clinic and we set this individual up in a seated position, because we do know that transferring spinal cord patients, sometimes that are spontaneous fracture, and certainly, unfortunately, they lose bone density rather rapidly. So we had small, the sand weights that we placed on the knees, and we had them in a seated position. And also in some of the studies too, I believe that with the children with cerebral palsy, I believe that Dr. Rubin either used a standing table or he did them as seated. So in our clinic, and the way the Maradyne low intensive vibration platform is designed right now, yes, but I have had spinal cord patients, probably about 2 or 3 of them, that I've sat at the edge of the vibration platform and placed sand weights on their knees, and I've had them on the working with the vibration platform.
Nice. And then also Dr. Ken said, asked question that regarding the NASA. So he heard that the NASA has installed a gym where astronauts in the space station can do heavy lifting to reduce the effects of osteoporosis and muscle loss. Is there a study comparing vibration plate with and without heavy lifting?
I'm not aware of that, Dr. Ken, but I know that the latest I read, and this is kind of interesting, I didn't realize this. Astronauts exercise about 2 hours per 24-hour that they're up in space. Now, they're not necessarily done, consistently, but they're doing that to try to combat the effects. And I'm sure that there's probably going to be some stuff that's going to come out to look at that. I think that right now, both are probably the best thing. I think there's benefits to both of them, but I have not seen myself personally any published data on those types of things, because I just read recently about how they're trying to have astronauts work out for about 2 hours while they're in spaceflight. That's a great question, though. I'd love to know that. Interestingly, too, just so you all know, we all have these bucket list things that we want to do. But like when I came out of physical therapy school, I was hoping to be an astronaut. Now, I came out of physical therapy school a long time ago, and I realized when I sent away for the information that at that time you had to be a trained pilot, which I was not. So I was kind of disappointed. Who knows? Maybe I'll be a physical therapist who goes up in a space flight, and I'll test myself.
Yeah. So how about the LIV? Will this it work for patients with radiation and chemo? So it's not sure if has been discussed, but how will it benefits our patients having chemo and radiation therapy, Doc?
Well, my experience with that is that we know, and I have a lot of patients who have gone through chemo and radiation, is that neuropathy will develop. So I'm looking at it from a neuropathy standpoint, all right, and a balance standpoint and a deconditioning standpoint. So there are benefits for patients who go through radiation chemotherapy and have those secondary conditions or conditions that are produced as a result of going through radiation and chemotherapy. We know, especially with chemotherapy, that neuropathy is somewhat common, unfortunately. So that's, yes, there are definitely benefits to individuals who are going through that.
That's good. Yeah. And how about our cerebral patients, especially cerebral palsy, spastic diplegia? Would this help with their muscle growth, especially the quads and the gastrocs?
Well, then once again, there are studies. Dr. Rubin has looked at the patient population of cerebral palsy specifically, and he's found that there's been increases in quadriceps strength as well as bone density as far as working with those individuals, because we know that they cannot load their bones the way the average individual can.
Yeah, especially when they walk, it's really difficult for them to walk better.
Sure, and think about it. I mean, there's a lot of patient populations. When you start, certainly as physical therapists, I think that we're really open-minded, and this summit that you're doing really kind of exposes us to everything that's out there. Some things that we never even touch in our own practice. But think about, if 1 in 2 women and 1 in 4 men over the ages of 55, 60 will have an osteoporosis or a compression-related fracture at some point in their lifetime. This is a huge, I guess, market for the physical therapy field to be the people, the person who is the #1 person who treats people with low bone mass. I work with a lot of physicians, and they'll be the first ones to tell me the only thing they really have for them is pharmacology. But we know that pharmacology doesn't strengthen muscles, doesn't help with balance for the most part. It doesn't get them more flexible, and certainly it doesn't improve function. So the thing about it is that they have their role, but I think that we have a very large role in working with this patient population, and the low intensity vibration platform is certainly something that's a very, very good complement. For those of you who are into marketing as well, if you have a vibration platform, think about your competition in the community. There's not a lot of people that have vibration platforms nor understand it like what we presented to you. So when you're talking with physicians about the benefits of what it can do for their patients, boy, that's something they don't have either.
Yeah, and then you're educating that. That's really wonderful. And how about the contraindications, Dr. Frank? Anna just asking.
There's not contraindications aside from pacemaker. All right, would be a very, very big contraindications. As long as they're cleared by their physician for a multitude of things, we have very, very few. People have asked of all the time, joint replacements. There's no contraindications for joint replacements. So pacemaker, electrical devices, things like that would be contraindications for the vibration platform.
Yeah, and also Christine just asked about our Parkinson's disease patients. What will be the frequency for their use for the low vibration intensity, though?
Well, according to Dr. Rubin, he's going to say as often as you can. All right. So the frequency that I would say, based on the Parkinson's that we've had here, is certainly 3 times a week is probably your best in conjunction with your gait training, your balance that you do in these individuals as well. But a lot of them have responded better, and then their balance test, their gait improves after they're on it. But it's like everything else, Dr. Jenny, we know in physical therapy that individuals, whether it's exercise, vibration, consistency leads to improvements.
Yeah.
Inconsistency is certainly something that's somewhat difficult.
Yeah, thank you so much, Dr. Frank. And also, guys, if you have any questions about the price, how does it work, we will definitely share it as well with you. And then Dr. Frank says something about that it's available in financing, right? So it's
Yeah, so the thing about it is that Ian Cutts,
Mhm.
Cutts, if you go on the Maradyne website,
Mhm.
you'll see that Maradyne is involved with a number of things. And I have known Ian for probably over 20 years. And we have worked together on a number of things. But he is somebody who, the low intensity vibration platform has gone through a bunch of evolutions technologically.
Mhm.
If you want to find out pricing, Ian is the one to talk about pricing. It's probably going to hover in the $2,500 range, just so you know. All
Mhm.
right. But there's financing plans that are available. A little hint that you might want to do is you could also have your patients ask about a refurbished model. They do
Okay.
have occasionally refurbished models, which will be less expensive, probably more closer to 2,000. And the warranty and the guarantee they give you is exactly the same.
Oh, that's good. Yeah.
So, you know, I think the best thing to do, Dr. Jenny, is that certainly use my name
Mhm.
for your participants out there who are wanting to contact Ian Cutts.
Mhm.
You know, Ian was certainly one of the people that, you know, put me in touch with you as far as doing, you know, this wonderful presentation, being part of
Yes,
this thing. But the thing is that, you know, he wanted a physical therapist who uses it to talk about it.
that's
Because
true.
certainly we can get a researcher to speak about it, but most of you are wanting, how can I use this in my practice? How is this helpful for me? Where am I going to put this into my patient's program? And certainly letting you know that we have very good success. It's very well tolerated. It is very gentle.
Mhm.
People find it, and the term they use when they're on it, it's very relaxing. So this is not like that power plate. It's a relaxing stimulation, and it's very well tolerated.
Yes, that's true. So I met Ian Katz, and then Ian is from Copa Health, and then he will be one of our speaker in the Innovator Summit. Other than the low intensity vibration, he also have those products like postural brace, you know, so that's very soft brace that we can use and refer to our patients as well. But for today, we discuss about low intensity vibration, and Dr. Frank is the best person because he's using it in his clinic. And thank you so much, Dr. Frank, for all those great information, because we talk about osteoporosis, low bone density mass, and of course, the benefits and everything. All right. So guys, if you have further questions, definitely put it on the chat. Dr. Frank, just put your information and social media as well, how we can contact you. But definitely, I will be sending them handouts of your presentation and also your email if they have further questions. Okay. Thank you so much. All right.
And Dr. Jenny, thank you very much for putting together a wonderful program. This is really great that you do this, and then hopefully I'll be back. Okay.
Yes, thank you. If you watch a
Thank
while
you.
ago, we have a great topics about neuropathy. So some of them, whenever you talk about neuropathy, they're a little bit more familiar and better now with their
Yep.
understanding. Okay, Dr. Frank, I would
Sounds
like
great.
to present this to you, a certificate of appreciation. All right.
Thank you very much, Dr. Jenny.
You're welcome. And thank you
All
for
right.
sharing your knowledge and expertise for us for the Geriatric Rehab Summit 2024, August 17. And this is our 5th annual event. Thank you so much and have a
Great.
good
Thank you very
day.
much, Dr. Jenny. Everybody take care now. Feel free to reach out if you need help.
Thank you, guys. All
Okay.
right.
All
Thank
right.
you. And then, so as what Dr. Frank is talking about, Marathon Live, low intensity vibration. He discussed pretty much what is it all about. And thank you, Maradine, for supporting us for this event, and we will learn more about the different things that we can learn in the Innovator Summit. So conditions such as rebuilding muscle mass, restoring joints, adjunctive treatment for obesity, relieving minor pain, or treating a temporary increase in local circulation may be safely overcome using Maridine Leave for 10 to 20 minutes a day. All right. Imagine they've been funded by the National Institute of Health and NASA. So that's why we are talking about this, NASA. All right. For our next speaker, so we're a little bit early than expected, but Dr. Net is already here since morning, and so she will be ready. Suppose we have a pelvic specialist in the house. So pelvic floor issues in older adults will be discussed by Dr. Net. And Dr. Net, physical therapy practice started way back in 2002 after graduating from Philippines with a bachelor's degree in physical therapy. She traveled and worked in Middle East for 8 years and then moved to United States 12 years ago. So I work with Dr. Nat in Sheikh Khalifa. We work together in Abu Dhabi. So I'm here in Delaware and she's in Illinois. So that's pretty much. So she attended the Evidence in Motion Transitional Doctorate Program 8 years back. Her 22 years of experience as physical therapist made her realize that there's a lot to learn and always room for improvement. So she is doing now combination of ortho and pelvic floor conditions and treat those cases. So she incorporates her practice a combination of accumulative treatment techniques that learned throughout her career. And she is very happy in her treatment and very contented with her patients' response, and she feels good by herself doing this these kinds of cases, pelvic floor specialist, and also she is more in the nutritionist program. And she will learn and teach us more about that. All right. Dr. Net, I'll give the floor to you. I believe you are already a co-host. I put you a co-host. And let's try and share your screen to be sure. Okay, let me see. You're good?
Yes. Hello,
Okay.
Jen. Good
All
afternoon.
right.
It's
Hi, Dr.
one.
Net. Thank you. All right. You're good to go.
Yeah, it's 1:15 here in Central Illinois time. I feel so honored to be part of this event, and I would love to share my passion about pelvic floor. So my practice started way back 9 years ago when it was actually one of those things that I did not choose. So it's not one of my plans to undergo physical therapy. So I was practicing as an orthopedic therapist. So I love treating patients with pain. And most of the patients that I treat are low back pain, cervical pain, hip pain. And then one day I encounter a patient that came to me with a script of low back from the physician. So I started my evaluation and I was just asking about how the pain comes, like frequency, intensity, and the patient's answer are all no. So I was like, you were referred here for back pain. And so she was like, but my issue is not in the back. So my answer is in the, her pain is in the vulva area. And all throughout the years of my practice, like when we treat as physical therapy, we always escape, most of the time, the vulva or the inguinal area because we just don't practice in that area. So that's where my pelvic floor interest came along. And so I attended the Herman and Wallace pelvic floor certification training. So, and as I get to know and treat patients with pelvic floor issue, I realized that the pelvis is a very important aspect of our body. Like, so when I'm treating pelvic floor, we are always thinking of just the pelvic floor itself, but in reality, it's more of a big topic. So as I was like telling you yesterday, Jen, can you see my slideshow or not yet?
Not yet. You can share now.
Let me share. Okay. How about now?
Yes.
Okay, so I tried my best to shorten this topic because it's really a very broad topic to discuss. So initially, when I started my practice, I was only thinking of the pelvic floor itself. And so when we talk about the pelvic floor, I have here a picture of a cross-sectional area of the pelvic floor itself. So this is for female and male. So we are only
Dr. Net, it's not showing, so make it full. It's on the different page. The picture is not showing. We're seeing the what is pelvic floor, which is your fourth page, fourth slide.
Having some issues here.
You can make it slideshow and you can click from the first slide or second slide.
Can you see now?
Not yet. I still have the what is pelvic floor function, which is your fourth slide. Yan. That's good.
Okay, so when we are talking about the pelvic floor, we are only thinking of this, of the pelvis itself. But along the years of my practice, I realized that the pelvic floor is just a transitioning of force from our upper and lower body segments. So here in front, we have a picture of a female pelvis. So if you look on it, we have like 3 pelvic organs for female. And on the back, we have like 2 pelvic organs. So here in front, you can see the most frontal organ is your bladder. So, and
Dr. Net, try to make it slideshow or bigger. So full.
So the bladder in front, and the bladder is the one that holds our urine. So bladder's capacity is around 3 to 4 hours of storage time, and that is around 400 to 600 ml of urine. And we know that there's a sphincter on the neck of the bladder, and then the second is sphincter on the pelvic floor itself, which is your urethral sphincter. So the urine will pass down to the urethra and then down to the urethral sphincter. So at the back of the bladder, we have our uterus. So for female, this is where the baby grow when we get pregnant. And of course, it's continuation with the vaginal vault, or what we call the vagina. And then we have our second sphincter, which is the introitus, or the vaginal sphincter. And then on the back, we have the rectum. So the rectum is where the final passage of our fecal matter goes, which then eventually exits via our anal canal. So for male, on the male counterpart, of course, we don't have the uterus and we don't have the vagina. So they have like the bladder and the rectum, but their urethra is longer. And on the just below the internal sphincter of the bladder, we have the prostate for male. So if you look on this picture, you can see that the pelvic floor muscle is like connected from the tailbone to the pubic bone in front. So it looks like an underwear. So it is like this. It looks like a hammock on the inferior aspect of your pelvis, which guards like the pelvic organs and everything that comes out of there. So the pelvic floor is very much connected to your urine, which is a function of the kidney, very much connected to the reproductive system, and then very much connected to the gut because of the bowel aspects. And then if we look on it from the top view and from the bottom view, then you can see that the pelvic floor is a hammock. So it has 3 sphincter. It has your urethra, your vagina, and your anal sphincter. And what is this pelvic floor and what is the function? Does most people know about it? So,
Dr.
like,
Net, excuse me. It's still not on full. Yeah, they cannot see that much. It's still not on full view. So you can make it on slideshow.
is it still not full view?
Yeah, no. That's what we're seeing right now. It's still on not full view. Try to click the slideshow so it will be bigger for us. Yeah, click that.
Okay, so most of the
Not yet,
people.
not yet. It's still
Not
not.
yet.
It's still not working.
Why is it not working? I don't know, Jen.
How about the other part? Yeah, it's still not coming out big on our side. It's like, so did you click it already?
Yes, I did it.
It's not where are the other part? There's another one because I think you are Mac. I don't know. What other part you can click? Yeah, when you click that, that's supposed to be. Where else Fretchy she can click? Are you Mac or Apple?
Yes, I am Apple.
Okay, okay. So I'm not an Apple. Usually I know it's on the bottom. Where else she can click to make it bigger? That's the only one I know. Slideshow. It's not making it bigger. Yeah. That's fine. Okay. All right. It's not showing, but that's okay, they said.
Okay, so when we talk about the pelvic floor, most people doesn't know that the pelvic floor is a muscle that therapists can address. So when patient comes to me, they are thinking that I will just address their pelvic floor area, and they don't know that we will be thinking about like how the pelvic floor coordinate with all the sphincters, with their overall posture, with their breathing, with the coordination of breathing to movement. The only thing that they know is like they need to do Kegel. So when patient comes to me and they are being referred by the doctor, these patients has been like doing like multiple Kegel all the time, like mostly in their days, like because they are trying to prevent leakage. And they don't know like that most of the like other muscles of the body, there should be a balance between flexibility and mobility and strength and coordination. So most of the patients that reach to me are like patients that have like very tight pelvic floor versus very stretched pelvic floor. So you need to educate this patient that initially Kegel is not the first exercise that they should be doing in pelvic floor rehab. So when we think of the pelvic floor, we are thinking of it like a muscle that contract with the storage of urine and while your bladder is filling up. So we are talking about the urethral sphincter. And then it's a muscle that relax when we are emptying. So when we have to pee or when we have to have a bowel movement, they should be relaxing. But in reality, like when we do pelvic floor eval, we have to educate the patient that the pelvic floor is a part of a bigger picture. So I always tell them that your trunk and your pelvis, we consider that as a part of the core. So the core is not only your abdominal area. The core is much bigger sense in the form that I always, how Herman and Wallace like presented it. It's like a soda pop canister. So if you look on the soda pop canister, there's a, it's like there's a pressure, there's a closure on the top. So that's your diaphragm, which starts from below your sternum. and connected to your pubic bone. And then on the back, you have muscles of your scapula, you have your spine, you have your paraspinal muscles, like your gluteal muscles. And in front, you have your abdominal muscles, and below, you have your pelvic floor muscle. So inside this canister, there's a pressure gradient or intra-abdominal pressure, because every time we breathe in, the pressure increases. And as we breathe in, the muscles around the trunk and the pelvic floor area, they relaxes. They tend to get lengthened. And during that time, if you still remember the length tension relationship of muscles, when the muscles are lengthened, usually they are like more relaxed. And that's the time that the blood supply goes to deliver blood for the nutrients of the muscle itself. Aside from that, when we breathe in, all the organs, starting from like your lungs, your heart, your esophagus, all organs inside your body, your stomach, large intestine, small intestine, all the pelvic organs, your bladder, your uterus, your rectum, they all descend around 2 to 3 centimeters. So in pelvic floor rehab, it's not only the movement, it's not only the pelvic floor, it's not only the breathing. Like it needs to be coordinated with the breathing, with the movement, with the pelvic floor core stabilization and the mobility. And that is to protect the spine and to protect the organs in all aspects of your trunk, from trunk down to the bottom. And when we talk about the pelvic floor function, we are summarizing all the function in 5S. So the first one is, of course, the pelvic floor functions for support, because it supports the weight of the head, the
Dr.
neck.
Matt, we're not seeing the next slides, okay? We're only stuck on number 3. I think you are moving your presentation, but the slide is not the same as what you're trying to show.
I'm sorry, I'm having malfunction. I'm moving it,
Yeah.
but it's
It's not showing on our end. It's like you're frozen, but I can see on the side that you're showing a nice image there and you're explaining the anatomy, but that's not what we're seeing. And then you're about to say something, but we're stuck on what is pelvic floor and function so far. So just want to
Can you
give
see the pelvic floor function, 5S?
No, you're stuck on number 4. I think you're going now to number 6 or 7. It's not the same, but I know that you're moving. Yeah, so we saw now the canister. So you explained that already. All right, now you're on 5S.
It is?
Okay, it's working now.
Okay, so there are 5S function when we summarize the function of the pelvic floor. So the first one is S, meaning for support. So the pelvic floor support the weight of the head, the neck, and the trunk, and it supports the pelvis, it supports the organs, it supports our posture, our breathing, and it fixes the trunk with the upper X movements. So the next one is for sphincter. So like what I showed you a while ago, there are 3 sphincter down into the pelvic floor area. And the first one is for the passageway of urine, which is the urethral sphincter. The second one is for reproduction and for sexual intimacy, which is the vaginal sphincter. And then the last one is for fecal matter or for bowel, which is the anal sphincter. And then the third function, S, is for sexual function or for reproduction. And 4 is for stability, because if the pelvis is stable and the pelvic floor is supporting our pelvis well, along with the good alignment of the lower extremity, then we have a good connection for the upper X and the lower X. And the spine remains in the middle of our trunk, which prevent postural deformity and postural issues leading to pain. And then the last function of the pelvic floor, like what our lecture tell a while ago about lymphatics. The pelvic floor is also a component of the lymphatic system because its ability to contract. So it's called sump pump. Okay, so can you see the next slide, Jen?
Yes, it moves.
Okay. So when we talk about pelvic floor in elderly, there are lots of things that happens as we get old. So first, aside from our age increasing, our hormone changes. So I always tell my patient that there are two ways that our body communicates. So we discuss a lot here today about neural communication, which I always explain this to my patient as the fast way of communication that our body uses. So there's a neural impulse, and then it goes to the nerves, to the muscles, to the organs. And then there's also a hormonal communication. And when I teach my patient or I treat my patient in the rehab, I both consider both neural communication and hormonal communication. And this is one of the reasons that I went for a functional nutritionist, because as I practice through the years, like most of the patients that come to me are patients that have like multiple of issues. Like they have been to 7, 8 doctors and nobody can explain how the symptoms are related to each other. Like and their hormones are not in homeostasis. The problem with our current medical system nowadays that I kind of realize is when you have like hormonal dysfunctions, so it's not only diabetes, like PCOS is one of the conditions that I usually see. But PCOS on the early stages, they are not yet diabetic. So their hormones is not level, but yet they are having like endometriosis, stuff like that. But our insurance doesn't cover or the primary care physician will not refer them to an endocrinology for further hormonal workout until they are presenting diabetes symptoms. So as patient gets older, they're having hormonal issues. And one of the big changes that happen is menopause for female. So we all know that the estrogen is very important part of the overall health of the pelvic floor because it maintains the strength, the elasticity, the integrity of all the tissues down there. So as we get older, especially for female, the estrogen goes down, and so that affects the health of the overall pelvic floor. So that these patients will have like changes in the flexibility of the muscles there. They will have changes with their skin. They will have changes with the ability to heal and more other aspect. So second thing that is usually you can see with elderly people, of course, is they have multiple pregnancy or multiple history of pregnancy and childbirth. So we all know that as we get pregnant, the belly gets big. There are hormones that are released that loosen our joints. And some of them, they are not referred to therapy after giving birth because there is no symptoms or people just doesn't know what is a normal pelvic floor thing. So in the hospital where I practice, I encounter one nurse who had multiple issues with pelvic floor that was not properly addressed for years. And she was having like severe back pain throughout the year. So she was coming for like, she's a repeater for back pain rehabilitation until one day, one of my colleagues said, Ned, I think you need to look onto this patient. I'm having like difficulty like treating her. Her back pain is just not getting better. So I said, okay, maybe I can see if there's a pain generator somewhere in the sacral area. So I treated the patient and sure it is like the organs are falling down and the nerves are congested. So maybe it's not only the nerves because we know in every part of our body there's nerve, there's artery, there's lymphatics, there's venous system, and it's same thing inside the pelvis. So since that time, this nurse, because she's one of the supervisor in the hospital, we developed a protocol that we close coordinated with our OB department that every female who give birth and return after 4 to 6 months of 6 weeks of follow-up and are having some symptoms, either urinary, sexual, or even pain issues or bowel issues, should be referred for pelvic floor therapy to prevent contraindications down the line. Okay, so next one is hysterectomy or other surgeries. So as we get older, like because of the changes in our pelvic floor organs and our hormone itself, there are people who undergo hysterectomy either because of cancer or because of severe bleeding or because of ovarian issue, and it can either be like partial hysterectomy or total hysterectomy, or they can have like other surgeries, including hip replacement, knee replacement, and even spinal surgeries. And all these things, they all affect the posture of the patient. They all affect the integrity of the ability of the pelvis to balance itself symmetrically. So when that happens, like the spine is in an abnormal posture, the core cannot work, and then the pelvic floor push or pull or the ability to contract is being affected also. And number 4, as we get older, we get fat because of the effect of cortisol and hormonal balance also, or just because of lifestyle. And as our belly get bigger, then the ability of the core to support our spine and to stabilize our intra-abdominal pressure is also being affected. And if that's the case, then it creates an increased pressure down the pelvic floor area, creating lots of other issues like prolapse, increased traction, or increased stress on the pelvic floor itself, or sometimes pain. And then, so postural weakness, number 5, is also related to everything that I already said on above. So when I do my pelvic floor treatment, the first thing that I look, of course, is the posture of your pelvis. So the pelvis is the foundation of our posture. So I always look if the patient's pelvis is symmetrical, if the patient pelvis is neutral, if the rib cage is elevated, or is the rib cage sway back posture. So I look from head to foot. So you are not only looking on the pelvic floor areas, because that stability of the pelvis itself, where your pelvic floor organs are in, is dependent onto the posture of the body. Yes? Okay. Number 6 is, as we get old, we tend to have more pain because of arthritis. So we talked a lot a while ago here about pain aspects of rehab. And so as a pelvic floor practitioner, you're not only looking onto the strength, the posture, the coordination, the hormonal balance, the nutritional aspect of and previous history of the patient. We are also addressing pain. So most patients who reach my practice, they have like multiple pain issues, like they have pain in the neck, upper shoulders, they have pain in the back, hip, knee, ankle, and that makes the rehabilitation of pelvic floor issue more complex, because until the patient gets a stable posture and is more become challenging with elderly patient, and then there will always be like a time that the problem of pelvic floor will comes back. So when I treat my patient, I always tell them at the beginning, like, I'm not expecting like a quick change. Like if there's one thing that I want you to learn at the end of this treatment, I want you to learn how to manage your symptoms. I want you to understand why things happen, or what happens, why things can come back. So they need to learn to manage their pain, their joints, and their muscles. And then as we get older, there are more other medical issues that is affecting overall body homeostasis. Some people will have a stroke, heart issue, degenerative changes, Parkinson's disease, and other aspect. And then they also tend to rely on multiple medication use. So these aspects, as we get older, all affect the pelvic floor rehab. So moving forward, so I try to just summarize this and just present with you guys like most of the four most important thing that I see with my pelvic floor rehab in elderly population. But in reality, there are lots of other common issues that are being presented when it comes to pelvic floor. But because it's a very big topic and I have like a limited time to present the whole aspect, I tried to just shorten it and just discuss like four of the most common things that I see with elderly population. So the first one is urinary incontinence. So urinary incontinence or urine should not be coming out when you are not ready. So some patients that I've seen are like they went to the doctor for years before they reach me in the rehab. And some of them doesn't even know that no matter how old are you, urine should not come out of your bladder when you are not ready to pee. That's abnormal. So some doctors, because pelvic floor therapy is I would say relatively new practice in around. Some of the doctors will tell them that, oh, you're leaking urine because you have diabetes, or you're leaking urine because you are already old, and that's just part of aging. But no, urinary leakage is not normal. So you have to tell the patient that when you are not ready and there's a urine that comes out, it is not normal, and you have to educate them why it's happening. So there are different kinds of urinary incontinence. So the first one is what we call stress urinary incontinence. So from the word stress, whenever there's an increase in force, you laugh, you cough, they play with their grandkids, they jump, they stand up, and to the point that sometimes it gets worse that even just turning in bed, which is just a little bit of force, and they will have urinary leakage. So that's what we call stress incontinence. And whenever I assess my patient on the initial evaluation, I need to make sure that I differentiate between the different kinds of urinary incontinence, because each urinary incontinence have different causes. So when we speak of stress urinary incontinence, like the first thing that comes to my mind is the first initial question that follows is like, do you feel something falling down? Because stress urinary incontinence is always related to prolapse. So when the organ from in the pelvic floor area, the bladder, the urethra, the uterus, the vagina, the rectum, or even your small intestine or large intestine goes down or descend, or there's a change in the position, usually there's a stress urinary incontinence. Another aspect, it could be like a weakness on the core, like the patient doesn't know how to coordinate the core with the breathing, or instead of them like breathing in when they should be going back to resting position when they're exercise, they are like doing the opposite. So then there's an increased intra-abdominal pressure, which pushes the organs out of their original position, and that can cause stress urinary incontinence later on. And then the next kind of incontinence is called urge urinary incontinence. So from the word urge, this patient present increased urges. So I educate them about the right frequency of urination. So I ask them how many times they go to the bathroom. at night and during the day. So the normal for nighttime urination should only be maximum of 1 to 2 times per night. So patient comes to me and they are like peeing every 15 minutes, every hour at night, and they are tired, they are weak, they feel so overall exhausted because they did not sleep all throughout the night. And so this affects their ability to even regain strength or to make their muscles strong or their bones strong, because we all know that growth hormones are only released when we are sleeping deep. And then even our immune system is only because our melanocytes are released also when we are sleeping, because that's the time that the system of our body is repairing. So these people goes to the bathroom at night many times, and so you expect from them lots of other medical issues. Their immune system goes down, they have lots of other infections and lots of other issues aside from having urge urinary incontinence because they cannot sleep at night. And then during the day, you have to ask them how many times they go to the bathroom in 2 hours. So the capacity of our bladder is around 4 to 5 hour maximum, and that is around 400 to 600 ml of urine. So for a normal individual, they should only be going to the bathroom 1 time in a period of 2 hours. So if a patient is going to the bathroom once in 2 hours, then they have urge incontinence or more than 2 at night. So I ask them how to do a bladder diary, and usually I ask them to do a bladder diary of 1 to 2 days, and I usually include like Friday, Saturday. One of them should be weekend, because sometimes our activity for the weekend is different, and that is because with urge urinary incontinence, the treatment is part of the treatment is suppression technique. And when we say suppression technique, from the word suppress, you will try to suppress the overactivity of the bladder. So you can only treat it individually depending on the presentation of the patient. So you need to know what is the minimum interval time for the patient when they go to the bathroom. Like when you look onto their bladder diary for 2 days, you need to see what is the minimum interval, and you can only suppress the bladder for a maximum of 5 minutes each week. So when the patient, for example, is going to the bathroom at a minimum interval of 30 minutes, and you want to challenge that to 2 hours, because that's the normal, but you cannot go to 2 hours immediately, because you will fail. The bladder muscle, the detrusor muscle, is not strong enough to hold that kind of urine, because it's been voiding like in a short time, and so that muscle weakens over time. So you can only challenge that bladder for 5 minutes each week. And when the patient is not struggling for that 5 minutes each week, then they can progress 5 minutes each time. So this is how I treat my patient until they will tell you, oh, I'm like, I progressed already from 30 minutes, and now I am like doing it like every 45 minutes, until finally you will be able to get to the 2 hours normal time. And from there, they can just progress further and further if you educate them how to do their own suppression and do all the other exercises and management. And when it comes to urge urinary incontinence too, because of the overactivity of the bladder, you need to educate the patient that before you can bring them to the normal ability of the bladder to hold urine, it's not only strengthening the pelvic floor, it's not only suppression technique. You need to educate them that there are certain foods and drinks that can irritate the neck of the bladder and will give them that urge of urination, and those are what we call bladder irritants. So you need to let them know that anything that has caffeine, anything that is carbonated, anything that is sweet, with dairies, cocoa, alcohol, those sugar, and even like sour fruits, it can irritate the neck of the bladder, and they can feel the urge more than usual. So other picture of urge urinary incontinence is when they hear running water, when somebody tell them that they need to go to the bathroom, or somebody just remind them of the bathroom, or they see the bathroom, or they reach their home and they're just parking and that's their what is this, comfortable area or comfortable place, and they will feel like, oops, they're starting to giggle because they're feeling the urge already to pee. So that's the picture of urge urinary incontinence. And usually it's because of the inability of the pelvic floor to contract. So when we say the pelvic floor cannot contract, it's either because the pelvic floor is way too stretched, or the pelvic floor is weak, or the pelvic floor is very tight. And when we talk about tightness, it all comes from abnormal posture, because maybe the posture of the person is abnormal, that the pelvic floor is the only one that is catching up that weight of the head, the trunk, and all the organs, and is in constantly overly contracting all the time, to the point that time will come that the length of your pelvic floor is so short and it cannot even close your sphincters. So those are the things that can cause and the presentation of urge urinary incontinence. And it's very important that you educate your patients what's the difference between the two, because the treatment along the line are different too, although they are also related to each other. And then when the pelvic floor issue is already like more advanced, then you can see both presentation of stress and urge urinary incontinence at the same time. So the patient is not only leaking like when they cough or jump, they're also leaking like with the sight of both of them are present, sight of water, running water, so just basically they are leaking most of the time already. So that's what we call mixed urinary incontinence. So the last kind of incontinence that we see in adult is functional urinary incontinence, and that is related to their inability to bring themselves to the bathroom because of mobility or safety issues. And the next one is bowel issues in elderly. So when we talk about bowel issue, we have constipation, diarrhea, and bowel leakage. So for years, I struggled. Like, I really struggle treating bowel issues. I feel like when we talk about urination, it's easier. You modify the drinks. You tell the patient to drink 1/2 of their body weight in water to maximize the ability of the bladder to hold urine and to strengthen the muscle of the bladder. But when it comes to bowel, it's like more complicated, because we don't talk about nutrition in physical therapy. So I've come to the point that I was like telling my patient, drink 1/2 of your body weight in water, eat 25 grams of fibers, do not eat like processed foods, do not eat sweets. And then like the patient will still come back to you and it's like, I haven't pooped for like 7 days. And I was like, oh my God, like what will I do? Like maybe I struggled with this issue for like years. And then you would ask them like, what does the doctor like tell you about this? And they undergo like a colonoscopy, but there's really nothing in there. Some of them have like Crohn's disease, IBS, they have like colitis, and they don't poop, or sometimes their poop is like water. And it's really a hard thing until I realized that I need to understand more about nutrition, because I cannot advise them what to eat. Like basically when they go to the doctor will give them Colace, metamucil, but metamucil is only 2 grams of fibers. We know that patients should be like having like 25 grams of fiber a day. So when I assess their bowel, I usually present to them the Bristol stool chart. So you can see here different kind of bowel, from like pellets to like sausage lumpy, sausage with cracks, and then type 4 is the normal bowel. This is the one that you like. It's soft, it's formed, it doesn't have crack. And so this is the normal bowel, and this one and 2 are constipation. Type 2 is like type 1 is the patient is like in the bathroom for more than 10 minutes or 30 minutes, and only one small bowel came out. And then second one is like when the patient is like shouting in the nursing home, like they are being castrated because the bowel cannot come out because it's so dry and big. So we wanted type 4. And type 5, 6, and 7. 7 is diarrhea, and 6, 7 are both diarrhea. They are like wet bowel. And so we wanted to bring our patient here. So every time they come, you ask them, like, so how's your poop? You teach them how to assess their poop because poop is very important. So I always tell my patient, like, there are 3 most important things in order to be healthy. First thing that you assess is your sleep. So we need to be sleeping 7 to 9 hours. I incorporate this in my practice because if the patient is sleeping good, you are activating your vagus nerve, you are activating relaxation, you are activating gut function, and so you are activating healthy transit time for your bowels. And then the next one that I ask is their bowel. So I ask them to assess their bowel, and the last one is blood sugar level. So, and that is when my functional nutritionist certification like comes into practice because I have to advise this patient about their nutrition too. So the next one that I usually see with elderly when it comes to pelvic floor is pelvic organ prolapse. So this is related to stress incontinence. So I have told you a while ago that there are 3 organs in your pelvic floor. So the first one is for female, this is the normal one here. The first one is your bladder and urethra. The second one is your uterus and your vagina and the rectum. And then here you have your female on the bottom left. You have your male pelvic floor, which is your bladder, urethra, and your rectum. So these organs, when the pressure inside your intra-abdominal pressure is not normal because of abnormal posture, because of abnormal breathing, because of pain, and because of abnormal coordination of breathing and movement and everything, and plus hormonal issues, this organ can come out, and they are called pelvic floor prolapse. So they are different presentations. So the first one here is your anterior vaginal wall prolapse. So if you look on the bottom, the front aspect of the vagina is descending down. And then the posterior aspect of the vagina can also go down, and that's what we call posterior vaginal wall prolapse. And then you have here urethrosil, wherein your urethra comes out, and you can see it like falling out. Like if you do your internal assessment, that you should see the vagina as just a hole. Like it should just be just a vault. You should not be seeing anything that is poking like from the top or from the bottom if they are in supine. But here you can see the urethra coming out. And then the next one is you have your uterine prolapse. The uterus can also go out of the vagina, just like this. And then you have your the vagina can fold on itself from the cervix, especially for people who have hysterectomy, wherein they remove the uterus already, and then they attach the vagina somewhere else, either with a stitch or ligaments, and that the vagina can fold by itself and go down the vaginal introitus if there's an abnormal pressure in your abdomen, or if you don't know how to protect your posture. And then the small intestine or the large intestine from the upper abdominal area along with the peritoneum can also go down, and that's what we call enterosil. So, and the rectum can also go down, and that's what we call rectal prolapse. So we have like a grading that we use for these kind of things. So usually when I grade my thing, which is like you go via your second, we call it PIP, and you put your finger on the level of the remnants of hymen, and then you will ask your patient to bear down. And then when you see any of these organs coming down, you grade them like according to how much they descend. So around 1 centimeter, you're grade 1. around 2 centimeter, you are grade 2. When the organ already is on the entrance of the vagina, then that's grade 3. And for grade 4, you are sending them down to surgery because it's already down here, out onto the pelvic floor. Okay, so the next common issue affecting pelvic floor, of course, is pelvic pain. So when I say pelvic pain, it's not only a pain that is affecting in the vulva area. So I address patients that have like symphysis pubic pain because that affects the ability of the pelvis to stabilize and to form its closure during activity. There is like SI pain, there is tailbone pain, hip pain, sciatic nerve pain, pain down the legs, because sometimes people think, oh, it's sciatica, it's coming from the back. But I've seen a lot of patients wherein it's not the sciatic nerve itself. It's the pudendal nerve that is being impinged in the pudendal canal that is causing the pain down the leg, and it's presented as sciatica. So that's also included in most common pain that you see in elderly population. And so we address that too, but most of the time, aside from the pelvic floor, pelvic pain, you're also addressing like issues of the abdomen itself. Because if the core, of course, you have your rectus abdominis, you have your transversus abdominis, you have your external oblique, your internal oblique. All of those close the abdomen in order to have like a good intra-abdominal pressure and to support your spine. And sometimes after pregnancy or with people who have obesity, they have pain on that area because of weakness of the abdominal wall. And so I also encounter a patient here who have like diastasis recti. And that's one of the one that I incorporate with pelvic floor therapies in my practice, because most of the patients that have pelvic floor issues have separation of the heads of the rectus abdominis too. And this usually happens after pregnancy or with obese individual. Okay, so when moving forward, after hearing 4 of the most common things that we see with elderly population, we have I wanted to discuss the quality of
Excuse me,
life.
Doc Net, 3 minutes to close, okay? And then they
Okay.
can ask question via chat. Thank you.
Okay, thank you. So I'm really trying my best here. So when we talk about the quality of life with elderly population, of course, their overall comfort is affected due to the pain. They are prone to multiple urinary tract infections if the pelvic floor is not bringing their bowel or their urine out properly, because supposed to be after urination, there should be less than 50 ml of urine left in the bladder. But some people after ultrasound, they are always having UTI because the tightness of the pelvic floor is not allowing them to void fully. And so there are tendencies that bacteria can reside down there, and then they will have multiple UTI issues. Then because they are always wet because of the moisture from urine and from the bowel, they also prone to skin integrity, and because of the loss of fluids, there's always dehydration, which leads to confusion and eventually to fall. So when I do my pelvic floor rehabilitation, education is very important. You need to educate them about the pelvic floor functions, about the signs, like you need to differentiate what are the different kinds of incontinence, about the impairments that you see in them during their evaluation, their posture, their breathing, their tightness, how they compensate the movement of the trunk and the leg with posterior rotation or anterior rotation of the pelvis, or elevation of the rib cage during breathing. All those things, you need to let the patient understand what you are working for. Because when they understand the issue, they will tend to comply with it more. And also with self-assessment, they need to know how to assess how many times they go to the bathroom, how many times they do their bowel movement. And so with their modification of the nutritions that they take in, the fluid intake, the fiber intake, their sleep, their ability to relax, because our body doesn't heal when we are in a fight and flight mode. They need to understand that they need to have a moment of rest and digest. So, and then I always tell them that they need to know that processed foods are not good because they tend to move very slow in our digestive tract or in our guts, and they need to go away from food allergens because those doesn't do good with their guts and just will cause more issues and inflammation. So as I talked a while ago, I already talked a lot about strengthening, and it's not only pelvic floor strengthening, it's not only core, it's not only the extremities, but it's also the pelvic, the abdominal wall. And then for people who have like very tight pelvic floor, we need to do stretching. We teach them stretching exercise. We incorporate fascial release. We incorporate breathing. We incorporate joint mobilization. And when the joint is not really moving or the muscle is not really relaxing because my hand cannot reach it or stretching is not giving way, then we do dry needling. And of course, we need to coordinate all those activities with movement and pelvic floor stabilization. And at the end, I always progress my patient with balance and postural stabilization, and of course with functional progression. So you need to ask, when are you leaking? What are you doing when you leak with stress incontinence? Are you doing vacuuming, stuff like that, running or walking? And so we need to do standing exercise, running, walking, and coordinate the pelvic floor with breathing and with the activity itself, so that you are sure that at the end of the treatment, the patient knows when to use that stabilization of the core, breathing, and a pelvic floor with their activities and prevent leakage. Okay, I think I did my best to put all those things. I feel like I'm panting. It's a very long topic, but I tried my best to just cover the most important things that I see with most elderly population. And I think I'm open for questions.
Yeah, I just told them that they can ask some questions because we ran out of time. We are now heading to our next speaker, but definitely put your questions there and Dr. Net can answer also. Dr. Net, please also put your social media or email so they can ask further questions, especially for our colleagues who are looking forward to learn more about pelvic floor and to be a specialist like you, and also your functional nutritionist, lifestyle medicine as well. All right. Thank you so much, Dr. Net. And then I will going to stop sharing and I will be the one started, and would love to thank you for this opportunity for sharing your skills and knowledge and expertise about pelvic floor. All right. We appreciate you so much, Dr. Net, and this certificate of appreciation presented to you, Dr. Nedry Nagsalda, and for sharing your knowledge and expertise as one of our speaker for the Geriatric Rehab Summit 2024, August 17. And this was certificate given today in Delaware, USA. All right. Thank you so much, Dr. Net, and connect with Dr. Net via chat, guys, if you have nice and great questions, okay? All right. So we thank all our sponsors. We have a wonderful Age Wiser video and talk about. So these are not only fall prevention, but it's also good cognitive training. And they're really wonderful. And I even installed that last night. So if on our recording, I will going to put the link, but I asked Swati Balantrapu how to download this. It's now available via Google App or App Store. You just like the clock yourself. You just check Age Wiser and there you go. So it's for you to learn more. All right. For our next speaker, we have Coach David Bailiff. He's the co-founder and coach of Uncaged Clinician. And of course, Coach Kevin DeGroot, he will be also one of our speakers. So I would love to introduce both of them at the same time. Let me see if I can do that now. All right. So Coach David has been practicing physical therapy in Scottsdale, Arizona since 1994. So he started his cash-based mobile practice in 2013. Other clinicians who started hearing about his practice model began reaching out to him for guidance toward making a similar jump. This led to a transition into business coaching in 2019. So today, he is the co-founder of Uncaged Clinician along with his business partners. So we have Coach Josh and Coach Kevin. Coach Kevin is here with us as well to present the entrepreneur success secrets. So at Uncaged Clinician, they coach, lead, guide, and mentor others to start their own practices. They do so by loving unconditionally, serving selflessly, caring deeply, and leading others to do the same. So Uncaged Clinicians believe that the world is a better place when business owners can authentically engage in their communities. So every time I have a summit, I balance it with medical and learning opportunity, and at the same time, business, mind, entrepreneur opportunity for our clinicians who are looking forward to learn and at the same time to have knowledge about business growth. And then we have also Coach Kevin. See, he is also the CN coach and partner. So let's introduce Dr. Kevin DeGroot. Coach, we have him. Is this really what healthcare is supposed to look like? That's what Coach asked. Kevin DeGroot, our coach of Uncaged Clinician, is a dedicated physical therapist, often found himself questioning this. So he's a physical therapist as a background and wasn't just a job for him as a physical therapy. So, however, with each job, he felt increasingly unable to represent himself authentically, which left him feeling frustrated and trapped. Realizing he had to make a change, Kevin decided to start his own practice with 3 primary focuses: giving clients the care they deserve to achieve more than just the bare minimum, providing job opportunities for clinicians feeling stuck, and allowing himself to be authentically represented in all he does. This bold move opened up opportunities for Coach Kevin to help support other businesses in doing the same. Eventually, he partnered with Uncaged Clinician to support individuals who, like him, are unwilling to compromise on their values and ambitions. On coaching calls, Coach Kevin often emphasizes that the one question no one else can answer for you is whether you believe you can do more. Once you decide that, he and his team can support you with the how. And for this afternoon, we will learn more about the entrepreneur success secrets. All right. So let me give the floor for our both coaches. So let me see both of you, Coach, and I can pin you. You can talk now.
Hello, Jenny.
All right. So
Hello,
let
Jenny.
me,
Thank you so
yes.
much for having us.
So let me see how I can pin you because I can do that. Nice to meet you both, gentlemen.
Yes, good to see you again, Jenny.
Good to see you. Thank you for having us.
Yes, an honor to be here.
My pleasure. All right, and then I
I'm
look.
going to
So I will, as we kind of get started, David's gonna post I see Jenny's face, and that makes me happy. We joke with our clients all the time that well, me in particular, I'm super ADHD, and I feel like I'm talking to myself. I'm like staring into the corner, doing all sorts of weird things while I'm presenting. So if people are willing to hop on the screen, we love that. We also we do this all the time. We get to present to people, and we are not afraid of questions. We are not here to answer questions at the end. If you have any questions along the way, feel free to post. I know that this is a kind of a more international summit as well, so we'd love to hear where people are from. I put that in the chat section. But David, anything else that you wanted to say to introduce yourself before I'm going to share a quick story?
Yeah, no, absolutely. Again,
Coach
first
David,
of all,
wait. Just make it like full view. It's not yet full.
how about
All
now?
right, perfect.
There
Thank
we
you.
go. Thank you, Jenny. Now, first of all, just again, thank you, Jenny, for inviting us. It's always an honor to join you and your crew. You always have a great crew here, and I love what you're doing. Kevin and I, we've known each other since 2018. We've been working together since 2020. So we're coming up close to 5 years, which is amazing. But we just, we love doing what we do. As Kevin mentioned, that we have a lot of opportunities to speak to other people, and something that what people will probably get from us is that he and I love to just have a conversation with each other and with the audience. So yeah, we have some slides, but it's probably going to be more of some bouncing off of each other back and forth, because we like for it to be casual, hopefully entertaining, but definitely informative. So Kevin, in case it wasn't mentioned, Kevin is there in Denver, Colorado, and I am in Phoenix, Arizona. So we get to work together virtually, but every now and then we do get to actually experience each other's company in person. So it's awesome.
In Colorado as well. Love that. So I want to just kind of clear the air with a little bit of a story before we get started. Entrepreneurship is oftentimes a scary topic, and I think it's interesting, not to contradict what Jenny was saying, but I think it's interesting that there's often this, like, we have the clinical side and we have the business side, and we want to talk about both of those things, but they're separate. And in my bio, it talks about how I felt frustrated as a clinician because I couldn't serve my clients to the way that I wanted. And I want to share a more personal story from the last few weeks, more on geriatrics. And my wife, her grandmother's been sick. Not been sick. She has your like typical kind of situation that happens with somebody of her age. She was actually at a Zumba class. She's 90 years old. She's at a Zumba class, crushing it, dancing her little heart out, and then got dizzy, fell, broke her hip, which is not a fun thing for somebody who's of any age to have happen to them. And broke her hip. She was in good enough physical condition that they decided that she was a candidate for a total hip replace or for a partial hip replacement. So she goes and does a partial hip. She wakes up from anesthesia feeling pretty good. She then goes and is about to get transitioned towards the rehab center, and she aspirated on throw up, which is not necessarily the most fun thing to hear, but she aspirates and then took a turn for the worst. So they, instead of deciding that they wanted to keep her in the hospital, they discharged her to the rehab center. Hygiene wasn't necessarily great there. She ends up exposed to E. coli. She ends up with blood infection. She ends up with all these different issues. And they came in one day and say, we're not sure that she's going to make it. And she might get better, but if she doesn't respond to this one particular type of treatment, we just don't know if we can do much. And all the while, as a healthcare professional, I'm sitting here and I'm like, you mean to tell me that she has an infection and all you're going to try is one antibiotic? Like that's really the best that you can do. And it's super, super frustrating as clinicians to hear those types of scenarios with our loved ones. But I think no matter where we live in the world, I think we can all agree that there's something broken about the way that we do healthcare. I think that that's a fair agreement, whether you're in Denver or Arizona or Germany or the Philippines or wherever that is. I think we can all look and we can say that there's something that's broken about our healthcare system or healthcare in general. And mine and David, and with Uncaged Clinician, it's not just about entrepreneurship as the importance of this. What we're looking for in healthcare is to empower people to be grassroots change agents in healthcare. So I know that this says entrepreneurial success secrets, and that is what this is kind of intended to be for. But from a more motivating perspective, every single one of you, whether you own a business or you don't own a business, or you're terrified to start something or not, we all believe at Uncaged Clinician that to be uncaged means that you get out of the rat race of, well, this is just the way that it is. And so we're going to present a variety of different things today. And if you think of yourself as an entrepreneur, if you think of yourself as a business owner, if you think of yourself as somebody who will never do one of those things, it's okay, because we're all kind of in this together with the belief that we want to uncage ourselves, not just as business owners, but we want to uncage ourselves to be able to treat our clients with the dignity, value, and respect that they deserve as high-level professionals. So that's my kind of inspirational monologue for the start of this. Just to make sure that all of you realize, like, you're in this with us if you're trying to change healthcare.
Exactly. I love that story, Kevin. And you brought up a very good point that I just want to make real quickly. And yes, it says entrepreneurial success secrets. So you could take this to meaning like, hey, this is for you if you want to start a business. You could take it that way. But with what Kevin just shared, everything we're going to present to you today, even if not owning your own practice, is even in your wheelhouse or in your, as director of my program would say, your bailiwick. All right. Even if it's not in your thought process, everything we're going to present to you today, you can apply to your own self to be uncaged for yourself, to change that brokenness that Kevin spoke of. So I appreciate you sharing that, Kev.
Yeah.
Yep.
So the first thing that we're going to start talking about is this really important idea of why are you doing what you're doing? So there's a really interesting book called The Power of Why, or Start with Why. Both are great, and it talks about knowing your why. Why do you do what you're doing? And David will reiterate this as well, but most of the time we get on calls with people who want to be business owners, and we say, why do you want to do this? And they talk about all of this first thing, which is intrinsic whys. Why does your business have to exist for you? And they talk about how they're not getting paid enough at their other job. They're not getting enough vacation time. They're not getting enough time, CEU credits. They're not getting enough, whatever, you name it. And the businesses that we see succeed most are people who they do have an intrinsic why, but they also have an understanding of an extrinsic why, which is, why does your business have to exist for your community? Those are the people who are more missional and in focus. It's like, obviously, like making more money as a clinician, making more money as a provider, having more freedom, having more flexibility. Those are all great things. But at the end of the day, no one really cares about those things except for you. And what we encourage all of our clients to really understand is, what is the extrinsic value or extrinsic mission that your practice seeks to solve? And again, if you're not a practice owner, what is the extrinsic value of what you provide for your clientele?
Yep, absolutely. Along with that, I would just add that, we hear so often, hey, why do you want to start a business? And it's kind of like when you enter into PT, OT, speech therapy school, usually the answer is because I want to help people. I want to change people. We hear all the time, because I want to be able to treat people the way that I want to treat them, and I want to give them the care that they deserve. And those are wonderful, wonderful things. But what we want people to recognize is those things are what you do. What are the reasons behind doing that? And that's why we have people sit down and really think about, why are you putting it all on the line? What's in it for you? And those are going to be your personal reasons. But why is it that your practice has to exist for the community? And those business owners, and again, even if you're not a business owner, if you understand more why you truly are a therapist, it's going to change how you practice. It's going to change the relationships that you build with people. So, but those who really understand these things, they end up going a lot farther in whatever capacity they're in, because they're so groundly rooted in what they're doing. So.
So the next thing that we're going to kind of get into is there's 9 characteristics. I mentioned my wife earlier. My wife is one of our coaches. She's a clinical counselor, so she works a ton with mental health, anxiety, depression, different types of things, and we include her in our coaching programs because through the years we've kind of realized that the number one thing that holds people back is their mental health. I'll throw a mindset in there, but when we talk about mindset, we as a coaching business, we hear of so many other groups that it's like, just own your power, know your worth, know your value. Not to throw this one under the bus, and sorry for the language, but you are a badass. Like, that's the kind of the attitude that a lot of places come at mental health with. And we've seen it time and time again that just telling yourself that you are amazing doesn't really solve problems. I don't know if anybody's ever, it's like, yeah, like standing in front of the mirror every morning and doing some morning mantras is like, it can go a little ways, but at the end of the day, that's not going to really solve those problems. And so Hannah and I, we were sitting down one time, and I was like, I feel like there's certain characteristics that we see in entrepreneurs, like time and time again, that show up. And those are the people, when we meet them, when Josh, David, Hannah, myself, etc., when we meet those people, we're like, oh, this person's going to crush it. I know that this person, it's not going to be easy, but I have a really strong inclination that they're going to do really, really well. And so we came up with a list of 9 things that when we look at them, when we see these people, like, yeah, that person's got it. We'll get into this a little bit later as well, but one of the things that's really important to know is that this is not an inherent trait. These are not just like you're born with them characteristics. A lot of these things are actually things that you have to work on and you have to develop. They're muscles, they're skills. There's a lot of things that are not just ingrained in who you are, that if you develop them over the course of time, they will, again, not only help you be a more successful entrepreneur, but they'll help you become a more successful clinician. So David and I are going to kind of bounce back and forth with these and share a couple stories. Again, if you have questions along the way, we'd love to answer them as we go. But characteristic, and again, not in any particular order, but characteristic number 1 is that successful entrepreneurs are disciplined. So I'll let David kind of kick this one off.
Yeah, with that, it's simply understanding that, really, if you want to be a business owner, building a business, building a practice, getting it started, honestly, it's not the hardest thing in the world, but it's not easy. You can do things to make it simple, but not everything building it is fun. You've got to put in the work, which means effort. And honestly, we see some people who just the effort there, or the effort is not there, putting in. So you've got to be disciplined enough to put in the effort to do the work. As far as being disciplined, it's being able to identify. And I'm sorry, people. I had surgery a couple days ago. I'm still a little bit groggy. I apologize. But you're able to identify what's going to move the needle today, and they're able to focus on what do I need to do today, and they have a very short to-do list to try to accomplish. They don't have a long laundry list. It's a short to-do list, and they spend each day with intentionality of accomplishing those things. So those are kind of some key character or key parts of being disciplined, is that putting in the effort. That it's not always fun. It's not always sunshine and rainbows. Sometimes, there's some challenges. But again, all these things, going back to those whys, going to help you to get through those challenging moments. And they are able to just recognize, how do I need to be intentional today to move the needle forward?
Another aspect of this that again, if we got some attendance participation, it'd be fun to see how many people would answer this truthfully.
Mhm.
But so it's Saturday. If you didn't have to show up to work on Monday, no one was going to yell at you, no one was going to like ask where you were, how many of you would still show up? And that is true, right? It's like David chuckles. When you're an entrepreneur, when you are building your own business, there is no one who is going to call you and ask you where you are. There's no one who's going to say, hey, why didn't you show up to work today? Yeah, you might have some clients that'll be like, hey, you didn't show up to our appointment. So you're kind of working for them. But what about those times when it's, the difference between like, true story for me, like wandering around Costco or deciding to work on my business. It's like I would just wander around Costco when I was first getting started because I had so much freedom, and freedom's great, but along with that, it's the discipline necessary to say, I don't have to show up to work. No one's going to yell at me. No one's going to, call me and tell me that I'm fired. But I have to have enough discipline when I don't have a boss that's going to check in on me to say, I'm still going to work. I'm still going to focus. I'm still going to be intentional. I'm going to show up. I'm going to do it. Not because somebody's going to yell at me, but because I actually have that intrinsic motivation and intrinsic drive and discipline.
Yep.
So moving into the next one, they manage stress. Successful entrepreneurs manage stress. And one of the things that I've again noticed over the course of coached business owners and physical therapists for probably I think it's 6 years now. And most of the time people who quit, it's not because of financial stresses necessarily, or not because they don't have the money, not because they can't do it. It's because everything in life starts to bang into each other, and they start to get stressed, and they start to have challenges with managing their different roles and responsibilities, and they have the ups and downs of, when clients are coming in, they feel great. When clients aren't coming in, they feel stressed. And most of the time, people who quit, it's because of number two. It's because they look at it and they're like, I just feel stressed all the time. I feel like there's just so much weight on my shoulders that I don't want to handle anymore. And so we go back into your kind of JOB, go back into that, and it's like, well, that's less stressful. That's less, it's more predictable. It's easier. It's simpler. We're just going to go back to doing the things that we've always done, even though those things never got us where we wanted to be, never gave us the life or the ability to treat people the way that we wanted. But we go back to it because it's less stressful. And that is fair, right? It's like David mentioned, that being like starting a practice is not it's not difficult. It's not rocket science, right? It's not the most impossible skill set to develop, but it is challenging when it comes to managing your stress, managing your expectations, managing the ups and downs that come in. And so that's again why we as a program include a mental health professional for every single person that we work with, is because we want to be proactive about managing stress. David, any additional thoughts on that one?
I just to kind of just take what you said one step further, which was beautiful, is that what in managing stress is it's how they talk about the stress, rather than saying that maybe I'm dealing with some stressful things right now versus saying I am stressed. Because what happens over time, like Kevin said, is that all these things can start to butt heads and you create a perfect storm. So now when you constantly tell yourself, I am stressed, now you start to adapt that as your identity, and it changes how you are moving forward with each day, because you see yourself as a stressed person rather than knowing really who you are in identity, and that there are just some challenges in your life. So that's the main thing about the stress. Resourcefulness, stress kind of goes into resourcefulness a little bit. Couple things I just want to say about that right quick is that recognizing that as we grow, things are going to change. We have to expect things to change from time to time. And expecting that change can help us in our resourcefulness because we can anticipate it. But sometimes, and I see this all the time, and I know Kevin sees it too, is that people tend to become hyper focused on what's the next thing that I need to learn? What's the next thing? What's the next new marketing technique? In fact, I was just talking to my wife about this morning, is that people focus on, hey, there's got to be something new out there. And oftentimes the resourcefulness isn't what's the next thing that I need to learn, but rather what do I need to remember from the past in order to move forward? And it's amazing. I mean, it sounds simple, but it's amazing how often people forget about the successful things that they've done in the past because they think, well, yeah, that worked then, but I got to do something new. So it's just being reminded of the old sometimes is part of resourcefulness. Another is that there are failures and wins are lessons. You always hear about, looking at a failure as not as a failure, but as a lesson, but also looking at wins as lessons as well. I saw a great interview with, in my opinion, the all-time greatest tennis player ever, Roger Federer. And Roger Federer won something like 1,500 matches. He won 80% of his matches that he played in his life. But he said, I was curious of the 80% of those matches that I won, how many points did I win? And so then when he broke it down of all the matches that he won, and then again, he won 80% of his matches, but when he looked at the number of points, he won only 52% of the points that he ever won. So he said, even the greatest at something lose half the time. So he said, the way that I was resourceful was that I looked at each point. It didn't matter if I missed the worst shot ever, it was only a point. Didn't matter if I made a shot that I knew was going to be on the ESPN top 10 list, it was only a point. So looking at each day, because you're going to have some challenging times, again, whether you're an entrepreneur or you're a staff member, you're going to have some challenging days. Looking at that as just a repetition, something to learn from. When something goes great, looking at it as just as a repetition. So being able to kind of temper those emotions, the highs and lows, if you will. But that's what I have from that, Kevin. Other than also, as far as resourcefulness, is knowing when they need to ask for help. That we can't do it alone.
For sure. And then we'll get to that one in a little bit as well, but happy to go to the next slide.
Yeah, okay.
So characteristic number 4 is having a growth mindset. With everything, there's this there's an opportunity to get better. Kind of what David was saying with Roger Federer. Like growth mindset means that you can get better. There's more out there. Along with that is having an understanding that there's no such thing really as competition if you're doing things properly. There are people who are in the same space, who are in the same sphere, who are kind of functioning within similar areas, but having a growth mindset and having kind of that blue ocean mindset is understanding that there's plenty of room for every single person that wants to do this. And it doesn't matter. I think it's four physical therapy practices or 4 physical therapy groups within probably 400 yards of my location in Denver. And it doesn't matter. It doesn't matter to me that all of them exist because we have a growth mindset and know that there's room for every single one of us. There's opportunities for every single one of us. And along with that is to just recognize that you are not going to be able to, you might not be able to solve the problems that you have today with the knowledge and the experience and the expertise that you have, but you can grow into the person who can solve those problems. And so just recognizing it's like I beat myself up all the time about mistakes that I made when I was 16 or 18 or 21 or 25. And as in my mid 30s, I can look back and say, as a 35-year-old, I would not make the same mistakes that I would have that I made as an 18-year-old. And that's good. That's fair because I don't have the same knowledge or experience or expertise that I did or that I did then, right? And so I make different decisions now than I would have back then, which is normal. I grew from those. I developed, I matured from those things. So having a growth mindset is huge.
Yep, absolutely. With that, they simply don't let others determine what their success is. They know their values with unshakable faith, and every decision that they make is in line with those values. So don't let others determine their success. But one key thing about that growth mindset, and please hear my heart here when I say this word, winners will always support and celebrate other people, whether it's on their own team or even if it's their quote unquote competition. Winners, entrepreneurs who are successful, they will celebrate other people. And that's part of recognizing that there's plenty to go around, accolades to be handed out. You're never going to lose by giving someone else kudos. So knowing how to lead, some of this we're going to get into with the last couple of things, but really leading, we're talking about leading others, not necessarily being a successful entrepreneur, but just leading others. There's humility, there's compassion and listening. Those three things go a long way, and you're gonna gain a lot of trust from other people by having humility, listening, having compassion. It's going to take you a lot farther. Again, whether you're a staff member, a director, a clinic owner, whatever that may be, when you have those, when you know how to lead people, you're never going to lose, and you're going to go a long way.
And my quick 2 cents on this one as well is we're not talking specifically about leading a staff.
Right.
In this one, we are talking about leading your clients.
Yep.
There are so many people that I meet, and I engage with them, and they have this kind of deer in a headlight look of, I don't know what I'm supposed to do. I'm scared. I've never had this experience before. I've never been through this before. I've never felt these things before. And they look at me as a doctor, quote unquote, whatever. We won't get into that debate right now. But they look at me as their physical therapist, as a doctor, and they say, effectively, Kevin, please lead me, help me know what I'm supposed to do. We trust you. And one of the most important things, I tell this to my staff, and I tell this all of our engaged clinician people as well, is that I think that there's this perception in physical therapy school that we need to solve and figure out all the problems in the first session in our evaluation. I disagree with that. I think the most important thing that I can get in my first interaction with somebody is that they trust me, because I have the ability to learn and develop and get to know them more, and I can do more digging into their problems if they trust me. But if they come and they bounce right after the first session, I don't care how good my clinical reasoning skills were, they didn't trust me enough to stick around. I'm never going to solve somebody's problems that way. So what we encourage people to do is to develop their leadership skills, not as a like, I'm going to talk down at you because I'm so much smarter than you, but I'm going to walk alongside of you and bring you from a place of difficulty and challenge to a place of hope.
Yep, great points.
Moving into, I think we're at number 6. So is people who are passionate about their work. This is a really challenging one for me, because I think that there's that like resourceful, I'm really high resourceful skills. And there are times when I'm not the most passionate about, showing up to work and doing the things that I have to do. But in the long run, being excited, being passionate, being mission focused, being engaged with actually solving big problems and wanting to actually do something that's bigger than just getting a paycheck. Those are the clients that we work with that always have better success. So similar to, talking about mission and talking about that, why you do things, we could probably relabel this as they understand the importance of what they do, and they're passionate about the mission that they're on.
Yep, absolutely. And they look at what they do as they get to do it.
Exactly.
Yep.
Number 7, I think if one thing can be changed in the like healthcare space, or at least as like physical therapists, occupational therapists, etc., is we need to be better communicators. This is again one of those things that we develop over the course of time, and in learning how to engage with people, learning how to not manipulate or coerce people, but to walk alongside of people. That's good communication. I'm actually David's going to be happy that I reference a book during this presentation. I'm just finishing a book called Super Communicators by Charles Duhigg, and it's all about how people like certain characteristics of people who he would describe as super communicators. And it's those people who have the ability, no matter what group they're talking to actually get into their head and understand and empathize, and not just empathize so that we can tell people like, all right, now here's what you have to do because I'm, the all-knowing physical therapist, all-knowing medical professional, but it's people who have who really understand the pain points and the difficulties and the frustrations and all those different things, and draw people forward, not force people forward, but draw people forward. And this is also one, I know we're running close to time on our portion, but I think communication is one of the things that changes from when you are a clinician to when you are an entrepreneur, when you are a business owner. The level of communication you need to have when you actually get involved in marketing and sales and closing, like converting clients into full plans of care and those types of things, it just matters more. So if you are interested in being an entrepreneur, if you're interested in being a business owner, communication is probably one of the most important things that you can develop.
Absolutely. Real quickly, the thing about this whole entire list and everything is that they all build on one another. The more that you have clarity over your whys, your intrinsic, extrinsic whys, your communication is going to change. The more that you improve your communication, the more you feel resourceful, the more you have a growth mindset, your confidence is going to grow. All these things help one another to grow. So if you look at this list and say, oh my gosh, I've got to grow in all these areas, they say that, whatever it is, tides rise all ships together or whatever. Kevin knows those things better than me. But everything's going to really kind of grow together. So don't look at it as like, oh my gosh, I got to focus on all these different areas. They're going to grow together. Confidence. People are able to just simply rise above the noise. They don't listen to the naysayers. As I mentioned, winners support other people who are trying to do what they are trying to do. You don't, if you hear someone chirping at you, if they're talking bad about you, it's because that you are doing something that they wish that they were doing. So they're able to rise above the noise. People are grounded in who they are. They know exactly how they impact people and what their gifts are. When you know that, your confidence grows. When you know how you impact people and what your gifts are, your communication is going to change. And then finally, they're willing to just step into being uncomfortable in order to grow. They have the confidence to pursue success. A lot of times, we say people, I'm afraid of failure, but I think a lot of times people are actually afraid to pursue success. So they are comfortable or confident in stepping into the uncomfortable. I'm just, I'm going to touch on humility right quick, Kevin, then you can jump in there. My only 2 cents there is that, there are plenty of successful people who have mighty big egos. But the ones who make a bigger impact with their patients, with the community, are those who are able to let go of the egos and have that humility to listen, to be compassionate, to communicate. So that's what I have to say about that. Because I know we're running short. We've got like at least 1 or 2 more very quick slides to get to. I want to give Kevin a chance to chime in there.
Yeah, on the humility side, I think it's important to this is what I could talk about for a long time as well. But there are a lot of people who think that it's somehow cheapened or diminished if they're successful and they had help.
Mm-hmm.
And that's, I think, so far from the truth. And I think it takes the humility to recognize that just because you asked for help doesn't diminish or negate anything that you accomplish.
Right.
You can still celebrate those things. You can still be excited about the fact that, you know, you graduated from PT school or you accomplished something. But it takes somebody who's truly humble to say, like, yes, this is me standing on the stage, but I have an army of supporters behind me that got me to this point. And like David and I still surround ourselves, well, not I say that, like we will always surround ourselves with people who are smarter than us, who are further along in life than us. Having a mentor, having a guide, having somebody to support you, encourage you, build you up, that it looks like a lot of different things to people, but really it takes the humility to know you're not going to be able to do this entirely on your own, and it doesn't negate it that you had to ask for help and you have people who are supporting you along the way.
Yep. That feeds right, Kevin. Beautiful. It just feeds right into this. That you can nowadays there's AI to do this. You can AI your notes. You can AI your content for social media, but you cannot AI your business. And Kevin was speaking to that directly. Of it's important to surround yourself, having the humility to ask for help, having the humility to surround yourself with people smarter than you to help you to move along. And that's part of what we do with people. I'm going to go back to one slide right quick. Two important things. Just remember, build relationships and develop communication skills. You're never going to lose with those two things. Those are two tried and true methods that will always endure. But AI can't AI your notes or your content, but you can AI your business, or you cannot AI your business. And we actually have ways that we can help you with that. Kev, you want to speak about our Launchpad right quick?
Yeah, so I think Launchpad would be kind of the next place that we would help people. Is if you're I saw that Netherine has interest in being she's a new entrepreneur. If there are other people who are interested in, like, what would it look like? What would it look like for me to get started as a practice owner? Is it for me? Can I do that? Like, first and foremost, like, we would love to get on a call with you. We offer free 30-minute growth strategy sessions. I mean, honestly, you can work with us or not. We don't really care. We just want to support other healthcare professionals. So please take advantage of that. Our email addresses are David or Kevin at uncagedclinician.com. So please reach out to us. We'd love to chat. And then the other thing is Jenny was so kind to allow us to give you guys a special for our Launchpad program. It's a 10-month accelerator program that helps you get through 10-week accelerator program, not month, whatever. I don't know what I just said. 10-week accelerator program that helps you build your practice from the ground up. There's a ton of extra add-on bonuses, but we're giving $200 off, so it brings it down to $800. So relatively cost effective to get started with the practice. We would love to support you, and this is particularly for those people who are like, yeah, I know that this is what I want to do. I have the conviction that I know that this is what I want to do, but I know that I need somebody else walking alongside of us. And Uncaged Clinician has helped over 1,000 practices at this point, in a variety of different ways. And so we would love to be able to support everybody who is interested in taking that next step.
Yep, absolutely. And this information right here is going to be in the follow-up information that Jenny has to send to everyone. But if you want to screenshot this, whatever you can. But this will be good through next Sunday. But if you're interested, we'd love to help you. And we just are thankful and grateful to Jenny for allowing us to mention this offer. So.
Yes,
Yeah, thank
you are
for-
welcome. Yes, my pleasure. Because when I'm thinking, I think the best thing they need to know is what is a Launchpad itself, you know? Is it like a community? Is it like a workshop? Is it like an app? Because the name itself, like, it's a launch,
Yeah.
you know? So a brief intro about that, Coach.
Yeah, so it's 10 weeks of both self-guided and coach-guided information. So you have an accountability coach that helps walk you through each individual step. You have access to myself and David along that as well. And then we give you it's called the CRM. It's a computer software. We give you it for a full year as you get started. So that alone, it's normally like $550 or $600 a month. We give that to you for free by joining. So that alone is worth the cost of admission. And then you are also included with different cohorts along the way of people who are also starting a practice. So it's not just one like self-guided video that you have to go through. It's us walking through. There's a ton of personal development. They're effectively journal prompts, but like really self-reflection to understand what it is that you're trying to accomplish, all wrapped in. So self-guided information, accountability coaching, software to build your practice on, and the cohort of community to build with. So we'd love, again, if you have any questions, feel free to reach out to myself or David with emails, and we'd be happy to get on a call in the next week or so and talk about what that would look like for you.
Wonderful. It's like Coach Kevin and Coach David will give you a clarity call, 30 minutes. Just is this for you? And then whatever question, at least you have the idea, especially for our new entrepreneurs and looking forward to learn more about, is it for me? So the first question, definitely they will ask you, what is your why? All right, we have those two whys there already. So you need to get ready for that answers. And then, of course, so the Launchpad is like a community, a cohort, a hybrid, because you can go into call them, ask them, and you have the community with them as well. So thank you so much. This is
Thank you.
really an eye-opening
Thank you, Jenny.
because you are welcome. So see the professionalism there, guys. Coach David still recuperating, but he's still with us right now. And thank you so much for your presence and sharing your knowledge with us.
It
So
was an
guys,
honor.
if you have, just kindly put on the chat your email, but definitely we will send them some of the other social media information, Coach, okay? All right.
Absolutely.
Thank you.
We appreciate you. So
Thank
Coach,
you.
thank you there. All right, my pleasure. And we have this wonderful, of course, we would like to thank both of you. So certificate of appreciation for Coach Kevin DeGroot for sharing his knowledge and expertise as keynote speaker of the Geriatric Rehab Summit 2024. Today, August 17, given this here in Delaware. All right. And we have, of course, for Coach David for sharing his knowledge and expertise. So we appreciate you for being our speakers for the Geriatric Rehab Summit 2024, 5th annual event. Amazing. All right. Thank you so much, guys. Thank you, coaches. Guys, if you have any questions, just definitely put on the chat, okay? All right. For our last speaker for, of course, it's morning already globally. We have Australia yesterday and close enough for the Philippines time, but here is already afternoon. But we have Dr. Jacqueline Dominguez going to discuss more about multimodal approach to providing excellent care in the management of neurological diseases in older adults. They're very busy right now. They're not in Philippines. They're, I believe, in Indonesia even. And so she's not really sure if she can make it live, but she is here. But she has recorded some videos for us to discuss. But if you have any questions, she will be here for us, all right? So who is Dr. Dominguez? Dr. Dominguez researches are in the area of neurodegenerative diseases, particularly dementia and its related diseases. She is the principal investigator of the Marikina Memory and Aging Project, a 10-year longitudinal cohort study on brain health and aging among community-based Filipino elderly. As an anthropologist, her research interest on the cultural underpinnings dementia led to the adaptation and validation of dementia assessment tools for local use, and the eventual development of non-pharmacologic interventions like dance in DAC. Dr. Dominguez is actively engaged as the primary investigator in phase 3 clinical trials in adult for neurologic conditions like dementia, epilepsy, stroke, neuropathy, other neurodegenerative illnesses, and COVID. Her team participates in collaborative research such as COSMIC. It is a cohort studies of memory in an international consortium, Davos Alzheimer Cooperative, Dementia Platform Australia, Southeast Asia, Consortium of the FTD Prevention Initiative, and Worldwide Fingers and Neuro-COVID. And she will going to talk more about it here in the multimodal approach. And she is the chief in the St. Luke's and also the president in the International Dementia in Asia. So without further ado, Jill also will help us to talk more and help and assist Dr. Jackie, okay? Thank you. All right, let me remove the pin. All right, let me see here. Right, guys. So, Jill, if you're here, just check and then I will remove the pin for for coach. See. All right. Okay. So you're the co-host, Jill, so you can present and show the Zoom anytime.
Yeah, hold on. I'm trying to share the
Thank
recording.
you. Yes, yes. And then I'm just removing some of the pin. Thank you. All right, so it's here right now, but there's no voice yet, okay? Thank you.
Sorry, no audio?
No audio yet.
All right, sorry. Sorry for that.
Really often chronic. We all know that. Dr. Jacqueline Dominguez. Dr. Jacqueline Dominguez. Disorders as well pose one of the biggest burden of care to families and society at large. And care is not only costly, but really often chronic. We all know that. So we in the healthcare profession continue to seek within our armamentarium of remedies to find what works for our patients. Drug development is rapid, facilitated, of course, by biomarkers and neuroimaging, and so are non-pharmacologic interventions. So the outline of my talk today would be just simply three. I would like to tell you and share with you the rationale for multimodal approach in neurologic conditions, particularly in older adults. Second, the multimodal interventions used in diseases common in aging. We'll have some examples of them. And of course, I'd like to introduce to you dance as a multimodal approach, particularly a dance we now call INDAC, or which stands for Improving Neurocognition Through Dance and Kinesthetics. So the brain is complex, as we all know. It has different lobes with different functions, Of course, the frontal lobe is for decision making, executive function. The parietal lobe is for spatial orientation, and also it processes all sensory inputs to the brain, literally. Temporal lobe is for memory, for auditory information and emotion, and the occipital lobe is primarily grossly for visual. Of course, the cerebellum is for balance. And within these lobes, we know that there are neurons or subgroups of neurons, as you see here, that have very specific connections with very specific role, distinct neurotransmitters, as you see here, with distinct receptors. And neurons have also support cells called glial cells, and that they are supplied by blood with these micro vessels. So it is in this complexity that I'm showing you that the brain's anatomy, histology, neurochemistry, neurophysiology makes it sort of vulnerable to injury or disease. While aging is not a disease in itself, the brain undergoes changes that puts it at a disadvantage somehow. In aging, there is atrophy, where certain parts of the brain that are important to learning and other complex mental activities a little bit lose brain mass or cortical mass. There is synaptic slowing, so slowing in the communication between neurons in the synapse. The neurons now or the synapse become less effective, the blood flow decreases, and inflammation increases in response to injury or disease. So all these changes sort of are seen in aging and are sometimes natural, but to a certain extent becomes abnormal, of course, in disease. So in terms of pathology, there are those that are commonly seen in aging. So for example, in this cohort of 100, say 1,017 brains that have been autopsied, 94 of these brains have at least one pathology. And the most common pathology is still relevant to Alzheimer's disease, 65%. But more than that, there are also other pathologies like chronic, macro, and micro infarcts. About a third of these brains have them. Moderate to severe amyloid angiopathy, again, about a third of these brains have them. There is also moderate to severe atherosclerosis, hardening of the arteries. There is arteriosclerosis. There is hippocampal sclerosis or thickening of the hippocampus, and we know that the hippocampus is the one that is most involved in diseases of cognition like Alzheimer's disease.
Thank you, Jill. So at least it will be bigger.
Hold on, some adjustments.
Thank you.
So AD was the most frequent, Alzheimer's disease was the most frequent pathology, but this rarely occurred in isolation. So it always came with combination. And these combinations can be heterogeneous. Some came in pairs, two or more, two pathologies, some came 3 or more, 4 or more in decreasing frequency. But what the pathology report would like us to remember is that there could be as many combinations as possible, like 230 different combinations were observed. So Alzheimer's disease came with some vascular pathology, and that is what we commonly see actually in the clinics. So common pathologies will lead to clinical syndromes. Clinical syndromes, I would say, because these are a combination of multiple symptoms, multiple signs and symptoms. So in this case, the clinical syndrome is dementia, in particular Alzheimer's disease or AD. And the combined pathologies that I'm referring to here are actually beta amyloid or amyloid beta and tau. And if you look at this on the right-hand side of the figure, there is dementia. So by the time of the diagnosis of dementia, we know that according to these red and blue lines here, that these pathologies or amyloid and tau are deposited in the brain as early as 20 years before diagnosis. You also see here that there's a stage here below called MCI, which stands for mild cognitive impairment. It is a stage between cognitively normal state and dementia. So now MCI is a target of interventions to prevent conversion to dementia, or at least to maintain the MCI state for as long as we can. In terms of pathology, so the amyloid and tau would eventually cause changes in the brain or atrophy by neurodegeneration. You see the green line here. And then after that, we see memory symptoms, which already begins in the MCI stage. And of course, further down, the green one is the full-blown dementia syndrome. So that is the complexity and the chronicity of what happens to the brain in Alzheimer's disease. Pathologies can also be combined with pathologies of Parkinson's disease or PD. But PD has another protein pathology called alpha-synuclein, which is what you see here. The presence of alpha-synuclein and they are called the Lewy bodies, okay? And Lewy bodies or alpha-synuclein can combine with amyloid and tau, meaning to say that Parkinson's disease can combine with Alzheimer's disease. But what is common to both is, as complex diseases, they are multifactorial, a combination of genetic and environmental factors that initiate the process that leads to apoptosis or neuronal cell death and then neurodegeneration. So it is the complexity of the brain and the diseases that affect this that actually merit a complex approach for management, which is in a multimodal or multi-domain intervention, which is the second part of the talk. Multimodal interventions used in diseases, in neurologic diseases that happen in aging. Okay. What are multimodal interventions have been used to treat a variety of neurodegenerative disease, such as PD and AD, neuropsychiatric diseases like depression, psychosis, epilepsy, traumatic brain injuries, and stroke. And the multimodal intervention usually in the clinics from the physician's point of view would be a combination of pharmacologic and another pharmacologic intervention or multi-drug therapy. Mental health, where multi-drug therapy is common. Antidepressants, benzodiazepines, antipsychotics, in many types of combinations, whichever works for patients. Okay, so we think that in certain cases, of course not in all, a combination of two is better than one. But again, of course, we know that the principle of care of medicating people in the geriatric age group is to use the lowest possible dose and the lowest possible number of medications that would help. Okay, so we do not promote, wanton use of drugs in combination, actually. So the case of drug or multi-drug therapy is also again seen in dementia, where two anti-dementia drugs, which are donepezil and memantine, which work differently. They have different mechanisms of action. One works on the neurotransmitter, preserving the neurotransmitter, which is acetylcholinesterase inhibitor. This is donepezil. And an NMDA receptor antagonist, which is this one, combined together can provide better outcomes in cognition and neuropsychiatric symptoms and even activities of daily living. Okay, but of course, even if two drugs are better than one, there is lower acceptability over monotherapy because if you use more drugs, of course, you have more side effects expected. Okay, and the reason for that recommendation of combining these two drugs is actually a combination trial where you see that. So we are all familiar with the mini mental state exam. The higher the mini mental state exam, the better is the patient. So the direction of improvement is here. And we see that people who were given both the drugs, this one, active donepezil and active memantine, this one actually did better than those who got either one or who got the placebo. And this is the same thing that is seen in the activities of daily living. In the basic activities of daily living, the lower the score, the better is the patient. So the direction of improvement goes down. And we see again that people who were given both donepezil and memantine did better than those given the placebo or either of the medicine. And those medicines have been used and approved for the last maybe 25, 30 years. And recently, I'd like to introduce to you anti-amyloid therapies that have been recently been approved. The second or the third anti-amyloid therapy has been recently approved in the US this July. So in this model of the Alzheimer's disease pathophysiologic pathway, there are multiple areas of intervention that are possible because of this pathway. Okay. So first is the amyloid. Amyloid can be targeted in a way that we can reduce amyloid production or remove amyloid from the brain. And this is what these new drugs are doing. These recently approved drugs do that. They take away the amyloid from already deposited in the brain. So these are the monoclonal antibodies. Another one is to increase amyloid clearance from the brain so that amyloid does not accumulate in the brain. And we can do this. And by the way, we clear our brains of amyloid during sleep. Therefore, sleep is very important. It has been shown repeatedly that people who are sleep deprived accumulate amyloid in the brain. Therefore, sleep deprivation is actually a risk for cognitive impairment. The other approach is to have drugs that will decrease tau accumulation. And these are already being tested. Of course, in addition to that, many drugs are also being tested for their neuroprotective properties so that the neurons are spared from excessive inflammation and cell death. So this is an example or a model where combined therapies, drug, and another drug can really mitigate the pathology in the brain and hopefully improve patient outcomes. And in terms of neuroprotection, we know that there are many natural products that are being marketed as for neuroprotection, having properties of being antioxidative, anti-inflammatory, anti-beta amyloid aggregation. They even target the tau protein and also target neurotransmission. So most of these drugs, most of these products, natural products, are marketed as natural products or even processed products, and they claim that they can improve symptoms for patients with Alzheimer's disease. Another multimodal approach is combining pharmacologic intervention with non-pharmacologic interventions. So we now know, and another also is a combination of non-pharma and non-pharma. And that today we hear public and private sectors, allied healthcare professionals, traditional complementary medicine practitioners, including folk healers. We are all part of the myriad of actors in the non-pharmacologic intervention ecosystem. And as interest in non-pharmacological interventions really grow fast, so do questions about safety. Is it safe? For example, is acupuncture safe? Is this kind of intervention safe? Is it effective? Does it really help? Are they standardized? Is it ethical, to give them, or is it ethical for this practitioner to give that kind of intervention? And of course, there must be surveillance and monitoring of the outcomes of these interventions. So while there are many out there in the field, I think we should also be vigilant that at least those that are reasonable have undergone studies or research about safety, effectiveness, and standardization should be considered before adopting any of these interventions into practice. Okay. So these are examples of non-pharmacological interventions combined with technology to improve patient outcomes. For example, transmagnetic stimulation combined with psychotherapy, okay, which is called self-system therapy or SST. And the rationale is that the transmagnetic stimulation of the brain, particularly in the left prefrontal cortex, would make people more responsive to patients more responsive to what they find most rewarding. And therefore, it is in this synergy that people acquire behaviors, learn behaviors and skills for regulating mood. This kind of treatment has been used in depression, and pre-treatment and post-treatment neuroimaging data actually show that there probably is a good response to motivational cues that significantly increase activity, particularly in the left prefrontal cortex. So I think in this way, technology using TMS, which is non-pharmacological intervention, combined with psychotherapy that's provided, of course, by a therapist, shows some benefit for patients with depression. The other one also is integrating complementary and conventional care. This is used for chronic pain. In the complementary care here being referred to is mindfulness. And the rationale here again is that meditation increases activity in the posterior cingulate gyrus. So using EEG feedback, patients can learn to both increase their posterior cingulate cortex activity and enhance the effect of meditation. Therefore, this biofeedback reinforces the patients on the complementary intervention, encourages them to do more, to continue on treatment because it works. It's been used for the treatment of chronic pain, and also it reduces craving for people who would want to stop smoking. Okay. The other combination is pharmacologic and non-pharmacologic intervention. And I'd like to say now that levodopa therapy plus exercise is now a standard of care in Parkinson's disease. But again, it's not just any exercise. It has to be standardized, safe. This is from the American College of Sports Medicine, where almost each element of the exercise is detailed in a prescription. So for example, the frequency, the intensity, the type of whether it's resistance, it's flexibility, or balance exercise, it's all in the prescription. And of course, most of physiatrists, physiotherapists know this because it's standard of care. So it's standard of care because in Parkinson's, if you only give levodopa treatment without exercise, they would not do as good if you prescribe levodopa plus exercise together. Okay? In the same manner that if we give just exercise without levodopa therapy, it will not work as much. So it's standard of care to combine drug and non-drug therapy, which is exercise. There are other examples of multimodal interventions. Pharmacotherapy, pharmacotherapy using continuous EEG monitoring plus neurostimulation have been used to prevent seizures. Again, transcranial magnetic stimulation and cognitive stimulation plus psychosocial intervention are also good to alleviate depression and enhance cognitive performance. And pharmacotherapy and psychotherapy could prevent progression of symptoms in children with bipolar disorder. So these are examples, and there are many combinations you can find in literature. But again, the caveat is make sure that they have been researched, studied, at least for their safety, first their safety and their efficacy. And the third part of the lecture is actually my introduction of the dance as a multimodal approach in itself. The context of this is that in the aging population, I mean, there's a lot of people, I mean, the world is aging, world population is aging. And together with that, there's an increasing number of people with dementia. In fact, the World Health Organization estimates, together with the Alzheimer's Disease International, estimates that 1 in every 3 seconds a person is diagnosed with dementia. So that's the magnitude of the problem. And the way to go is really for prevention. So the FINGER study, which stands for the Finnish Geriatric Intervention Study to Prevent Cognitive Decline, Impairment and Disability. It's a 2-year multi-domain intervention study that includes diet, exercise, cognitive training, and vascular risk monitoring. It's the first randomized controlled trial to show that it is actually really possible to prevent cognitive decline using a multi-domain lifestyle intervention among older people who are at risk for dementia. Okay? So again, why multi-domain? Because dementia is a complex disease and it is associated with modifiable vascular and lifestyle risk factors. So they enrolled 1,200 at-risk individuals as defined by the CAIDE dementia risk score of more than 6. The CAIDE, by the way, the CAIDE risk score incorporates cardiovascular risks, of course, age, and different lifestyle risks that are thought to, increase the risk for developing dementia. So the participants were randomized into 2 groups, the control and the intervention group. The control group received regular advice with a nurse and with a physician, while the intervention group actually received regular health advice plus nutritional guidance, aerobic exercise, cognitive training and social activity, and management of vascular risk factors. So what were the interventions used in the FINGER study? Nutritional intervention, 3 individual sessions and 7 to 9 group sessions, advising them on their diet, recommending a diet from which they could gain 10 to 20% of daily energy from proteins and 25 to 35% of daily energy from fat. They were also recommended an intensive exercise, actually aerobic exercise, progressive muscle strength training 1 to 3 times per week, and 2 to 5 times per week of aerobic exercise, as well as exercises to improve postural balance. And this is actually based on the doctor's extra protocol. That's a standardized training protocol, exercise protocol that was used for the elderly. And then there's also cognitive training that involved 10 group sessions and 72 individual sessions of at least 10 to 15 minutes computer-based training that was delivered 3 times a week. And then there is a close consult with their physician and nurses to manage their vascular risk factors. So this is the way it was done, and the intervention lasted for 24 months, for 2 years. These are all the activities for that. And what they found out is that, and their outcomes were cognitive scores. So we see in this figure, those in red are those who received the intervention, and those in blue were the controls. They did not receive the intervention. And we see that the neuropsychological test battery in this figure, the executive function in this figure, the processing speed, and memory all were significantly better in those who underwent the intervention. So their conclusion is that multi-domain intervention could really improve or maintain cognitive function even in those people who are at risk for developing dementia. Okay. So the finger study has now cascaded to different countries, and now it's called Worldwide Fingers. It is a platform of global multi-domain dementia prevention trials to share our experiences and data and harmonize our methods. So there are almost 50 countries involved here as of late. And so because we have an intervention using dance, which is called the Phenomain, Filipino multi-component intervention to maintain cognitive performance in people at risk for dementia. But instead of exercise, we use dance. So, and the basis for that dance also came from a previous study. So the target of intervention for our protocol are people with MCI. You remember the figure earlier I was showing is the state between normal cognition and dementia is MCI, okay? With a clinical dementia rating of 0.5, and when we test them, they perform less than 1.5 standard deviation. They have normal activities of daily living. They are able to perform exactly what they do every day, but they are at increased risk for developing dementia. And as I said earlier, they're a good window of opportunity for intervention. So in our first study, we included Filipinos because this is a study done in Marikina in Metro Manila. People with MCI who have no pre-existing illness that could limit the physical activity. Of course, they need to be able to do the dance. Okay, so we were able to recruit from screen 317 persons and eventually randomize or assign 110 participants to join in DAC, which is the dance group, and 106 participants declined to join the dance group. And the groups were comparable in terms of age. They were not different from each other. The mean age, years of education, the sex, the clinical and vascular profile in terms of stroke history, of hypertension, dyslipidemia, diabetes, thyroid function, and vitamin B12 deficiency. They were comparable. So this is a good cohort. And so we also compared their cognitive cognitive capacities, cognitive tests at baseline, and we found that they were not any different. You're familiar, I hope, with the ADAS-COG. It's a scale from 0 to 70 that counts the number of errors. So the higher the score in the ADAS-COG, the worse is the person. And the allowed score, at least for elderly, is actually 10. Okay, so 11 is there's a little bit of symptoms, but not enough to have dementia. The MOCA-P score, Montreal Cognitive Assessment, the Filipino version, the Boston Naming Test, the Neuropsychiatric Inventory, Geriatric Depression Scale, Disability Assessment in Dementia, and IIDS. All these were measured at the beginning and at the end of the 12-month dance intervention. And this is what we found out, that for people who dance, we compare the mean difference between baseline, between baseline and between groups. And we saw that those who actually danced declined in their ADAS-COG score by 3. And for the controls, they declined only 0.9. And the mean difference is minus 2.3, and this is actually very significant. So not only did they improve in cognition, but also they improved in their geriatric depression scale score. So people who dance reported less symptoms of depression versus those who did not dance. This is at the end of the study, and the decline or the difference is statistically significant. So what we can see from here is that dance, which was administered for 48 weeks or 12 months, actually improved cognition and improved their depression scores. Okay, so dance by itself is a multi-component intervention. Without any combination, it's also multi-component because it incorporates cognitive stimulation, social stimulation, physical exercise, and integration of sensory motor skills. So in other words, it's providing what we call an enriched environment for older adults. The elderly needed to remember the dance steps. They need to imagine themselves. They need to sync with the music with their partner. They have to be coordinated. So it improved a lot because dance was a cognitively challenging task. So it required recall of the dance steps. It required improvisation. It required motor coordination, and all these were done in increasing complexity over the 12 months. So there are also studies that show that dance is actually better than aerobic exercise in promoting hippocampal plasticity, which is, as I said earlier, hippocampus is the one that subserves short-term memory. Okay, so it's adapting, it's adjusting. Okay. So the induct dance is composed of 8 ballroom dances: reggae, cha-cha, samba, merengue, bachata, swing, tango, and salsa. And each dance is organized into 6-week modules. It is delivered 2 times a day, of course, by a dance teacher. And that the program is that it's arranged in a way that it begins with simple modules. So these are non-partner dances to allow familiarization with one's own movement, especially for those who dance for the first time. And then later on, the dances become more complex because they dance with their partners, which require complex interaction. Okay, so each session or each dance session is 60 minutes, 5 minutes for warm up, 45 minutes for dance proper, and then 10 minutes cool down. Okay, and then in the dance program, the teacher actually shuffles the figures or the steps so that it can create different sequences to test the memory and cognitive ability of the participants. Okay. In the Phenomen, though, in addition to the dance, we administered not only the dance, but nutritional counseling and vascular risk management. So there are actually 3. And we actually did resting state fMRI, which actually have shown that it did improve intrinsic functional connectivity in the brain. Functional MRI also, we also did that, also DTI. And of course, we wanted to look at brain volumes if they have increased or if they have changed. So while we did not see changes or increase in brain volume, we saw increased or improved functional connectivity in the functional MRI. And the reason why we found improvement clinically in an MRI are positive, any of these. During dance, there is brain or neural activation. This can actually improve brain volume, brain activity, and even cerebral blood flow. It can also promote neuroplasticity, and it can also promote increase in brain-derived neurotrophic factor. And these are substances, natural substances in the brain that increases when the brain or the neurons want to repair itself, want to restore itself after an injury. Okay, so these are potential mechanisms why dance works. dancing works, and it has specific target areas, the prefrontal lobe, the temporal lobe, and even the hippocampus. So in summary, I would like to say that the brain is complex and diseases that affect it are complex and multifactorial, particularly in aging, and therefore it is reasonable to use multi-component approach to interventions. But let us be mindful of the safety, effectiveness, and standardization, even ethical practice of providing these non-pharmacological interventions. Dance, as we have seen, is a multi-component intervention in itself that improves cognition and depression symptoms in older adults at risk for dementia. These are people, older adults under the MCI stage. And I would say that multi-component care could improve patient outcomes and prevent diseases. And having said that, I think that whatever practice we do, we care for older people, uh, we should not, or we get out of our silos and reach out to each other so that we can provide better care for our patients. Thank you, and I'd like to part and say that this is the logo of INDAC, and the tagline really is Dance for Your Brain. So if you have time, please learn to dance because you are dancing for your brain. Thank you.
That's really nice. Thank you so much, Dr. Jackie. All right, so I will going to put you here. Guys, if you have any questions, definitely Dr. Jackie is live here from Indonesia. She's doing back-to-back training right now, and it's midnight right now in Indonesia as well, with Jill as one of their colleague. So if you have any questions, definitely you can put it on the chat. But Dr. Jill, do you want to just say hi or any closing remarks that you want to add on? Because you're here as well, no problem. Let me see here. And see, and you can, I believe, unmute. Are you? Let me check.
Yeah, I'll just give this opportunity to Dr. Jacqueline Mingus to speak about everything.
Let me see. Yes, all right. Dr. Jackie, nice to meet you and nice to see you again. So how's the weather in Malaysia? Oh, I cannot hear you.
Morning.
Yeah, I can hear you now. Go ahead again, Dr. Jackie.
Hi, good morning, and good morning to everyone who are here today in your forum. Yeah, you were asking about Malaysia. It's warm, much like the Philippines. The weather is nice. It's not been raining, so it's good.
Okay, thank you so much. I know the time is really rough, and that's really wonderful presentation. We always know the value of dance, and then at least I learned lots of things now with the different things like researches. I'm not familiar with finger, those things, the finish. At least I have something, I just know the value, and I know the induct from you. And now I'm learning more the deeper, like evidence-based back and research about that. And I like the pictures as well, how the effect on the prefrontal or frontal cortex. And I expect that with the evidence-based that once it improved the cognitive deficits, decreasing the cognitive deficits with the dance, I know that the GDS will also improve because of the the happy hormones will be there. So I
That's
expect
right.
that. Yes. So
That's
thank
right.
you.
That's
Yeah.
right. Yeah.
So do you have any closing remarks for us? Anything that you want to add for our attendees? Because this will be recorded and everybody who registered can learn more from you.
Yeah, I think the lesson really is to be open to each other. Sometimes different disciplines work in their own areas, not knowing what the others are doing. But we see now that anything we do together will really benefit patients, and patients will really it improves trusts to know that for patients to know that we are talking to each other and we are coordinating. towards their best interest. So as parting words, I think the more the better, and happier if we work as teams rather than working singly in our practices.
Yes, and
So,
congratulations. I know that you're doing the Institute of Dementia Care Asia, you know,
yeah.
that's you're part of that. Jill, did you say something? Do you want to also share something, Jill? I think I heard you.
Yeah,
Okay, give me a
yeah,
second.
it's okay. All right. Well, thank you so much for letting us here, and also we're doing a lot of things together with Dr. Jackie, all for the love for dementia.
Yes.
Uh, and that's
You
all
don't
I
have
can say.
camera. You don't have camera, Jill.
Oh, yeah.
Yeah,
It's really dark in here. I'm really sorry. So I couldn't put it on.
yeah.
Um,
So Jill
yeah.
is
All right.
also one of the main, if you talk about dementia in Philippines, definitely we have the dementia care practitioner, and he's the one who made those books, co-authored by Dr. Jackie, and they did all those dementia care practitioner from Asia, definitely. So that's okay, Jill, we cannot see you here. But if you have any future projects that you want to share, definitely let us know. And you can share it as well. I can share it with them on the, what do you call this, on our upcoming handouts that we're about to give. And that's very, very informative handouts that you have, Dr. Jill. So that will be shared as well. All right. Thank you so much, guys. And then
Okay,
we
thank you.
appreciate you. Maybe you can sleep again. It's still too early. So I would love to say thank you, Dr.
Thank you.
Jill. Dr.
Yeah.
Jackie, I mixed your names already. And I would
All
like
right.
to give this certificate of appreciation. So I want to present this certificate of appreciation to Dr. Jacqueline Dominguez, Doctor of Medicine, for sharing her knowledge and expertise as the speaker for the Geriatric Rehab Summit 2024, August 17, and this certificate was given today, August 17, 2024, in Delaware, USA. All right. Thank you so much, Dr. Jackie. We will go in.
Thank you.
Please just kindly put your email on the chat, and then, but we will put it as well on the handouts and giveaways information for them too. All right, guys, that ends our day 2 for the Geriatric Rehab Summit. And thank you so much for joining us. And we would love to share as well and thank our sponsors. Talking about dementia, we have Marbles Brain Body Fitness Gym. It is one of a kind brain first fitness franchise gym. So that focus more on the dementia or brain itself, and that leverages innovative dual tasking technology to deliver customized programming in a fun, supported environment. It reduced Alzheimer's prevalence with evidence-based exercises and technologies accessible nationwide. So this is very different than other wellness program that you have. There's no treadmill, there's no bike. It's all about, like, there will be innovative smart fit that you will just move. So we will incorporate dance too as well, but more on dual tasking, which is good, amazing for the brain. We have Dr. Cody Sipe and Dr. Mike Studer as their office chief officers and mentors as well. And Hello Note, thank you so much. There are some of the sponsors that we have. If you want to learn more about, if you want to have a medical, Medicare B or wellness on call, like this is a good EMR base that you can do, house calls that you want to do, outpatient. So Steven Steven Gluck is the best person to connect, and we will also put his information there. HelloNote is a web-based therapy practice management software. These are all for PT, OT, and even speech for patient documents, and also only practice management solution that helps an AI that helps to enhance your workflow efficiency and patient care. So we have a wonderful HelloNote video a while ago as well. And AgeWiser is the innovative platform that I'm sharing with you a while ago. It has an AI named Jen. So this is not only a typical app. You have a social media here where you can see socialization with your family. It asked me when I install it, it asked me who is my best or trusted person, because once you have this app, it will connect you to your best person or trusted person or family members once you have an incident of fall. And then there's also collaboration with your primary care. There will be going to ask you deeper information about your health, mentally, physically, and it will tell you that you are at high risk of fall. So this is more on prevention. So for physical therapy part, there is like time up and go, dynamic gait index, things and activities that it shows you what other exercises. So check it out, guys. So at least you can share it with your patients. I'm using it on the memory part. There's some nice games, which is good for cognitive. I don't know how to play chess, but there's a chess part there. So that's good. I'm very good in word factory thing. So they have a something like that there. So that's good for mental also practice, right? Mental gain. All right. Thank you so much, guys. And that concludes our event for tonight. And this is, again, all our sponsors. We appreciate you guys because of our sponsors were able to make this very affordable here for all our clinicians with 11 CEUs in 30 plus participating states. And also we're able to sponsor lots of attendees, beneficiaries for free. We have students as well that benefit here. I would like to thank also Doc J, and then he has lots of students that benefits here as well. He's based in Batangas. And also Arnold Delusong, shout out to you. He's the president of Philippine Go, and he also among Rodriguez Medical Center. So he is able to share this event to our colleagues, physical therapists back home in Philippines. Thank you to Activator Paul. We have Dr. Juliet. Maradine Lee, we have a low intensity vibration from Dr. Frank. AgeWiser, I salute you. Swati Balanthropy from California. She innovated this AgeWiser. Hello note from Steve. Optimist Spirit from Carlos. And then LSVT Big Dr. Laura Gusay talk about that. And Pop Doc Newman. Ludofit, straight from Canada. We have Mark Evan, and we enjoyed a lot there. Future Foundation, guys, we have a Facebook, Future Foundation. If you want to learn more, you want to share what projects we're doing. We appreciate you. We have skill sharing. So once we visit the Board of Trustee, visit the Philippines, we do short webinars. So if ever I will go visit Philippines, I would love to share that too. So definitely I connect with you. If you have any questions, so definitely connect with me, guys. I will going to send you all my, what do you call that? My information, and I'm going to present all these things again. So let me remove the pin for Dr. Jackie, and we will going to check everything. Guys, if you have any question, just put it on the chat while I'm removing this as well. All right, give me a second. I can't easily remove the pin here, so you can see me fully. All right, here. Okay, all right. So let me see my self. All right, okay. All right, guys. So thank you. So if you have any question, let me see here under the chat, because I it's always make it so big. All right. Okay. You are welcome, Christine. Her name is unique. I think she's Christian or Christine. All right, guys. Would like to thank you personally for coming. And it's me again, Dr. Jenny Yusuf, physical therapist and doctor of physical therapy. If you're not familiar with me, I am based in Delaware. I'm a physical therapist and doctor of physical therapy, board certified specialist in geriatrics. I'm the current state advocate for geriatrics here in Delaware under APTA, and I'm the previous vice chair of the Global Health Aging Interest Group. It is a special interest group in APTA. So if you have any concerns in the future, if you have a specific topics you want to learn more or webinars that you want to present, let me know and I will look for the best speaker that I can interview, or we will do webinars together, okay? So bye for now, guys. I will send you an email where all the handout will be there. And of course, some of the PowerPoints, hands out, and the recording of this 2 days event. So share it with your colleagues. They can still avail the recording. And then part of proceeds goes to Future Foundation. And thank you so much. And God bless you all. All right.